Kumar on the stage for the Enlightened Council. And Dr. Rajesh sir is here. Thank you, sir, for coming. Dr. Vishal sir will be joining very soon. So I would like to invite the first speaker, Dr. Anshuman, who will be speaking on Type 1 ROP in Bihar. Anshuman? Okay, since Anshuman is not here, he will be joining us very soon. Dr. Surbhi can start with her presentation. Dr. Surbhi ka laga.
Hello.
I would request the next speaker to be ready with their presentation because we are tight with the time. You can connect directly. The time allotted is 6 minutes, so it would be good if you finish in 6 minutes. Anshuman, you can present. Straight. Anshuman, I would like to invite Dr. Anshuman. He will be presenting Type 1 ROP in Bihar. The time allotted is 6 minutes. I'd request to stick with the time.
So can we start? A very good morning. My topic is current scenario and management of Type 1 ROP, a tertiary care perspective. Now, I have no financial interests. Now, India and preterm birth, our country accounts for over 20% of the preterm births worldwide, which was just over 3 million preterm births in the year 2020. Bihar is just a reflection of what is happening all over India. Now ROP as a problem statement, at least 5,000 preterm infants will require treatment for ROP every single year. All these eligible preterm infants admitted to special NICUs require screening. 15% of these babies can develop Type 1 ROP, and they might even require urgent laser treatment by an ophthalmologist. Now we conducted a knowledge, aptitude and practice study among pediatricians regarding ROP. And these were the responses which we got. All of them were using gestational age only as the screening criteria, and most of them were getting the screening done at around 30 days of life after 8 weeks. Otherwise underwent laser photocoagulation at mean of around 6 weeks. And a very encouraging sign for us was that none of the eyes progressed from stage 3 to 4 or 5 ROP after being treated. Now, to summarize, I have 4 points. The first one is that there are increasing trends of aggressive ROP, and there are extremely worrying trends of stage 4 and 5 BROP. And we can see that if we are treating retinopathy of prematurity in the earlier stages, that is stage 3, then the chance of this disease progressing to 4 and 5 is very, very less. And the most important point is that there is a dire need of trained ophthalmologists, preferably young people, who can go to screen the babies in special NICUs. Thank you.
Presented.
I
Very
guess
nicely presented, Dr. Anshuman. Just I want to know, apart from prematurity and low birth weight, what are the other risk factors which increase the incidence of ROP?
So most important one is oxygen supplementation, which is very, very common in our country, that preterm babies are often due to the lungs are not matured, so they are put in special NICUs and PICUs with unregulated oxygen at 100% saturation. That is the main risk factor, sir.
Okay, my question was, what are the other risk factors in baby which will cause early incidence of ROP? Like usually you want to screen the baby at 1 month or 28 days, but in what are the other risk factors which will provoke you to screen the baby earlier, say for example at 2 weeks or 3 weeks?
Sir, if the baby is born at less than 28 weeks, then we have to screen the baby at 2 to 3 weeks.
Okay. If there is history of multiple blood transfusion,
yes,
distress syndrome, intraventricular hemorrhage, blood transfusion, so these are all other septicemia, neonatal jaundice. Okay, okay, thank you so much.
So why did they receive anti-VEGF?
Because basically, sir, the purpose of anti-VEGF is to reduce the neovascularization. So,
no, but it is stage 3, and which stage 3? Which zone?
Zone 1.
Zone 1.
Zone 1 we can give.
Yeah, zone 1.
As per BEAT ROP study, in zone 1, any stage of ROP, we have to give this.
Yeah, in zone 1. It was in zone 1.
Yes, in zone 1 we have given to 2 patients.
And was there any plus disease in those?
Yes, sir. Plus
There
disease
was
also.
plus.
Yes,
in
sir.
that. That's why it was given.
Yes, sir.
Okay, thank you.
So this was your thesis paper. This is your thesis paper.
No, sir, this is not my.
Okay.
Okay, very nice, Anshuman.
Very
Are
Thank
you, just one last question from you. Are you aware of ICROP 3 additions? What are the extra additions, new information added to ROP?
So classification has slightly changed, sir. Stage 5 AB3 has come, ABC has come. And
What are those?
Sir,
ABC?
as far as I remember, sir, stage 5A is when the disc is just marginally visible, and B is when the disc is not visible, and C, I'm sorry, sir, I can't recall.
Okay, great.
Yes, sir.
Actually, stage 5 is total retinal detachment,
Yes,
isn't
sir.
it? So stage 5A is total retinal detachment, but open funnel configuration. That is, disc is visible. If disc is not visible, means it is closed funnel RD. Stage 5B and stage 5C is closed funnel RD with anterior segment changes like cataract.
The next I would like to invite Dr. Surbhi Tiwari for a talk on RP and its syndromic association.
Good morning everyone. I am Dr. Surbhi Tiwari and today I will be presenting 2 rare but insightful cases of multisystemic retinal dystrophies, Usher syndrome and Bardet-Biedl syndrome, where the retina served as a window to hidden syndromic disorders. We obtained informed consent, institutional ethics clearance, and I have no financial conflicts of interest to declare. Some retinal dystrophies are not isolated conditions. They may signal systemic syndrome. Usher syndrome involves RP with congenital hearing loss. Bardet-Biedl is a pleiotropic celopathy that affects vision, kidneys, hormones, intellect, and more. Recognizing these early can guide life-saving multidisciplinary care. Our aim was to present 2 syndromic RP cases and emphasize how retinal evaluation can guide early systemic diagnosis, especially in young patients. A 17-year-old male presented with progressive night blindness and hearing loss since childhood. Fundus showed classic RP features. OCT revealed CME and preserved ellipsoid zone. ERG was extinguished and audiometry confirmed profound bilateral SNHL. This is the fundus photo showing classic triad of bony spicules, waxy disc pallor, and attenuated vessels. OCT macula. The right eye CME with loss of foveal contour is present. Left eye CME, RF, IRF, ERM with preservation of ellipsoid zone subfoveally present. Audiogram, we can see bilateral profound sensory neural hearing loss. Visual field assessment with HFA shows peripheral constriction. Case 2, a 20-year male presented with poor vision, renal failure and delayed milestone. Fundus showed RP-like changes. He had post-axial polydactyly. Systemic sign pointed to Bardet-Biedl syndrome. In color fundus photography, we can see waxy-paler disc, attenuation of retinal arterioles. Overall, typical RP picture was present. Fundus autofluorescence was done. We showed areas of hypoautofluorescence. OCT was limited. Due to unresponsiveness of patient, as patient was mentally retarded. Therefore, suboptimal fixation was there. We obtained the scan capturing the inferior macula. It demonstrated diffuse retinal thinning with structural disorganization, particularly affecting the photoreceptor layers, consistent with retinal dystrophy. Comparison, both are autosomal recessive celopathies with RP pictures. Usher present with early dual sensory loss. Bardet-Biedl is more systemic, affecting growth, intellect and kidneys. Diagnostic flowchart. Childhood, first we take history, childhood onset night blindness, then we go for ophthalmic evaluation, fundus, OCT, ERG, FAF, or, then we go for audiometric renal screening, and then we go for genetic counseling. These are my review of literature. Literature supports our approach. These reflections validate the need for early syndromic evaluation in RP. Ophthalmologists often make the first clinical contact, therefore Usher is underdiagnosed unless we ask about hearing. Bardet-Biedl may be missed unless we look beyond the retina to body habitus, IQ and kidneys. Take-home message, multidisciplinary care is vital. ENT, nephrology, endocrinology, rehab, genetic testing offers long-term clarity for families. These cases reinforce how the eye can lead us to systemic disease discovery. We should always think syndromic in early onset RP. We should ask about hearing, weight, family history and milestone. Timely recognition and referral can change lives. Let's be the specialists who don't just examine the eye but see the whole patient. Thank you.
Very nicely presented, Dr. Shurbi. Just I want to know what are the genetic testing which you want to do in a case of RP?
We should go for genes, gene genomic testing. We should go for genomic testing to know the genes involved, like in Usher, USH1, 2, and Biedl-Bartle, BBS 1 to 10 genes are present, so we should go for genomic imprinting.
Okay. And so far genetic counseling is concerned, what you will advise?
We should go for we should advise parents, we should know their family history, and pedigree charting should be done to know is it autosomal inheritance, or we should know try to know the pattern of the inheritance, then we can go for that.
Okay, excellent. Thank you so much.
As a resident, I would like to advise you one thing. Whenever you explain any fundus photo or OCT, it should be elaborate enough so that others can understand, and we get to know that you have a deeper understanding. Diagnosis is not the problem. Diagnosis is clear, but you were saying like IRF, ERF, so these words should not be used as a resident. For retina people, it's fine that we are using OCT, IRF, whatever. But as a resident, you should keep this in mind. Nicely presented. Now we'd like to move to the next speaker, Dr. Prachi Singh. She will be speaking on the leukemic retinopathy in AML, a case report.
Good morning, everybody. My name is Dr. Prachi Singh, JR1 RIO. My topic is spontaneous resolution of bilateral leukemic retinopathy in a pediatric acute myeloid leukemia patient, a case report. I have no financial interest, no conflict of interest, and consent is taken. Leukemic retinopathy is a retinal complication of leukemia common in acute forms caused by anemia, thrombocytopenia, and leukostasis of related retinal changes, Valsalva or trauma-induced hemorrhages, Valsalva retinopathy. Investigations, hemogram showed moderate anemia or thrombocytopenia, consistent with post-chemotherapy status, coagulation profile normal, no signs of leukemic CNS relapse, fundus photograph. These are the these are the fundus photograph at the first visit of the patient. It shows multiple hemorrhage, sub-ILM hemorrhage at bilateral fovea, raw spots at the posterior fold. Diagnosis is bilateral leukemic retinopathy secondary to AML under chemotherapy. Management plan, conservative approach with close monitoring, no ocular intervention or intravitreal therapy initiated. Patient educated on red flag symptoms. Regular follow-up scheduled every 2 weeks, but patient presented later. Clinical course and outcome. Over the course of 2 months, serial fundus evaluation showed gradual and complete resolution of hemorrhages. Final visual acuity is 6/6 in both eyes. Refraction at last visit is right eye plano. Left eye plus 0.50 cylindrical, minus 0.5 into 90 degrees, plus 0.5 spherical, minus 0.5 into 90 degrees cylindrical. No recurrence. Demonstration of the lesions on the fundus photograph to the patient can prevent unnecessary interventions and reduce patient anxiety. Take home message. Leukemic retinopathy should be on the radar for any leukemic patient with visual complaints. Not all alarming fundus appearance necessitate intervention. Clinical judgment and follow-up are essential. Visual recovery can be complete with systemic disease control alone. Thank you.
Very nicely presented case report, Dr. Prachi. Thank you so much. I don't have any question from you, but just a message. It is rightly said that eye is the gateway to the soul. Just I want to emphasize that many a times on routine fundus examination, you will just find retinal hemorrhage here and there, and this may be you may misdiagnose it as retinal vein occlusion of young, but thorough systemic examination is required because this retinopathy, leukemic retinopathy, just this hemorrhage may be the presenting feature of underlying systemic disease. So always evaluate the patient systemically. So you never know, you may diagnose this leukemia or underlying cancer. Thank you so much for the nice presentation.
Anything, Rajesh sir, Vishal sir? Anything you want to add? Okay. We move to the next presentation. Dr. Anjuri, she will be presenting Bubble to the Rescue.
Good morning, everyone. My topic of presentation is Bubble to the Rescue. I am Dr. Anjuri, JR1, RIO IGMS, and my mentor is Dr. Shivani ma'am. I have no financial declaration, no conflict of interest, and consent has been taken. So moving to the introduction, pneumatic retinopexy is a minimally invasive, non-incisional procedure for repairing retinal detachment. This outpatient procedure is considered a less invasive alternative to more complex retinal surgeries like stellar buckling and vitrectomy. My aim is to report a case of rhegmatogenous retinal detachment successfully treated with pneumatic retinopexy. So this is a case of 32-year-old male with complaints of diminution of vision in right eye since 1 month and with photopsia and floaters. Vision in the right eye was 6/18 and the fundus finding was subtotal retinal detachment involving superior quadrant. Left eye vision was 6/6 and the fundus was within the normal limit. This is a fundus photo showing a single horseshoe tear at 11 o'clock posteriorly near superior temporal arcade with localized superior detachment. There were no break elsewhere. So we planned a 2-stage procedure. In stage 1, we injected intravitreal injection of 0.5 ml sulfur hexachloride fluoride 100% under aseptic conditions with proper head positioning towards left. And then stage 2, laser photocoagulation applied the second day after the subretinal fluid has been decreased. This is a fundus photo post pneumatic retinopexy demonstrating intravitreal gas bubble tamponading the superior break. Reattachment was confirmed 1 week after follow-up, and the vision improved from 6/18 to 6/9 at 2 weeks. The fundus photo confirming reattachment with resolved subretinal fluid and laser break. So studies report primary success rate of 74 to 85% with better outcomes in the phakic eyes and superior retinal breaks. Pneumatic retinopexy offer faster recovery and fewer complications compared to scleral buckle or vitrectomy in suitable cases. This is a pivot study by Rajiv H. Muni comparing the outcomes of pneumatic retinopexy and vitrectomy in retinal detachment. This is a randomized controlled multi-center trial involving 176 patients with retinal detachment involving superior retinal breaks. The outcomes were compared, and the primary reattachment rate in the pneumatic retinopexy group were 80%, whereas 93% in the vitrectomy group. Final reattachment rate was similar in the both. The vision, best corrected vision was 20/40 in PR group and 20/50 in vitrectomy group. The contrast sensitivities were better in PR, and the cataract formation significantly less in the PR. So the conclusion of this study is PR showed better visual outcomes and better contrast sensitivity, especially in the phakic eyes. And it is a valid first-line treatment for selected cases of retinal detachment cases.
Okay, thank you so much.
Dr. Shalu Bhagat, is she here? Okay, she will be presenting on iridofungal coloboma.
Good morning, everyone. I am Dr. Shalu, and I am presenting on clinical presentation and consideration in management of iridofungal coloboma among population of Eastern India, a case series. There is no financial interest to disclose, no conflict of interest. Study cleared by Ethics Committee, AIIMS, Patna. Ocular coloboma are rare congenital disorder occurred due to defective closure of ectodermal optic vesicle fissure during embryogenesis. Affect various structures, that is iris, ciliary body, zonules, lens, retina, choroid, and optic nerve. Incidence ranges between 0.5 to 0.75 per lakh birth, can be sporadic or hereditary, and varied association include diminution of vision, nystagmus, microcornea, macroophthalmus, strabismus, cataract, and retinal detachment. Isolated or can be associated with syndromes, commonest being CHARGE syndrome. Furthermore, can be typical, complete or incomplete. Refractive error correction and amblyopia therapy had been the basic management. With advancement in vitreoretinal surgeries, the complications are being managed in better way, and we conducted this study as retrospective analysis of data of all iridofungal coloboma cases registered in retina clinic from June 24 to March 25. We had included all the 47 cases presented with iridofungal coloboma during the study period. Clinical examination and indirect ophthalmoscopy were performed. This were coloboma were classified according to Edelman classification. Fundus photographs were taken wherever possible, and OCT macula was done if necessary. Complications such as cataract, retinal detachment were managed accordingly. Patients were advised regular follow-up to monitor the prognosis. And all the data are collected and were entered in Microsoft Excel 2021. Categorical and qualitative data were expressed as mean and proportion respectively. Based on calculation, age of presentation was most commonly seen in less than 18 years, that is 60%, and followed by 18 to 35 years, that is 25%, and more than 35 years is 10%. Most commonly, coloboma was bilateral, and male was more commonly found. Presenting features were diminution of vision, screening, deviation of eyes, microcornea, other were flashes, distorted image, and syndromic association like golden hair syndrome, CHARGE syndrome, and TAR. These are the anterior segment images. Microcornea, we have total number of cases for microcornea were 15, nystagmus 15, and strabismus including esotropia, exotropia, cataract, and retinal detachment, macroophthalmus without microcornea, and retinocysis. Edelman classification, type 1 is above the disc, type 2 superior border of the disc, type 3 involving inferior to the disc, type 4 involving the disc, type 5 small island with normal retinal above or below it, and type 6 pigmentary changes over the in the periphery, and 7 peripheral location. These are the images of various type of colobomas. Most commonly we have seen that type 1 were the most common presentation in our study. Cataract surgery in iridofungal coloboma are associated with early cataract formation. Cataract surgery in eyes with coloboma is challenging and higher complication rate, and most common complications are due to zonular deficiency, poor dilation, hard nucleus, and microophthalmus. Postoperatively, retinal detachment and coloboma related maculopathy were seen. Choice of surgery depends on corneal diameter, phacodonosis, and capsular instability. Surgical consideration include making a corneoscleral tunnel, use of iris hook, capsular tension ring, Sionis ring, high molecular dispersive viscoelastic agents. Retinal detachment surgeries Incidence of retinal detachment ranges from 23 to 40%. It has been attributed to premature vitreous syneresis, inherent defect at the locus minoris resistentiae, and thin rudimentary retina with break involving the intercalary membrane. The challenges enlisted were difficulty in visualization, defection, and closure of break, laser photocoagulation sparing the edge of fovea. Higher chance of recurrence were noted in case where relaxing retinopectomy were done, lancectomy type 1 or 2 coloboma, and additional peripheral breaks. Role of laser barrage. Prophylactic laser barrage has conferred significant reduction against development of retinal detachment. They strengthen and reinforce the colobomatous margin. Weighing the complication and suboptimal visual outcome associated with RD surgeries, laser barrage are safer option. 3 rows of contiguous laser spots of 400 micrometer diameter applied using slit lamp delivery or laser indirect ophthalmoscope and foveal region are spared. Conclusion: iridofungal coloboma were seen in maximum number of cases. Diminution of vision were the most common presenting complaint. Bilateral presentation was more common. Presenting visual acuity was poor in coloboma involving macula, and colobomas are not involving macula without any complication were given refractive correction for the possible best character visual acuity. Associated cataract were
mostly it is bilateral condition. So many a times what happens, patient comes to you with closed funnel RD in one eye and in other eye suppose some 660 vision and iridofungal coloboma is there. So in that case definitely you need to do prophylactic barrage. So there are many interventions like prophylactic barrage. If there is retinal detachment, so you can do retinal detachment surgery. In cataractous lens, you may remove cataract also. So to rehabilitate the ocular morbidity is the key. And I want input from Dr. Shoni ma'am also. What are your experience, because you have dealt so many cases
basically
there in Patna.
Yeah. So this is probably the first publication which is going out from AIIMS Patna. The abstract has already been accepted in the Journal of Methodology. And Roshan was my senior resident up to January. And he has been instrumental in getting this data together. And this is, of course, an interim analysis. The sample size is 86. And we have, as far as the iridofungal colobomas, we are fortunate that in AIIMS people are coming back for follow-up. Now, follow-up is a very important thing because you cannot do a prophylactic barrage to every patient that comes in. Of course, the suspicious ones, we have done a lot of barrage lasers. I think about 10 cases we have done barrage laser, and some of them came to us with barrage in the previous, but fortunately we have not landed in the follow-up of cases that we have done till now. I'm talking about 2.5 years of follow-up now. None of our patients have turned up with a retinal detachment as yet, and they have been coming back for follow-up. That's another important thing to do. So as of now, I think there's one, again, I would like this VRSB to take an initiative to compile all the iridofungal colobomas that I feel that are occurring in a greater proportion in Bihar compared to the rest of the country. So maybe we VRSB people could take an initiative to compile our cases together and bring forth another larger publication later on, a collaborative publication on that. So let us see how we go about that. Words from the President.
Rightly said, we see a lot of coloboma patient. Sir, when I was in RP center, sir, we were straight away told that do laser barrage or op coloboma in 91, 96. What is your take on that, sir? Should we do laser barrage in all coloboma patient or iridochoroidal coloboma having particularly those are at risk?
There is a 40% risk of retinal detachment with the people with coloboma iris and after coloboma choroid. But then, as Sony told, if the patients are coming for regular follow-up, then maybe you don't have to do. But in case you are not, because follow-up is not very regular for this patient with the same physician all the time, they might consider doing a barrage to prevent risk of detachment. But having said 40% risk, there is 60% no risk also. There is right now no clinical parameter to say which will or will not develop into a retinal detachment. So I will be careful about the patient compliance.
And the regular follow is much more essential because they develop cataract also very early, and many times when they land up, the cataract is so hard that it becomes very difficult to manage. Sir.
You have been doing cataract.
I would like to add a medical legal point that it is important to mention whether you have noticed any LMR holes or any ICM detachment or ICM holes whenever you see a case of hydrofrontal coloboma. That will actually justify whether you have done a laser barrage or not.
So yeah, ICM detachment is very important to judge whether it is a suitable candidate or not.
Yeah, if you have the holes or a break somewhere, you have to do it anyway.
Yes, ICM detachment.
Even if the hole and breaks are not there, if the ICM is detached, there is a fluid, we need to laser it.
So one more thing, like if you have the coloboma which is involving the full, we see the full posterior pole is involved, you know, the disc, the macula. So in those cases, do you go and barrage all around or you just leave it? What do you say?
Actually, barraging in retinal choroidal coloboma is very tricky, you know. Because many that depend upon the extent of retinochoroidal coloboma, whether it is involving, whether it is in extent is inside the arcade or not. So if the portions which are outside arcade, definitely you need to laser. But if it is coming very near to fovea, say for example, if within 200 microns of the fovea, then you may leave that particular area, or maybe very light burn or 1 or 2 row you may add on.
But that is the point. Like even if the disc is involved, even if the disc is involved, would you laser that coloboma or just leave it? Because then we are going to damage, you know, even the nerve fiber layers.
No,
and sometimes these patients are one-eyed patients, and if we aggressively laser them, they may lose whatever vision.
If the extent of retinal detachment is if it is more, then definitely go for retinal detachment surgery. If it is,
I'm saying there's no detachment. It's not the question. There's no detachment. Prophylactic barrage, I'm asking.
Okay. Okay. So in that case, just you need to leave posterior pole, isn't it? Because yes, sir. Input from you.
No, what you are saying scientifically is all right, but you have also see the social status of the place where you are practicing.
Yes,
and mostly these kind of cases come in low socioeconomic strata patient. To them, to give you consultation for periodic checkup and this thing, which I have seen and I have followed in last 35 years of my practice. In these cases, I used to tell, you don't have to pay consultation, you come, I will see it. So this should be a social, or to the society, your commitment should be, if you are in private practice. For the government institution, you don't have any role to do. This is the one thing.
Thank you so much, sir, for your input.
For surgery in such patients, fortunately there is RBSK, and we are following. We have taken up whatever surgeries we've done it under the Rashtriya Bal Suraksha Yojana. So there is a way out for very poor patients coming to government institutions with congenital problems. Same for ROP, same for any congenital problem. So fortunately, and most of our patients were kids, and we have been able to do it.
₹50 at IJMS for that booklet, and unlimited consultations are allowed until that booklet is finished.
So we would move for the felicitation of the speakers. I would like to invite Dr. Jaiswal sir on the stage to facilitate. Dr. Anshuman. Arvind Jaiswal sir, please. Sir, felicitate करना है. Yes, sir. तो है ही सर. Dr. Surbhi. Dr. Prachi, very nicely presented. Dr. Anjuri. Dr. Shalu. काफी अच्छा. नहीं.
बिहार सोसाइटी में महिला सिस्टम काफी अच्छा है.
For the next session, I would like to hand over the mic to Dr. Deepak Agarwal, sir. फिर से आना होगा.
प्रोग्राम बुक है. जी जी जी. A very good morning to everyone, and we're moving on to the second session when anterior meets posterior, and definitely it's a very important session for anterior segment surgeons. So I would request the panelists for this session, Dr. Arvind Jaiswal sir, Dr. Pranav Ranjan sir, Dr. Ranjana ma'am, and Dr. Pooja Sinha ma'am to please come on the dais. And we'll begin with the first talk by Dr. Vishal Kishore on anti-VEGF, when not to give.
So good morning everyone, and this is a very extremely, I mean all four topics are extremely good. I wish there were more in the audience from the anterior segment as well to take home the crucial points from the speakers. Yeah, please Vishal.
So good morning everybody. So coming to my talk on anti-VEGF, when not to give. Now we can't treat our patient like a guinea pig, and in this era when we have so many scientific evidences, so any treatment, any protocol which we are following, we have to have a scientific basis for it. We can't go like hit and trial method for our treatment. So you have to have a clinical evidences for whatever you're doing. So I thank Dhanya Sukla sir for majority of the pictures and text in my presentation. So we all know that our eye sees what our mind knows. So where we have not to use this anti-VEGF, so first we have to know what are the clear-cut indication for these anti-VEGFs. So based on many trials and study, evidence-based indication has been formulated, like it is indicated for exudative age-related macular degeneration, then for myopic CNVM, then diabetic macular edema, then it is for retinal venous occlusion. These are the clear-cut indication based on various studies. Now it is used as a second line of treatment in case of ROP, especially in adjuvant to laser photocoagulation, but based on this BEAT ROP study, we can use it as primarily for zone 1 any stage, but limitation is the systemic pulmonary complication and late recurrences. So it is used as a second line of treatment in case of ROP. Now it is used as an adjuvant in case of Coats disease, in case of vasoproliferative tumors, then in case of retinal microaneurysm, and then in central serous chorioretinopathy. Now this central serous chorioretinopathy is again a debatable talk, because is there any need for anti-VEGF? Because nowadays any fluid in the macular area in the OCT, it has been subjected to anti-VEGF. We can't go rampantly like this. We have to have a clinical based evidence for these treatment. So various studies have been done, but 3 controlled study was there which indicate that we can give anti-VEGF for CSCR patient in case of chronic central serous chorioretinopathy and in case of CSCR with subfibrin, this subretinal fibrin. Now, it is used, means when it becomes useless, means we have to switch to other treatment. In case if it's not, means the disease is not responding even after 3 to 6 of injection, or in case of macular edema with very significant subretinal fluid, which on OCT shows steroid spaces, in that case you have to shift your treatment to intravitreal steroids. Now, if after repeated injection the visual acuity is worsening, you have to change injection or your treatment line. Now, when you have to stop your treatment, now if the CNVM becomes scarred or you note the choroidal atrophy, you have to stop your anti-VEGF treatment. Now, it has more futile indication are macular telangiectasia, then retinal or choroidal hemangioma. Then when anti-VEGF actually harms, now in case of vitreous hemorrhage in PDR patient or East disease with fibrovascular traction, it's better to avoid anti-VEGF injection because it will do more harm to the patient. Now you have to avoid injection in case of uncontrolled diabetes, in case of blepharitis or conjunctivitis for the chances of endophthalmitis. So you have to take a judicial decision while you are injecting an injection. Now still, like in this first picture, you can see there's macular edema, but here the fovea is spared. The vision is 6/6. So these patients are strictly no-no for anti-VEGF. You can give laser, means grid laser can be given or focal laser could be given, but anti-VEGF is strict no. And then the second case on OCT, you can see this taut vitreomacular traction. For this case also, this anti-VEGF is a strict no. So, and in these some clinical entity, you even don't have to think of anti-VEGF. Like in a case of AIN, CRO patient, then case of X-linked retinochisis or optic pit maculopathy. So to summarize, it is not used for fovea sparing macular edema. You have to switch your treatment after 3 to 4 injection, means if there's lack of response or if there's worsening of response after 1 or 2 injection. You don't have to use anti-VEGF in case of vitreal retinal traction, irrespective of whatever the etiology. Avoid anti-VEGF for any indication of fluid accumulation below macula. Just first look for the cause, diagnose the disease, and then decide judicially based on all the protocols and the trials. Avoid anti-VEGF on hit and trial basis. Now in this era of medical legal problems, misuse of anti-VEGF is rampant, so treatment should be evidence-based. Avoid anti-VEGF for any indication for the fluid in the macular edema. Just follow the clear-cut indication, clinical, means evidence-based indication as we have discussed earlier. Thank you.
Thank you, Dr. Vishal. So basically the message is very clear. First of all is the most important thing which you want to say is first the diagnosis.
Yeah, diagnosis.
So if you don't diagnose the condition, then the treatment will be difficult. So like you mentioned many a times, the common mistakes which sometimes people do is that parafoveal telangiectasia.
Yeah, correct.
So it appears like a small cyst, and people sometimes tend to think that it's a CME or something. So first of all, the diagnosis has to be clear. And another thing is do a complete indirect ophthalmoscopy, because sometimes you just see subretinal fluid and don't jump to a conclusion that it is CSCR. And sometimes it can be a retinal detachment also, which presents with a SRF which is extending to the fovea. So diagnose, and like you rightly said, for chronic CSCR, would you like to say any particular anti-VEGF which should be used, or any anti-VEGF people are using for that?
Any anti-VEGF you can use. Many times this bevacizumab which is off-label, that has a better efficacy in these patients.
I think for CSCR, since it's a deeper lesion, and if we want to use any anti-VEGF for that, I think for that brolucizumab or aflibercept would be a better choice than
smaller molecule.
Yeah, because it's a smaller molecule and you want the penetration to be deeper. So the choice of the anti-VEGF also has to be kept in mind when we are dealing with such condition. Any?
So I think the brolucizumab, I would agree that we are also seeing, especially in the chronic CSR, where you suspect CNVM or even if you don't suspect CNVM, yes, it does play a role, but the patient should be in, we need, because sometimes there can be idiosyncratic reactions. So we have seen patients coming with severe retinal vasculitis also. So it's important that the patient should be in touch with, like it should be close follow-up. Another indication which can be also thought of is especially the uveitis curriculum, where anti-VEGF is also now given in the tubercular granulomas. Manisha has a lot of study which has with follow-up. So these are the varying indications. Yeah. Otherwise, you have covered everything.
One of the dilemmas generally for the anterior segment surgeon comes that when you give a single injection in a diabetic patient, it dries it out completely and the visual rehabilitation is there. And when you understand that there's a 3 injection regimen or something like that, whether you want to continue with 3 injections or you stop at that, that is one dilemma that exists for us.
I feel, yesterday also we were discussing, Pooja and me, if one injection it responded means there could be some underlying vascular occlusion element, because wow response with anti-VEGF usually happens in vascular occlusions, not with diabetic macular edema. Diabetic macular edema, many times patient feels happy, vision improves, but OCT may not even change any changes if it is a truly diabetic macular edema.
Just one last point on your talk.
Pooja, go ahead.
Just one last point. In my experience in chronic AMD cases, when there's a lot of scarring, lot of disciform scarring, the traction of the fibrous element also causes some fluid cystic spaces. So we many times mistake it for active lesion and keep injecting anti-VEGF. So that should be also a point in consideration, that if the vision is poor and there is traction related fluid, we should not continue anti-VEGF.
Just one quick query basically. Does the anti-VEGF have anti-inflammatory effect as well?
Anti-VEGF, yes.
Anti-inflammatory.
It does.
It does. All of them.
Most of them.
Most of them. Okay, right.
Sometimes it may lead to some rip and all. Do you have any experience of injecting, or you would not inject?
No, sir. Large
exudative detachment of AMD.
Large exudative RD.
Long standing.
Long-standing exudative detachment.
RD.
You're saying exudative retinal detachment like leakage?
No. AMD cases which is neglected and there is a large collection of fluid. If you inject anti-VEGF in those cases, there is a chances of, I think, rip of the retinal.
So, yeah, that's what, if there's a large PED, there's a risk of RP rip is definitely there, and we have seen definitely, like ma'am was also saying regarding brolucizumab, where we have a wow effect and we give it for IPCV. Sometimes when the PED is very tall and big, we do expect a complication may happen.
Yeah, so it happens sometimes even whether you inject or even if you don't inject also there can be a rip happens, and these patients should be explained, because especially if the patient is having good vision, 6/9, and then there can be a chance of possibility, but literature says that even if there is going to rip happens, even then, because we are treating an active disease process, we have to inject.
Okay, thank you.
All with large PED, even with Avastin also, but mostly I have seen with the Eylea, the reason being that it decreases, there is sudden decrease or there is faster decrease in the fluid that causes actually tangential force on the this PED and causes the rip. So recently we have seen in 2 eyes of the same patient with Avastin also, and earlier I have seen more with the Eylea. So madam, what is your which drug causes more?
I think when it comes to whether these hemorrhagic PED and everything, especially when we are dealing with PCV process, definitely aflibercept or brolucizumab, these are the agents which work. Whereas when you come to the ranibizumab or bevacizumab, they usually does not work as effectively as we actually see with the aflibercept. So we do recommend, because as per the studies also, it's important that we should go for aflibercept or brolucizumab or Vabysmo, like that, because these are the drugs which are supposed to work on the PCV process.
Thank you. Thank you, Dr. Vish.
At the end, I just want to say the history and the economics of anti-VEGF. When it came, before that, when I was in medical college, I used to coax my colleague and other to give intravitreal in endophthalmitis cases, लेकिन कोई तैयार नहीं होता था. जब anti-VEGF आया और शुरू होने लगा और एंटीरियर सेगमेंट सर्जन ने उसको लगाना शुरू किया, तो विशाल ने जो टॉपिक आज पढ़ा है वो मेडिकल रेटिना के एक्सपर्ट लोग हर एक कॉन्फ्रेंस में पढ़ते हैं. कारण क्या? इसलिए कि एंटीरियर सेगमेंट सर्जन सबने एंटी-VEGF लगाना शुरू किया और पोलियो का जार में रख करके घूमते रहते थे. तो अब दिक्कत हो गई रेटिनल सर्जन एंड वीआर सर्जन की, यही हम लोग का कमाने वाला धंधा आया था. उसके पहले तो हम लोग कटोरा लेके घूमते रहते थे. तो लगा कि भाई कैसे इन लोगों को रोका जाए. तो तरह तरह का, मतलब कि हर एक कॉन्फ्रेंस में ये तरह का नहीं देना चाहिए, देने से क्या दिक्कत हो सकता है, ये सब शुरू हुआ शुरू के दौर में. अब तो वो दौर खत्म हो गया, हम उस दौर से गुजरे हैं, इसलिए हम बता रहे हैं आपको कि वो चीज़ था. प्लस एक पंजाब में एक ऐड निकला था कि आँख में कैंसर का बने एकदम सब चीज़ की दवा एंटी-VEGF, चाहे वो टेरेजियम हो चाहे कुछ हो, सबको लगा दिया था. ये चीज़ है. तो आप लोगों को सबको पता लग जाएगा क्या चीज़ में लगाना है क्या नहीं लगाना. तो हमारे विद्वान प्रवक्ताओं ने बोल चुका है. मैं यही कहना चाह रहा हूँ कि विशाल ने क्यों इस टॉपिक को चुना, उसका कारण ये था. ओके, थैंक यू.
Okay. Thank you, Dr. Vishal. And next, can I invite Dr. Vidhata Vidu to talk on anterior chamber reaction after cataract surgery. Is it infection or inflammation?
So, very good morning to all of you. It's a pleasure to be here and present this my favorite topic on endophthalmitis, and it's great honor to be presenting in front of Dr. T.P. Das sir, whose books endophthalmitis has helped me to gain the depth and insight of the endophthalmitis topic. So I will be discussing the post-operative AC reaction, how to proceed. And this was actually, the thing started in 2016 when I was a first year resident. I was posted in the emergency duty just after 6 months of joining, and I got a case which was operated to a few days back, and she had a DOB since last 1 day. She had a AC reaction of 1+ cells and flare 1+, and glow was there. So I thought it's just an inflammation or the recurrence. Probably she was not putting the drops properly. So I gave her some steroids and asked her to come after 2-3 days. 2 days later when she came, she had a frank end-off. I didn't look into much earlier, but what I missed was the end-off. And we had almost lost the eye, but somehow we referred to the higher center and her eye was saved. So this led me to develop my interest in the endophthalmitis. And so as a cataract surgeon, we all dream for great post-op results, but there are times when we don't get the desired results, and we have to land up with the situations like this. And we get a situation like hypopia and DM folds and the corneal infiltrates. So how do you appraise these cases? Whenever as a resident you get a case who has been operated recently, and they come with an anterior chamber reaction after few days or even 6 weeks or 5 weeks. So how do you proceed in this question? So first thing, these usually occur after 12-24 hours. We are more favored towards the TAS, and after 24 hours we more favor towards the infective cause. Culture always comes negative, and the clinical features that includes are the blurred vision, corneal edema, severe anterior chamber inflammation, hypopian, which are usually whitish, and there is a variable IP with more or less little pain, and posterior segment remains normal. The causes of TAS includes the irrigating solution. Viscoelastics are the very most common thing. Intracameral drugs, gloves, powder, endotoxin, detergents. The endophthalmitis as a definition you all have read. It is a clinical term used to describe the inflammatory response of the eye to ocular infection. So it is dreaded complication and we don't want to face this. Symptoms include a bacterial, if it's bacterial, presents within a week, and most frequent danger sign, the increased pain out of proportion and decreased vision. The pain, in case of endophthalmitis, pain will be more, the poor recovery and rapid decrease in vision, and there will be absent fundal glow, disproportionate AC reaction. You can see a pupillary membrane or a hypopion. So let's look at some of the cases. This was a post-op SICS, POD1, present with a small hypopion. There were some DM folds, and vitreous cavity was cleared. You can see the fundus photo. And we treated just with a hourly steroid, labeling it as a post-op inflammation, and it got cleared. The second case, this patient presented with presented with a hypopion, a small hypopion here. There was a pupillary membrane, AC was shallow, but the vitreous cavity was clear. On BA scan also there was some glow. So we treated with the oral steroids and the vision improved and the patient resolved after 3 days. The third case, the patient had a SICS with IOL implantation. On POD1 we saw the IOL was decentered. So IOL explantation with anterior vitrectomy was done. When the patient was sent for retina evaluation, we saw the patient did the BA scan and there was some homogeneous echoes in the vitreous cavity, which was not like what we see in endophthalmitis. The vitritis was more towards the posterior side and it was quite homogeneous. Probably that was because of the viscoelastic that has fallen down during the manipulation. Again, considering it as a task, we treated the case, prayed for 10 times Visolone, and the patient resolved after few days. The fourth case, now you can see this as a post-SICS, DOB since 1 day. This was on POD5. You can see there is a hypopion. The retrolentar glow is absent, and there you can see there are membranes, and the vitritis was present in the BS scan. We treated the patient with vitreous biopsy, PPV, and intravitreal vancomycin septa. After 1 month, patient did well and the vision improved. So this was the fifth case. This was a case operated in a camp. There was a cluster actually. Almost 7 to 10 end-op cases came all of a sudden, and the worst was given to me as a first-year resident. So that there was no hope. They felt that we won't be able to salvage the globe. So we took the patient for PPV, and there was a dense vitritis in the patient. Sorry, I won't have time to play the video. So I will be proceeding. So after PPV, the PP was quite difficult, and there were dense membranes. But we were able to complete the PPV, the base dissection and all. And after 6 days, the glow improved. The patient did well. After 1 month, vision was 660. So the important thing, whenever you get this case, is you differentiate how is it as a TAS or as an end-op. As I said, timing is important. The early presentation within 24 hours goes in favor of TAS. The delayed presentation 3 to 7 days or later, it's infectious in endophthalmitis. Lid swelling is more in case of endophthalmitis. Pain is more in endophthalmitis. Corneal edema is localized near the wound in endophthalmitis cases. And what you see in TAS is the more limbus to limbus, white to white edema. AC reaction, again, fibrin you can see in the TAS. Pupil is fixed and dilated. Irisotropy may occur in TAS. IOP is more increased in case of TAS actually. So we have to give AGM, IOP lowering agents. BS scan is important in these cases. The vitreous cavity is almost anechoic in cases of TAS, and culture comes negative. So mild, how do you manage? The mild cases you can just treat with topical steroids and cycloplegics. The severe cases you need to give oral steroids and cycloplegics, NSAID, AGM, IOP lowering agents. If you have diagnosed as a case of TAS, what you do is look at the vision. As per EBS protocol, it was PLPR. Now the things have changed. We go in for early vitrectomy. So if the vision is less than 618 or less, then we choose to do a vitrectomy in these kind of cases. And if the vision is better, we can inject and observe if the patient is improving, then we can keep on observation. And if vision decreases, then PPV. So Oro Lab has made the thing easy. They have provided a e-kit. So IBAB can be given using this e-kit. Vitrectomy in severe cases if the vision is less than 618. And finally the approach, so you have to examine the patient, check the vision, ask for days in surgery, and if the infection, decide whether it is infection or inflammation, glow is visible or not, USG, do a BA scan, look for the vitritis, and if suspecting TAS, start hourly steroids. If improvement, then continue. If not, then consider TAS, consider infection, and if considering infection, then go for a IVAB. Thank you.
Thank you, Dr. Vidhata. So, as we all know that, yes, endophthalmitis definitely is a nightmare for any anterior segment surgeon. And it is very important to differentiate and diagnose between TAS and endophthalmitis. So, you have already dealt with the management and everything, but it is also important that once we have diagnosed that it's a TAS or an infection, we should look into the root cause for that. We should not just, think that it may be the patient's fault that he may have exposed or done something. We have to look into our systems very carefully, even if we have a single case of TAS or a cluster of cases. Even a single case of TAS, we should look into all our systems, which means right from the cleaning of the instruments, where we know that even if the viscoelastic substance, if it is not cleaned properly, it will remain on the instrument, and just autoclaving it will cause the proteins to denature and the formation of resistant endotoxins, which will remain on the instrument despite sterilization. So these are the things which will lead to TAS in these cases. So we have to repeatedly tell our staff, we have to monitor them, we have to educate them regarding the sterilization. And if we are sterilizing in a B-class autoclave also, the water reservoir in that sometimes may not be changed frequently. And that water reservoir in the autoclave is a source for, resistant endotoxins of the bacteria. So all these things we have to actually monitor and check also. So I think that is very important.
And just one last comment. We have been taught, treat all cases of post-operative inflammation as endophthalmitis unless proved otherwise. So this is a very important take-home message for every one of us sitting here.
As far as this TAS is concerned, there are so many ways by which you can see that what were the causes, but there are certain things which are not there in your hand, like viscoelastic. In my practice, what I have found that the most of the time, whenever I have encountered TAS kind of thing, like in 2002, 2003, I had actually series of inflammation after cataract surgery. When I looked into it, I found that particular brand actually of viscoelastic was causing problem. And about 5 years back, I again suffered severest kind of TAS in my patient, where I lost 4 patients, 2 patients, all of them developed glaucoma, uncontrolled glaucoma with iris atrophy. 2 patients required corneal transplantation, 2 patients required trabeculectomy, but only 2 patients the eye could be survived. So that was the severest form of the TAS which I could see, and that again was the viscoelastic in that case. When I removed that, from my stock, everything became smooth.
Was that batch of viscoelastic cultured, or was it checked?
It was sent for culture, but nothing came out. But the company took back all the products, saying, "Sir, और भी दूसरी जगह भी थोड़ा मोड़ा आया है complaint."
I have one experience. I got a series of post-op cases having lid edema, everything resembling, mimicking endophthalmitis, but I was absolutely quiet. I was changing something like intracameral, I was changing topical drops and all, but nothing works. Then I changed the betadine and I got the issue resolved. So betadine may be sometimes, providine iodine may be sometimes mimicking the infection type of thing. That is very menacing to me in the case of series.
I would want your patient to disappear as an anterior segment surgeon. Very frequent follow-up is very essential. We are calling the patient almost every day or a day gap of 1 day, and seeing the progress and improvement or whatever that needs to be done is very much encouraging for the patient as well as retains the faith in you, because it is a catastrophe for an anterior segment surgeon.
Next, we'll move on to the next talk by Dr. Abhi.
Hey, रुको. ये मेरा लगाव इन ऑप्थेल्माइटिस से 1983 में हुआ, जब हमारे प्रोफेसर और हमारे गुरु डॉक्टर A.N. पांडे ने हमको थेसिस का सब्जेक्ट दिया इन ऑप्थेल्माइटिस के ऊपर। सुभाष जो बोल रहे थे उसी दौर की बात है, जब पटना में 4-5 आदमी के यहाँ ये हुआ था टास्क का। मेरे यहाँ डॉक्टर शरद, डॉक्टर रंजन अखौरी, डॉक्टर V.N. प्रसाद एंड रांची में डॉक्टर कश्यप, और सब लोग में एक ही पॉजिटिव था। आई डोंट वांट टू नेम द कंपनी, वही चीज़ था। ये बता दें। दूसरा चीज़ आपने अपने पेपर में लिखा था, अपने प्रेजेंटेशन में, कि पाउडर ग्लव्स, लेकिन अगर आप उसको, अमेरिकन एकेडमी का एक रिव्यू आर्टिकल है, आई थिंक लेट 2000 में ये पब्लिश हुआ था। टास्क नया 2004-5 में काफ़ी कॉमन हुआ था अमेरिका या सब जगह। उसमें है कि अगर आप पाउडर फ्री ग्लव्स भी आप जो है, उसमें जो मोल्ड में जो केमिकल यूज होता है उसको बनाने में, उसको वो भी एक पॉजिटिव फैक्टर है आपका टास्क का, इसलिए पाउडर कोई नहीं। दूसरा चीज़ कि वे बैक इन, इफ आई रिमेंबर करेक्टली, इन द अर्ली 2010 के आसपास में, उसी समय यूरोप में इंडोप्थेल्माइटिस विट्रेक्टोमी स्टडी या कुछ उस तरह का पब्लिश हुआ था, एंड मूरफील्ड हॉस्पिटल लंदन में कॉन्फ्रेंस था, उसमें लाइव सर्जरी हो रही थी और जितने भी सर्जन थे बिना ग्लव्स के थे। इसलिए ये टास्क में मेरा मानना है कि सब चीज पॉजिटिव फैक्टर है। आप आकाश के नीचे, आप एयर में जो भी चीज है, सब चीज उसका है, वो आपको पकड़ना है कि कैसे आप उसको। दूसरा सबसे चीज जो दीपक ने कहा, उसमें जो भी कैनुला या जो भी आप उसको नॉर्मल साइज, जो भी आपका रिंगर लैक्टेट जो भी, उससे फ्लश कर दीजिए, तब उसको ले जाइए। ये बहुत सिंपल है जो हम फॉलो करते थे अपने सर्जिकल प्रैक्टिस में। उसे जितना भी अंदर में टॉक्सिन, इंडोटॉक्सिन, डीनेचर, दिस थिंग, वो वॉश आउट हो जाएगा। थैंक यू।
Thank you. Next, Abhishek Anand will present on PCR management.
Tips for anterior segment surgeon.
Yeah, tips for anterior segment.
The theme is anterior meets posterior.
Yeah.
So so hello everyone. I am Dr. Abhishek Anand. I would be speaking on management of PCR, tips for anterior segment surgeons. So primarily this talk is focused on anterior segment surgeons. So with the disclaimer, PCR is a known complication and it can happen in best of the hands. And badly managed PCR should be best avoided. So one of the most important point is the early identification, which can be a game changer in PCR management. So how do you early recognize PCR? If you have a sudden deepening of the anterior chamber, there is a sudden transitory appearance of a clear red reflex. So the red reflex you are not seeing, and then there is an area in which you can see a red reflex which has suddenly appeared. Inability to rotate a previously mobile nucleus. That means that the vitreous is coming and has occluded the followability of the phaco probe. The loss of nucleus followability, or tipping of one pole of the nucleus. So you have to see whether both the poles are in the same plane, or it is tipping in, one pole is slightly tipping more than the other plane. And partial descent of the nucleus into the anterior vitreous. That is an obvious sign that there is a clear PCR. Now what is the goals? Now this is the identification of PCR. Now you have to focus at the goal. What is your goal when the PCR has already happened? You have to avoid posterior dislocation of the nucleus, nuclear fragments, epinucleus or cortical matter into the vitreous cavity. So if you are an anterior segment surgeon, this is the primary goal, but this should not be your guiding goal, that you should be doing it at any cost. Minimize, the most important is the minimization of the collateral damage. And what are the collateral damage that you can do while trying to achieve this is to damage the corneal endothelium. So corneal endothelium damage has to be minimized as much as possible. Prevent the enlargement of tear. Why it is important is because the more vitreous will prolapse. prevent damage to capsular axis. That is very important. Most of us, most of the time, you will be having a very good circular capsular axis. And this will be the base where you will be placing your secondary IOL. So if you damage in the process of retrieving the nuclear fragments, this might not be possible. Avoid traction to the peripheral retina, and this is most important. Most of the RDs that we'll see in our practice have some component of peripheral retina tear if post PCR. Removal of leftover cortex and then you have to remove the leftover cortex. You can't just place the nucleus and leave the leftover cortex, because this cortex material gets mixed with the vitreous and causes secondary inflammation. And most important is proper positioning and centration of the IOL, because if you don't, then you have patient who will have irregular sort of astigmatism, and the patient will not be able to achieve the desired BCVA that is. And how does this dose transit depends on what is the extent of the posterior capsular tear, what is the intactness of the hyaloid pus, whether it is already dislodged into the vitreous cavity, and overall, what are the availability of equipment and the surgeon, vitreous cutter, vitrectomy machine, do you have access to the posterior, and availability of alternative IOLs. Always keep an armamentarium of availability of alternative IOLs, and availability of VR surgeon and setup. So ours should be controlled, sudden removal instruments should be avoided. Anterior chamber should always be filled with viscoelastic while withdrawing the instruments, and the surgeon will try to understand it. So this is a case, we can see in the inferior part there is a small PCR that has happened. Look at the surgeon has filled the viscoelastic. So I'll just pause it before. So before withdrawing, the surgeon has filled it the viscoelastic. He is in the foot pedal 1, withdrew it, and now he has introduced the vitreous cutter just at the extent of the PCR. So at that point, they are trying to remove the prolapsed vitreous. And the second part is the infusion is already on. So this is how you do. You don't withdraw the instrument itself, because that will create a sudden hypotony, and the whole of the posterior vitreous will prolapse into the anterior chamber, and this prolapsed vitreous will further enlarge the tear, causing further complications. You should use dispersive viscoelastic to plug the posterior capsule. Nucleus material is moved into the anterior chamber with a spatula or emulsified and should be emulsified with salt bursts. Low water light, low settings. Attempts to retrieval or dislocated nucleus carry high risk of peripheral tears, so avoid fishing at whatever cost. Now, basic principles of vitrectomy and PCR management. Anterior vitrectomy should be performed so as to allow closure of the wound without vitreous incarceration. Secondary removal of dislocated nucleus through 3-port pars plana vitrectomy should always be employed. What are the principles? Use of the maximum possible cutting rate. So if your instrument has 1,000, then use 1,000. If you have 3,000, so maximum possible cutting rate. Vacuum should be around 200 to 300 mm of Hg. The vitrectomy tip should be inserted through the opening in the posterior capsule and placed a millimeter or 2 behind the posterior capsule. So you should identify the plane of the posterior capsule, and the vitrectomy tip should be slightly behind the plane of the posterior capsule. And the aspiration port should be directed upwards towards the cornea. So in this case, let's see, there are two scenarios. One is the posterior capsule. You are seeing that the vitrectomy port is slightly above the tear, and second is in which the vitrectomy port is slightly below the posterior capsule. So the ideal position is when it is slightly below, because then it will suck the posterior prolapsing vitreous towards the area in which it has to be. If you are slightly above, then it will keep pulling the vitreous into the anterior cavity, which you don't want. Now, let's understand with a practical scenario. This is a case being done by a resident, and then she notices that there is a sudden dislocation of the posterior, of the whole of the nucleus into the posterior part. Now, here we see the first mistake has been done. The instruments were withdrawn very fast. Now, how to manage our? Let's go. We had an already 3-piece IOL, and we are able to place the IOL into the sulcus because we had a very intact rhexis. So once we have placed the IOL, this is a very important step which I see is missing, is you suture the main port. Once you have sutured the main port, the whole of this has got an integrity. Now we can see that there is a lot of cortical matter. We place a 3-port port, and now we continue with it. We have, first of all, the most of the vitreous that is prolapsed into the anterior chamber is being removed. Once we have taken care of the vitreous that has been polarized into the anterior chamber by doing doing a continuous vitrectomy, sort of core vitrectomy, we proceed with removal of the cortex. Now, cortex can't be left behind because we are managing a posterior discoid nucleus. What is the advantage that we have is you can use the same vitrectomy cutter for aspirating the cortex. And once this cortex gets removed, you can also switch to the vitrectomy mode because you know that some amount of vitreous will always be get entangled in it. So you keep switching between the aspiration and the vitrectomy mode, and this gives you the best control without creating any peripheral traction or any break. So you aspirate, and then you have to assume that there must be some amount of vitreous which is clogging it, and then you continue with the cutting mode. We try to do an optic capture in this patient, but because there is a positive back pressure from the infusion port, sometimes it's a bit difficult, and it will come. Okay, the captured IOL will keep prolapsing from the anterior capsular rim. Now the next part is we have done a PVD, and then we do a phaco-frag and close the rim. So to conclude, identifying the most important step is the pre-op itself. You have to identify the presence of a predisposing factors and appropriate modification of the surgical plan. So you can't be surprised at the point. There are multiple clues which can give you a clue that this patient is predisposed for a PCR. Do not panic. Early recognition and treatment of a capsular tear and vitreous loss prevents serious complications and improves post-operative outcome. Take time to ponder what would be the best surgical strategy in an event of PCR. In case of doubts, discussing intraoperatively even with colleagues, mentor can have long-term implication. Take help of a retina colleague whenever required. Discuss PCR with your patient post-operatively because it has a lot of medico-legal significance, and explain the intraoperative and future management strategy. Thank you. Do what suits you the best. Thank you.
Thank you, Dr. Abhishek. And now we'll move on to the oration by Dr. T.P. Das, sir. So can I request Dr. Satyajit Sinha to please take over? Thank you.
A very good morning and congratulations to all the postgraduates who made wonderful presentations. Now we are at the most important session for today, which is the Professor Rajvardhan Azad oration. And to begin with, I would like to invite Professor Rajvardhan Azad to please come on the chair, please. Arshad ji. Dr. Arvind Jaiswal, sir. Dr. Subhash Prasad. Dr. Nagendra Prasad. Dr. Shivendra Sahai. This is the most important and the most coveted oration of our society, and all the office bearers need to be here. Dr. Shivendra Sahai, Dr. Pooja Sinha, Dr. Deepak Agarwal, please. Kahan hai Deepak? So it's an absolute honor and pleasure, the highest privilege that I could have had in this session, of introducing our speaker for today, Dr. Tara Prasad Das sir, who we are very, very grateful for having accepted this oration and accepting to deliver it today. Dr. Tara Prasad Das is the Vice Chairman Emeritus of L.V. Prasad Eye Institute. He is the mentor and the Chief Advisor of Shantilal Sangvi Eye Institute in Mumbai, which has just come up. It's a world-class facility. He has 19 research grants, 378 journal publications, 58 book chapters, and 13 books he has authored. Presently, he is the President-elect of the Asia Pacific Academy of Ophthalmology. He is the Counselor at Large for Asia Pacific VITREO Retinal Society. He is the member of the Advisory Board of the Asia Pacific Journal of Ophthalmology. He is the member of the APJ Kalam International Foundation, Board of Directors of Bhubaneswar City Knowledge and Innovation Cluster. I also understand that he also has a designation of, which is a parallel to the cabinet rank of Health Minister in the government of Orissa. So this is a very, very proud moment for us that he is with us, and he has, in his awards, he has 27 eponymous lectures. He has 50 awards from India, Government of Orissa, national societies like Asia Pacific, APO, APVRS, and from Bangladesh. Internationally, he has received awards from the American Academy of Ophthalmology and also the Association of Prevention of Blindness, the International Association. He has a doctorate of science from Raveshav University in India from 2011. Government of India civilian or highest civilian honor. He is already a recipient of Padma Shri, which he received in 2013. He is from the top 2% scientists of the world of Stanford University, and this has been happening continuously for the last 5 years from 2020. He is the top 100 influential ophthalmologist from the Asia Pacific region, according to the Asia Pacific Academy of Ophthalmology survey. We are very, very grateful to you, sir, for having accepted our invitation to present the Professor Rajvardhan Azad oration. And may I now kindly request you to please deliver the lecture, sir.
Thank you. Can I have my first slide here? Thank you, the BIHAR VITREO Society, and particularly Professor Azad and Satyajit, who spoke to me several months ago, and I gladly accepted it because coming to BIHAR should be everybody's privilege. First, University Nalanda, 3 important legends coming from this state, the national emblem coming from Ashok the Great, there is no other thing. Equally delighted that I'm speaking for my good friend, mentor, philosopher, Professor Rajvardhan Azad. Azad has been a wonderful clinician scientist, a great teacher to everybody in the world. He's an able administrator and now an important policymaker in the government of Bihar. To me, he's always been a friend and mentor. So allow me to call him when I address Professor Azad as just Raj. Raj has been associated with various organizations. Not only Organization for Medical Sciences, he rose from a beginning humble to become chief of the RP Center, but also has been the hem of affair of Foreign Ophthalmology Society at Asia Pacific Academy of Ophthalmology, VITREO Society of India, South Asian Academy of Ophthalmology, and now the government of Bihar. Raj has knowledge talk about the health. I know he doesn't smoke, doesn't drink, occasionally takes coffee and tea without sugar, and talks about health, both mental and physical health. But friends, how healthy are we actually? Global indices says that in years that we have lived last, let's say, 3 to 4 decades, the under 5 health burden has decreased significantly but not for the adults who are above 16 or 18. And the highest burden is increasing in the people who are in my age group 70 plus. Also, while there is non-communicable disease decrease significantly, communicable disease decreases significantly, non-communicable diseases are not. Example, diabetes, cancer, or hypertension. They published in Lancet Diabetes a couple of years ago. It says that known diabetes in the country 101 million, and that shows how fragmented distribution of our diabetes patients in the country. And also 136 million are non-diagnosed diabetes. I think together 237 millions of people. It was 2023, maybe today, Padmaja keeps on following those International Diabetic Federation notebook, and she might say that it might actually cross 140 or 240. And how to treat these patients? Either give injectable or oral anti-diabetic medications. We certainly advise them to have a healthy diet, have a regular exercise, and weight loss. Despite that, over a period of time, despite this knowledge and advocacy, and what we always talk about, the knowledge, attitude, and practice, diabetes is not decreasing in the world, anywhere in the world, not only in India. In fact, we are a little better off than the Middle East countries. Is there a missing link? And to my mind, and that will be my talk today, the missing link would be a gut dysbiosis. Years ago, there are two important cover page publications in 2010 and 12 in Nature and Economics about the gut microbiome. Many of us are not aware of it. Human cells are numerically less than the microbiome population in the body. And our gut microbiome genes are 10 times, 100 times higher than the other genes in the body. Somebody like Joshua Landerberg at the young age of 33 got Nobel Prize. Very unusual, usually don't get Nobel Prize so young. I know that insulin guy got Nobel Prize at the age of 36, but 33, but discovering and discussing about the microbiome. It refers to a collective genomes of microorganisms either in a particular place or environment or the body. Usually by birth we are incomplete. By age of 3 we are complete, have a complete body microbiome is formed, and this plays an important role in all chronic diseases that we have, or even thinking process for mind. Scientifically, there are 5-6 varieties of microbiome, but today, for the talk today, I will confine to only to bacteria. There are this important bacterial microbiome in the body. There are actually hundreds of them, but then important ones are Firmicutes, Bacteroides, Actinobacteria, Probacteria, Fusobacteria, and Bericoma microbiome. And the first 3 are more important than the latter 3. Also, we can divide them grossly from layman perspective. They are good bacteria, the good microbiome, bad microbiome, and some group are sitting on the fence depending on your body ability or the immune system. They jump from side to side. Example could be a E. coli. Generically speaking, the E. coli are bad bugs, but could be also be opportunistic and join from one side to other side. Gut retina axis, which affects your gut, affects your brain, your hypertension, your diabetes, obesity, inflammatory bowel disease, etc. is all done by the gut retina axis. We defined, we published many years ago in IOVS that how the different mechanism of enzymatic modulation, the gut dysbiosis ultimately leads to a diabetic retinopathy. In a subsequent slide later on, I will explain to you how actually it happens in pathobiology. This hypothesis, which we developed later on, that diabetes mellitus is associated with a particular changes of core gut microbiome that goes through the different diversity, different dysbiosis, ultimately healthy become diabetes, and diabetes develop diabetic retinopathy or diabetic kidney disease or diabetic heart disease. That brings you to the topic of my day, the gut microbiome in health and diabetic retinopathy. Before I talk to the topic, let us introduce two important words I will be frequently using in the presentation called alpha and beta diversity. Alpha diversity is within and beta diversity is without. Let's say that, supposing we talk about the Sony, what changes she has got in a gut microbiome on her own. Supposing say Sony and Satyajit, then how, even though they both are in S, how different that can be called beta diversity. These two terms are using very frequently, so good to explain that. We started our project in many years ago with a meta-taxonomic study with a grant from the Scientific Engineering Research Advisory Board of Government of India. We took patients from our region, Hyderabad, which is Telangana, and so you can't avoid Andhra Pradesh, Hyderabad and Telangana, Andhra Pradesh. And we have 3 publications after that. We worked on the human beings, both on the gut microbiome and microbiome, both bacteria and fungi. That means that we translated into animal models of a streptozocin-induced rat model to prove that what we saw in the human being is replicable in a rat study, rat model. And finally, we talked about the intraocular fluid. We took the aqueous fluid only to study the microbiome population people with diabetic retinopathy. We'll talk about on the first paper, about the paper published in Scientific Report about the gut microbiome dysbiosis, bacterial dysbiosis in people with health and diabetic retinopathy. It was 82 people from Andhra and Telangana. And from these 82 people, we got a 27.8 million of bugs, require a supercomputer, quantum computer to analyze the data. And we found that there are 4 important bacteria in that sample. We have Firmicutes, Bacteroides, Probacteria, and Actinobacteria. And this was alpha diversity I explained to you is Bacteroides are reduced in our sample in diabetic retinopathy, so also Actinobacteria, not in others. As the graph shows, SC stands for human control. We define human control the people who did not have at least diabetes, definitely diabetes, probably no retinopathy and no cancer and no chronic health diseases. On alpha diversity is a three-dimensional picture, but shown in 2-dimensional. The pictures are one circle, other circle, other circle. We show that one in the last called retinopathy, they are differently clustered. They're all, think about different 3 planes. They're differently clustered and compared to diabetes mellitus or healthy control. So they are different. Also, between the healthy and the diabetes mellitus, there is some kind of a overlapping, but most probably most of the diabetic retinopathy are from a different cluster. When we went to aqueous fluid, a very small sample size of 12 people only, because we didn't have much opportunity to do that, so our funding was getting over. From those 12 samples, we generated 9.7 million of high quality read. When it's high quality read, actually it will be around 12 million, but when it's varieties of people. In a beta diversity, we found that there is a huge clustering of the diabetic people are all shown in crimson and red are clustered together compared to those who have diabetes or those who are normal. So people of diabetic retinopathy, they have a separate group compared to people with diabetes or without diabetes. The summary of those papers we published says that Firmicutes is an important bug, important microbiota. We reduced in both DM and DR, but reduction between the human control and retinopathy is much larger compared to the other group. And this is very important microbiota because it plays a key role in digestion, in fat absorption, and improves the efficacy of energy and of harvesting. So you should have that, the good bug to have it in the body. With diabetic retinopathy, people do not have it. The learning from these 6-7 papers and the published data says that in diabetic retinopathy or even diabetes, there is an increased pathogenic and pro-inflammatory bugs, microbes, and there's reduction of anti-inflammatories, so less control and more provocation, so it leads to an inflammatory condition called a diabetic retinopathy, even though it is still called a metabolic disease. That led to a bigger study. Considering, given that this was a last small sample size and sitting in two areas of Telugu-speaking population of Andhra and Telangana, similar lifestyle, we cannot talk about India because India is a large, diverse country from Kashmir to down south and the central east to west. So we ventured to get data from different people. Also, we changed from the meta-taxonomic to metagenomic, because meta-taxonomic, you got a small area like this, overlapping area, compared to metagenomic. If you want to look at a species level and develop some therapy or diagnostic from that, you have to do a metagenomic, which is much more expensive, requires a huge lab setup, which you can, many times you cannot afford it, but we ventured to that, and we have fortunately we have a funding from our own funding. We went to the entire India. Those who are colored, south, north, east, west, are the people who collected from the 15 eye institutions in 1 key laboratory, 17 states and 1 union territory, and the logos of all the participating institutions, government or private medical college or freestanding eye hospitals are located from there. We excluded people who are younger than 30 years, who had a commercially using probiotics. Today, a lot of things, suppose you go to a mall, you get a pro-diabetic curd. So those things are known, actually excluded those people. And similarly, those who have taken antibiotics affect people with microbiome of the gut. We excluded those who have taken antibiotic for the last 3 months. This was the process. It's a long process, we will not explain too much, except that the gut microbiome, the first pass of the stool in the morning stool, is collected in a particular kit, and then DNA extracted in the lab. Extracted DNA is sequenced. After sequencing, do the metagenomic, the whole profiling, and finally think about a metabolomic study, find metabolites from those sequences, so they can actually study better. We'll talk in 2 parts. One, people with retinopathy, and people who are healthy. A very, very short brief, only this time giving not the entire process. We found that zone-wise, east, west, north, south is written here. The differences of phyla, genera, and species will come to east, because we are in East India today, talk about East India. We have got 13 phyla, 641 genera, and 1022 species, compared to other things that are shown in the west, north, and south. Do the Venn diagram. It shows differences between phylum, genera, and species. Very difficult to explain on this in a short time, but I will skip that and go to the summary table only. That the Formicutis is the most important abundant phyla in the south zone. And when you got the Formicutis bacteroides ratio, this is important to describe about the health and the disease in the human body. The south was higher, 1.49, the lowest was north, 0.18. You can maybe possibly say very loosely, but don't quote me for this, that people living in the west, the south are reasonably healthier than people living in the northmost. But this is very loose definition, so don't quote me tomorrow for something else. In alpha diversity, we found that people of retinopathy have got a differential than the people who are healthy or so in diabetic richness, in a Shannon index. All 4 indices of alpha diversity found that diabetic retinopathy different than people with health or diabetes. Similarly, in beta diversity, found that people with the DR microbiome stand away from the people with the DM or in health. When you do the ANOVA analysis of all the data together, which is more important now, that we found that those green means higher, yellow coded are middle, and the red means, and the green means is the lowest. We found that red means is lowest. We found that example Formicutis is higher in people with a DR, and other things are lower. And at the level of genera, this is a similar story, that red, green, and blue, the traffic color I have used to find out what is there, and all stats. This paper is now getting published soon. And then similarly at the species level. Important is to find the species level, because supposing you want to develop a therapy for this, then you can't develop on the phyla or genera, because they are all DNA extracted. You can't grow them. Species you can grow in a culture medium. So for us, the Cigatella species, both stenosis and Seneca are important, and we're right now working to grow them. It's not easy to grow them at all. So growing them in a different lab to find out whether you can develop something from that. The functional parameters equally important. We talk about metabolites, that we have got a huge number of metabolomes developed from these study. 448 pathways for combined human control, diabetes and retinopathy, and then specifically 15, 9 and 4 pathways for different things. I will go to one more slide a little later. Compared to people of retinopathy and compared to health, this is a very short, brief slide that the difference between the different zones of the country, north, east and south and west. And similarly, there is a different way they behave. Example, this Sigetala copri, which is the most important species that we have identified, they are dependent on interval between the meals. What time it took a meal at 2 hours gap, 8 hours gap, 9 hours gap. Intermittent fasting, this is how it actually works. We found that related to the body mass index, obesity or fat or lean, but is not much related to the level of hemoglobin or glycolated hemoglobin. So sugar level per se, that means doesn't affect your microbiome in the body. We already affected it, happened already. But your food habits, interval between the food and your obesity factor certainly impact your microbiome in the body. The summary of all these things are that there are 4 phyla and 3 species are important for the human microbiome study in people with diabetic retinopathy or diabetes. The FB ratios are different between different zones. And that is why when you develop a therapy, you develop more precision medicine people of diabetic retinopathy or kidney disease in India. We also studied the metabolic pathway, functional pathways. We found a huge number of pathways. Very busy slide, you can't make out of it, but important is this. There's one important pathway for people with health. There are 13 for people with diabetes mellitus and 19 for people with diabetic retinopathy. This is important because these all actually control the entire metabolism, entire body system. In the left, all the bucks, in the right, all the metabolic pathway examples. Suppose you take butyric acid, this is the only example I will give you, and I can talk all these different things, but let me give one example only. Butyric acid controls your gut epithelium and leaky epithelium. When it is deranged, then becomes more leaky, then there is an increased lipopolysaccharides or inflammatory disorders that ultimately lands you to either obesity and or diabetes, and diabetes led to diabetic retinopathy later on. This is a very long journey. Though I completed in 20 minutes time, but a long journey. 2017, 18, we thought about it. I worked with Dr. Shivaji, our former CCMB, current LB Prasad. He was working, he is a microbiologist, core microbiologist. He got 17 organisms named after him actually. And he worked in Antarctica to North Pole to South Pole everywhere. And then we think about the hypothesis. Took us some time to write a grant proposition to Government of India, and we got a grant and worked with my clinician scientist Brijesh Thakkar in Hyderabad to develop this proof of concept of gut in health and disease for bacteria and fungi and from the gut and the aqueous fluid. That led us to idea of doing a further study which is expanded to all India basis. Then I joined hands with Sobhik Mukherjee from NIBMG from Calcutta or near Calcutta. That came in the large DRMS study. Then I talked about all the friends all over the country, from Dehradun to Madurai, from Cochin to Guwahati, to convince them to participate in this study so they can find out possibly a important treatment therapy for people of India and or South Asia. But if you think that's all done because you published some, are going to publish some more, it is not clear, not done. It will not be done till we find something new, which might take me 3 more years to find out 2 important things that I aim to do. One, develop a GMI standing for gut microbial index, and 2 is the develop a nutraceutical. GMI, if you ever pray for me, if you ever developed the combination of the gut microbiome taxonomy and gut microbiome functional facility, example metabolites, develop into a visual analog development scale, vast scale, where from the red is bad and the green is good. Like you do a hemoglobin A1C today to say about your diabetic health, tomorrow we can do a gut microbiome to find out how healthy are we. If you are number 5, you are healtty, you are okay. If you are going to left, you are unhealthy, going to right, you are healthy. Hemoglobin A1C today cannot diagnose pro-diabetics. So when Mohan published the data about the pro-diabetics, 136 million today in the country, this was based only on the GTT or HbA1c or FBS. But gut microbiome will tell you that supposing somebody say I have a strong family history, are you becoming diabetic or not diabetic, GMI can tell you. So advanced people can be warned to take care of their lifestyle disease or go to a physician to treatment. Developing over the nutraceutical, there are these 4 varieties of pro, symbiotic and postbiotic, but I will most probably we'll stop with stay with the pre and pro and prebiotic. Probiotic more difficult, so maybe prebiotic mostly. Develop so that you can develop your metabolite, change your gut system in a way that will help you. Like we talk about the Mediterranean diet or a low carb and high protein diet, and all are actually related to this, that develop something which will be important to us. If you think that we are the only people working in the world and we have got a kind of a big foresight, actually not true. Whole world is working. Talking from this land of where Chanakya was born, he talked about how food actually controls. He says that how you behave shows your culture, how you speak shows your upbringing, and what you eat says about your health. And Raj always talked about the health. But the only guys, because they are not the only guys, being the studies also done in United States of America or Latin America and Europe and India and Asia. But you see that looking at the different, there are 3 types of enterotypes, thinking that they are all different between the North America, Latin America, Europe and Asia. So even if you develop some, this cannot be used for another country confined to our own part of the world. So most probably it will extend to Nepal, Sri Lanka, Bangladesh and Bhutan, but not beyond that, or Pakistan, not beyond that. In Asia, China and India are working most. We are the largest group of microbiome study, gut microbiome study in Asia, and followed by China. And we have also saw that our enterotypes or our microbes are different between Chinese habitat and Indian habitat. So that's why I'm telling that our work might be confined to South Asia or India, but then we have got 237 million people of diabetes. If you combine South Asia of this another 6 countries, maybe 300 million people, so it will be good enough for our work. I talked to Raj few weeks ago to chase him, telling that give me something. Yesterday he gifted us some books, 3 of them, and I know he's a big poet. When we occasionally have traveled together in the same flight, maybe sharing the next seat, and then we don't talk about ophthalmology, we don't talk about RP Center, LV Prasad, we talk about the life. That's more important than talking about your profession. Profession is, to my knowledge, your profession is called, allow me to quoting this, called a papi pet ka sabha. Unless you do that, you can't survive. But that is not your soul satisfying. So he asked a very important question that धरती पर मेरा प्रयोजन क्या है, मेरा रचना की समायोजना क्या है, मेरी कर्तव्य का सार क्या है और मेरी सृष्टि का आधार क्या है. Today, to me, we will say that मेरा कर्तव्य का सार क्या है या मेरी सृष्टि का आधार क्या है. I will say, can I complete my microbiome study and give something new and novel to people of India or South Asia? And for him, I will call him to ignite our minds and rekindle our souls. This is my life where I work, and I don't show the quantum, what do you call that? Quantum lab where I also do all my quantum computer studies I do. But then I'm certainly grateful to Shivaji, Vijay Stakkar, Sobhik Mukherjee, and all my colleagues from entire India, including Padmanja, who helped me to do this. Thank you so much.
Thank you so much, sir. May I request everybody to please give a standing ovation to the wonderful lecture that sir has given on Professor Rajvardhan Azad's oration. May I request Professor Azad to please come in the center, and all the office bearers, please. We'll honor sir once again. So just for the picture with the office bearers, sir. We have already given. Yes, sir.
Thank you. Excellent is not the right word. It is much above the excellent presentation. The reason is, that's what I say. That's what he and me think alike, you know. I tell all my younger friends, do something out of box. See the work, this work. How did he conceptualize about the gut dysbiosis? Gut dysbiosis is a big field, you know, a big arena. The gut dysbiosis will be something else in Bihar, something else will be in Andhra, and something else will be here and outside the country also. So think something and conceptualize it and then work on it. Just thinking and not working on it is not enough. So this is all for the younger people. This presentation of today is for all. It should incite and it should create a kind of an encouragement in you so that you work further. So I am really mesmerized by your presentation. I did hear about this biosis earlier, but it's a wonderful presentation, I must tell you. It's a gift to all of us here.
Thank you so much, sir, once again. I would now like to request Dr. Bholesh Rai to please moderate the next session.
Good afternoon, everyone. So I request Dr. Pooja Sinha ma'am, Dr. Soni Sinha ma'am, Dr. Abhishek Kedia sir, Dr. Deepak Agarwal sir to come on dais as a panelist for next session. Dr. Soni Sinha ma'am, Dr. Deepak Agarwal sir, So our first speaker of this session is Dr. Vidhata Vidhu. He is going to speak on PFS, leap ahead in anti-VEGF therapy.
A very good morning again to all of you. Hello. So this is a sponsored talk. Is pre-filled syringe a compelling leap ahead? Pre-filled syringe, we are referring to the Razumab, which has recently come up with the pre-filled syringes. So, what is the disease burden in India? It's around more than 1 crore. There are more than 1 crore patients requiring anti-VEGF. Mostly the DME patients, followed by the RVO, then wet AMD, and these are the different trials which has been done so far. So mostly the anti-VEGF agents, ranibizumab, aflibercept high dose, brolucizumab. So since long, around from 2006, we have come a long way ahead. And in 2021, the ranibizumab biosimilar got authorization, and since then the practice patterns has changed. So the EMA approved the ocular formulation of bevacizumab for macular degeneration in 2024, and the mechanism of action of ranibizumab is it acts on the VEGF-A and lacks an Fc domain, and it has a short half-life. The other anti-VEGF agents like aflibercept, they act on both VEGF-R1 when VEGF-A and VEGF-B along with PLGF. So how do I select anti-VEGF agent? So every disease, neovascular AMD like DME, RVO needs a sustained VEGF inhibition. So after safety and efficacy of an anti-VEGF agents are proven, choose an approved drug which is time-tested and financially cost-effective to the patient. And what is important is type of approved anti-VEGF, number of injection to be administered, and the financial burden to the patient and the government. So how does biological has helped us? Biologics. So biologics impart a huge financial burden. Biosimilars are safe, effective, more affordable, and offer improved patient access. And there is a need to develop alternative affordable therapy option with same efficacy and safety. So why not the biosimilars? So let's talk of the cost of treatment. So in comparison to parent biological drugs, biosimilar agent lead to 25 to 50% reduction in treatment cost. And it has been reported that Intas, Razumab, ranibizumab, Eccentrix, which cost around $320 US, aflibercept, which cost around $760 US, and brolucizumab $380 US, and faricimab $2,316 US. So the total annual cost of the treatment was $2,700 to $3,700 US for a innovator Razumab Eccentrix, and versus the US $1,600 for Razumab. So Razumab biosimilar of ranibizumab, with its cost effectiveness without compromising efficacy and safety, can be considered a valuable alternative to other approved anti-VEGF agents with retinal diseases in developing nations with limited resources like India. So why to choose why biosimilars? What are the challenges to the anti-VEGF treatment in India? 18 to 20% of the Indian population live below poverty line, and India's per capita income is mere $720, which is as compared to the US, which it is around $43,740 US. India is a developing country with very few people today have health insurance. Treatment costs are not covered by the insurance companies or sponsored by the government agency. So 70% of India pay for healthcare expenses out of their own pockets. Most dropout of treatment occur because it proves to be expensive. Biosimilar makes the medication affordable and helps to reduce the substantial cost burden on the patient in India. So the best alternative, the first one we have is the Razumab, and this was the first, came in 2021. So if you see the regulatory status, GGCI approved for 6 indications like wet AMD, DME, RVO, macular CNV, PDR, and ROP. While other biosimilars are not approved for the ROP, and they have a less than 4 indications like wet AMD, DME, RVO, and macular CNV. The Razumab has passed phase 3 and phase 4 is completed, and others are in phase 3 completed. The shelf life of Razumab is 36 months and others 24 to 36 months. Publications are more for Razumab and others are still on the way. So these are the government agency where Razumab has been Razumab is being used, like CGHS, AIMS, etc. This is being the first make in India. What is PFS? The intravitreal injection play increasing critical role in numerous vascular diseases. Initially, anti-VEGF came in vials. They had to be drawn up by the physician into a syringe for administration. So in 2016, US FDA approved the ranibizumab 0.5 milligram PFS, and in 2018, the US FDA approved 0.3 milligram PFS for the treatment of diabetic retinopathy and DME. So the advantage of the PFS being reduced injection time, possible reduced endophthalmitis, reduction in intraocular air bubbles and silicone oil droplets, improved precision in the volume and dose of the intravitreal ranibizumab administered, and compared with vials, PFS have associated increased procedural efficacy, improved safety and greater clinical preference. It is a time saving, and safety benefits of PFS have been positive implication for clinical capacity. So if you look at the overall advantage and the disadvantage of the PFS, intravitreal drug delivery, the proposed advantages include the reduced injection time, reduced end-of risk, reduction in the intraocular air bubbles, accuracy and precision of intravitreal ranibizumab, and disadvantage of a syringe drug assembly. So what Ranibizumab PFS offers us is precise. They have consistent dosage, drug delivery, and fast reduction in the preparation time, and designed for easy route of administration. The syringe comes with a lure lock, and it has a cap above it, and there is a dose marking of 0.05 ml. So they are the best in class for ophthalmologic biologics, superior gliding performance throughout the drug shelf life, that ensures enhanced stability and integrity of the product, and guaranteed surface sterility. They come with a pre-measured dose, ensuring accuracy and precision. Thin clear line depicts accurate 0.5 ml mark, eliminate risk of dose variation, reduces possibility of air bubbles entering the eye. They minimize the preparation steps. They have a quicker procedure time and saves around 30 seconds per procedure. They are designed for the easy and ready for use administration, reduces touch points for hassle-free handling in OT, and no difference in product stability during the entire shelf life. So this is the startup process. Remove the cap, attach the needle, dislodge the air bubbles, set dose, and then inject. Snap. SATA is snap, break the cap, attach the needle, tap, and adjust. To conclude, the PFS represents a novel method of administering intravitreal anti-VEGF therapy. They come with a small syringe barrel, minimally siliconized with low EBIT volumes, and they reduce the injection time, end-off, and reduce the intravitreal air bubbles. Thank you.
Well presented, Vidata. Do you think in a cost-sensitive country like us, PFS is going to make a difference, like cost-wise?
It does help. Biosimilars have definitely helped us to reduce the cost. No, I personally don't think so. It's 160 rupees just pricier than the normal one. But considering the biosimilars, it has definitely helped.
So, very nicely presented Dr. Vidhata. So pre-filled syringes, he wanted to summarily say pre-filled syringes are basically have reduced one procedural step outside package and reduced chances of infection a little bit. So our next speaker is Dr. Savitab Kumar sir, who is going to deliver a talk on pachychoroid spectrum diseases.
Yeah, good morning everyone. I am really thankful to all the office bearers for giving me this opportunity. I am really feeling nice that I am presenting the presentation in front of my mentor Dr. Chaitra ma'am, who has come all the way from Bangalore, and I all thank to all the seniors for the opportunity and VITREO RETINA Society of BIHAR. So I'll present on pachychoroid clinical spectrum. When we see the anatomy of choroid, it's a 5-layered structure, and it's a vascularized and pigmented tissue which is continuation with ciliary body and iris. It surrounds optic nerve head and extends anteriorly till ora serrata, and mean thickness is 0.15 mm anteriorly and 0.22 mm posteriorly. So when we see the imaging of choroid, the gold standard is ICGA, but it is invasive, does not give layer by layer info. So in hand depth imaging, a method that improves resolution of choroidal details when focused manually, placed more posteriorly than in standard retinal OCT, images result in production of inverted images. So, measurement of choroidal thickness, the lack of clarity to variability in manual measurement, which limits the applicability of various machines and in comparative study. So, anterior boundary is hyper-reflective band corresponding to RP and Brooks membrane complex. When we talk about posterior boundary, there are two schools of thought in measurement of choroidal thickness. The Spade et al., the hyperreflective space underneath the choroid and suprachoroidal space, whereas Moore et al. Concluded that it's a well demarcated hyperreflective band between the large choroidal vessels and the sclera and the suprachoroidal and scleral interface. So difficulty comes is insufficient quality of images, determine the accurate location of the choroid scleral interface, presence of pathological lesions, thick choroid and manual measurement. So there are multiple factors which affect the choroidal thickness. Age, approximately 194 micrometer at birth, but decreases with approximately 80 micrometer by the age of 90 years. Thinner in blacks compared to white and Asians, 18% thicker in men than in women. Axial choroidal thickness reduces by 15 micrometer per diopter of myopia, and subfoveal choroidal thickness increases with deep anterior chamber, thicker lens and flatter corneas. So it is generally thicker between 3 am and 9 am, and its thinnest between 3 pm to 9 pm. So these are all based on research articles. The measured choroidal thickness may differ across machines due to different segmentation algorithm. So what is pachychoroid? What does it actually means? It means that it's pachy, which means thick, and it was introduced by VRSB et al. While describing the pachychoroid pigment epithelopathy in fellows' eyes of CSE. So pachychoroid spectrum consists of increased choroidal thickness. It can be focal or diffuse. Pathological dilatation of Hallard's layers referred to as pachyvessels, loss of choriocapillaries and saddler layers overlying pachyvessels, and histopathological findings of hyalinized thin-walled choroidal vessels. So this is the OCT showing increased choroidal thickness, pachyvessels, and loss of choriocapillaries and saddler layers overlying pachyvessels. So pachychoroid spectrum consists of pachychoroid pigment epithelopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, and PCV. So if we see there, the clinical manifestation may vary, imaging showing similar morphological findings in choroid. Sequelae is similar, focal choriocapillary atrophy with inward displacement of deep choroidal vessels. So when you talk about pachychoroid pigment epithelopathy, there's a reddish orange fundus, there's focal RPE changes, no SRF or previous SRF, they will be idiopathic serous PED. So Vedder et al. In 2013 as a 9-patient case studies he did. So this is the case study from the original VRSB paper on PPE. This is a color fundus photograph which exhibit a reddish orange background due to fundus with minimum choroidal vascularization visible, and there is a hypopigmented RPE lesion just temporal to the fovea, and it's found directly overlying the dilated choroidal vessels. So OCT imaging showing numerous scattered small p elevation of RP representing RP hyperplasia and Drusen-like deposits, and serous PED are present, and there is a thick choroid usually located just beneath the clinically apparent RP change. So when we talk about central serous chorioretinopathy, it generally in healthy young or middle-aged patients, serous detachment of a neurosensory retina, which is often associated with one or more serous PED. Kim et al. Found 125 micrometer increase in choroidal thickness in eyes with CSCR compared with age-matched controls. So again, this finding of a very thick choroid in patients with CSE provides additional evidence that the condition may be caused by increased hydrostatic pressure of the choroid. So studies which compared choroidal thickness post-PDT in cases of chronic CSR and laser photocoagulation in classic CSR. As given by Everest 2 trials as well, the subretinal fluid resolved in both diseases, however, its choroidal thickness and the hyperpermeability seen during ICGA was reduced after PDT. This finding suggests that PDT reduces the choroidal vascular hyperpermeability seen in CSE and may different mechanism by laser photocoagulation. So pachychoroid neovasculopathy is type 1 sub-RP neovascularization overlying focal areas of choroidal thickening. It's a long-standing chronic CSE may lead to neovascularization. It differs from AMD in that young age at the onset of neovascularization, absent of drusen, and thick choroid with pachyvessels. So we see there is a type 1 sub-RP neovascularization overlying focal area of choroidal thickening. Ischemia leads to neovascularization. So OCT showing SRF beneath the fovea associated with RP pigment elevation with the characteristic double layer sign and consisting of type 1 neovascularization. There is thickening of choroid associated with dilated vessels located beneath the neovascular tissue. So the finding of shallow irregular PEDs in pachychoroid eyes on OCT is considered to be a sensitive sign for neovascularization. OCT angiography may be more sensitive for the detection of vascular network compared to FA. And in PNV, patient with no evidence of AMD and patient with PP are frequently misdiagnosed as having inactive CSCR, early age-related macular degeneration or macular dystrophy or inflammatory chorioretinopathies such as punctate inner choroidopathy. A greater awareness of the entity may encourage clinician to perform these investigations and may diagnose earlier. So when we talk about PCV, it's primarily a disease of choroid characterized by sub-RP polyploidal dilatation of network of abnormal choroidal vessels associated with serous exudation and hemorrhage that may lead to detachment of RP and sometimes neurosensory retina. So the definite diagnosis is made by ICGA, which shows multifocal choroidal hyperfluorescence, polyploidal vascular dilatation, and polyps and BVN. So PCV has traditionally been considered either as standalone idiopathic entity or a variant of neovascular AMD. Closer examination of the choroid of many patients diagnosed with PCV reveals features consistent with those of pachychoroid phenotype. Anti-VEGF acts by decreasing and choroidal vascular permeability. So pachychoroid is a hyperpermeable thick choroid. When RP able to overcome fluid overload, it's PP. When RP not able to overcome fluid overload, CSR, and microripid Brooks membrane develops in the process if associated with type 1 NV, then it's PNV, and vessels may develop terminal polyps in this case of PCV. So when we talk about focal choroidal excavation, it's an unusual concavity in the choroid and occurring without posterior staphyloma or scleral ectasia. It's a good visual acuity, near normal overlying retinal architecture, little change over time, and associated with PCN, CSC, CNV, ERM. And in OCT finding, we see increased choroidal thickness. There is dilated choroidal vessels directly adjacent to or outside the area of focal choroidal excavation, inner choroidal thinning with atypical highly reflective choroidal tissue, and poor definition of the choroidal and scleral junction within the area of focal choroidal excavation. So this is the OCT. It shows increased choroidal thickness, dilated choroidal vessels directly adjacent to FC, and poor definition of choroidal scleral junction. Thank you. Thank you for the time.
Thank you so much. This was an excellent deliberation. Dr. Chaitra is here and she's done a lot of work on pachychoroidal imaging. Any inputs you want to share? How do we prognosticate diseases based on choroidal imaging?
A couple of comments first. So there are, as Sabita told, there are two more entities added now. One is the FCE and the other one is peripapillary pachychoroid as well. In addition to that, two more new ones that have come in are peripapillary pachychoroid associated with neovasculopathy. You know, so many times we tend to miss out imaging around the disc. So if we see any suspicious lesion, also important that in the pachychoroid spectrum that we image the disc as well. It can even sometimes extend nasally. So all the more important to do a disc-centered OCT. And the other new condition that's been added in the pachychoroid spectrum is PHCR. We always knew it's an extension of PCV, but it was not included in the pachy spectrum. The difference is that not all patients with PHCR will have a thickened choroid. Sometimes they even have a thinner choroid. So those are two new things. Another thing that we speak about is pachyneovasculopathy. Octa is an excellent tool for pachyneovasculopathy. So any CSCR that's worsening or not responding to conventional treatment, either with EPLI or with laser, best to follow up these patients and look for PNV, treat them, and about 40% of these patients eventually develop PCV. So these are patients that we need to keep a really close follow-up because we don't know when they develop PCV, and you know that can be catastrophic. They'll have such severe submacular hemorrhage that many a time the patients never come back to normal vision. So these are few pointers. Of course, imaging is the biggest tool here. Using EDI, we can't use ICG and routinely keep imaging these patients. But I think the new classification that Jay's group from Giridhar have done on the OCT and the color fundus photo classification, that's more than enough to follow up these patients. Thank you.
Thank you.
Okay, so that was an excellent talk. So now we'll move ahead with our guest speaker for today, Dr. Ruchir Tiwari. Is he here? Dr. Ruchit Tiwari is a very senior VITREO retina surgeon based in Noida and Faridabad, and he has traveled all the way from Noida to be part of our scientific session, and we are very grateful for that. So over to you, Dr. Ruchit. He'll be speaking on reimagining drying durability with brolucizumab.
Thank you, ma'am, for those kind words, and I would like to thank VRSB for giving me this opportunity. So I'll be talking about drying and durability with brolucizumab. So this is a standard disclaimer. Novartis sponsors for the travel and the stay. So I started using this drug long back when it was introduced. I think it's been 5 years now, and this is the course that I have followed. Phase 1 were only cases which were very difficult to treat, which were non-compliant and non-responders. When I started using the drug with these cases, then I got more confidence, so I shifted to treatment optimization, which means that these patients were responding to the anti-VEGFs before, but the treatment burden was such that they just could not keep pace with the treatment. Finally to treatment naive, and then eventually to DME and non-CNV and non-indicated cases. So I'll be sharing few of my cases that I've treated with this drug over the past 5 years. So the first patient is an 80-year-old gentleman. I first saw him in September 2020. His BCVA is 6.9 at this point in time. You can see some drusenoid PED-like structures. Now, he's a one-eyed patient, and BCVA of 6.9, 78, 80-year-old gentleman. I kept the patient on follow-up. He came back in April of 21, 4-5 months later, and his BCVA had dropped down to finger counting close to face. Now, if you look at the OCT picture, he had suddenly out of the blue developed a giant RP rip along with a lot of subretinal fluid, intraretinal fluid, and his vision had dropped down drastically. So this is 2021. The standard of care was still aflibercept or ranibizumab at that point in time. I discussed both the drugs with the patient. We decided on ranibizumab. I injected 1 dose of ranibizumab to the patient. He comes back after 6 weeks. There is some resolution of the intraretinal fluid, but the SRF is still there, and there is no vision gain whatsoever. So at this point in time, I shift the patient directly to brolucizumab. So patient again comes back after 4 weeks. At this point in time, a lot of SRF has gone away, and after so many months, vision improves to 660. So at 8 weeks, fluid further goes away. So after 1 injection of brolucizumab to a patient which was not responding to ranibizumab, the fluid went away after 8 weeks completely. Now this patient has been under my care for the past 4 years, and this is the OCT picture, last OCT picture before the last injection was given. There is no SRF, but there is a lot of IRF, degenerative fluid as well. He's received 19 injections so far over the past 4 years. He's on a 3 to 4 monthly injection regimen. Now the patient understands when he requires an injection, and he comes back on time. His BCVA is down by 1 line, but he's still able to manage and navigate. So he's able to do his daily activities very well. The second patient is a 60-year-old female, decreased vision in left eye, diagnosed as neovascular AMD elsewhere. Now when she came to me, she had already received 3 monthly ranibizumab and 1 aflibercept injection, and when I looked at all her previous OCT scans, there was no change in the OCT picture at all with any anti-VEGF that was given before. Her BCVA was 618 with or without treatment, and last injection she had received 3 months back. So this is the OCT picture and the fundus picture. The OCT clearly shows a well-demarcated membrane complex with subfoveal fluid and SHREM. At this point, I repeated ranibizumab. Now, I was following this patient up very closely, so I called her after 2 weeks. Her BCVA remained 618. There was some resolution of SRF, but at 4 weeks, the disease recurred again. So a patient again not responding to ranibizumab, history of aflibercept use with no response, I shifted the patient to brolucizumab. So this is 4 weeks post brolucizumab, and this is the first time when all the SRF went away. Her BCVA improved to 6.9. However, at 8 weeks, she again had a recurrence. So vision dropped to 6/12 part. She received her second injection. This patient again has been under my follow-up for the past 4 years. This is the last OCT of the patient. Now, this OCT was done in September of 24. By that time, the patient had received 14 brolucizumab over a period of 30 months. She remained disease-free for 18 months. And her BCVA was 6.9. She again had a recurrence this year, and she has received one injection in May this year. So after a disease-free interval of 18 months, she again had a recurrence for which she received one more injection. The next patient is a 40-year-old female, a working mother. She was diagnosed as pachychoroid with type 1 CNV. Between October 2019, when I first saw her, to September of 21, I had to inject 14 ranibizumab and 2 aflibercept injections, but her BCVA remained 6.9. These are the initial pictures that were taken, OCT, the fundus, and the angiography images. This is September of 21, when patient again had a recurrence after 6 weeks of last ranibizumab. BCVA was 6.9. So this is one case of treatment optimization where we wanted to decrease the treatment burden of the patient. So I discussed the patient for brolucizumab. She agreed. She was switched to brolucizumab. The patient comes back in December. There is no fluid. BCVA is 6.6. In January, no fluid. Feb, March, April, May, July, and till September. So for 12 months, the patient was disease-free after one single injection of brolucizumab. A patient who had already received 16 almost monthly injections for the same disease process. Now, she again received an injection. She remained disease-free for 30 months, and then she again had a recurrence for which she has now received the third brolucizumab injection, but the BCVA remains 6.6. Next, I'll show a few DME cases. So the first patient is a 60-year-old female, BCVA 6.18 and 6.9, right and left eye, early nuclear sclerosis, both eyes, fundus show tull reflex. Right eye has a center involving DME, left eye shows non-center involving DME. Now this is May of 22, patient's BCVA is 6.18, her CMT is 387 microns. She has history of 3 ranibizumab, 1 aflibercept, 1 ozurdex in the right eye over the last 1 year. She did not respond to any of these injections. Her systemic control was fair. She was given 1 injection of brolucizumab. She comes back after 2 months. BCVA remains the same, although the CMT goes down a little bit. At this point in time, she receives the second injection. Now this is a non-compliant patient. She comes back in August, BCVA 6/12, CMT goes down to 276 microns. Then she disappears for 1 year. And to my surprise, when she comes back, BCVA is still the same and CMT remains the same. She's still kept under observation. In December 23, 6 months later, when she comes back, BCVA drops down by 1 line, CMT is better. This is because of cataract. She undergoes cataract surgery, regains her vision to 6/12. In April of 24, BCVA 6/12, CMT of 215 microns. So 2 injections were given 2 years back, and the patient maintained the same anatomical structure and the visual acuity with a good systemic control. Now we can always attribute this to her good systemic control, but then we do have the other eye to look at. So this was the initial picture of June 22, when BCVA was 6.9, CMT was 300 microns. She was kept under observation. Now the left eye kept on deteriorating. This is December 23, but she refused injections in the left eye. 430 microns, 6/18 vision. She finally received 1 brolucizumab in April of 24. And these are the last, when I saw the patient, October 24, BCVA 6/12 both eyes, and both eyes are doing well. The next patient is a 60-year-old male. Now he's a colleague's father. He had DME in right eye, BCVA was 6.9. This is the initial picture, March of 24, BCVA 6.9, CMT 300 microns, observation. He comes back after a month, vision drops by 1 line. I discuss brolucizumab and inject. He comes back after a month, BCVA 6/12, CMT goes down a little bit. In June, CMT goes down further, but vision remains the same. In August, after that 1 injection, the fluid keeps on going away. So unlike CNV cases, DME cases respond in a very different manner with this particular drug, and they keep on getting better with time, even with no further injections. The third patient is a 50-year-old female, bilateral DME. She had a very poor metabolic control. This is the original picture of the patient. She was asked to control her sugar levels and then get back. Unfortunately, she disappeared. She comes back after 6 months, and by that time, although her A1C was good, she had already received 3 ranibizumab and 1 aflibercept in each eye. This is the OCT picture from that time. She had drastically worsened, vision had dropped down. So like any other retina specialist, looking at the number of hard exudates, the lot of SRF, I would inject ozurdex, and that is what I did. 2 months later, there was some response to ozurdex. The left eye seemed a little better, but there was no gain in visual acuity. However, at 3 months, post-Ozurdex, there was again a recurrence. So now I had a choice to either inject Ozurdex again or to shift the patient to brolucizumab. She had already received all possible other injections. So I shifted her to brolucizumab. At 1 month, little seems to have changed. However, at 3 months, the fovea dries up in both her eyes. She gains vision by 1 line in both her eyes. And to my surprise, this thing continued for the next 3 months. So she had a recurrence in the right eye after 6 months, and in the left eye, she still did not require any injection. So this patient is now on a 6 to 8 monthly brolucizumab regimen, and she is maintaining her vision well. So what has been my experience so far? In the past 5 years, I've injected around 1,000 vials. I've used it in all possible indications. This is my first line agent for all approved indications. It is my second line in refractory non-indicated cases as well. As I was mentioning with my cases, the response in AMD seems to be a lot different from that in DME. DME patients tend to require a lot less number of injections compared to AMD. I have had 2 cases of mild intraocular inflammation which were treated with a topical steroids and had no vision loss at the end. So this drug gives us increased longevity with fewer number of injections. It significantly decreases the financial burden of the patient, and in my practice at least, it has led to an increase in the patient compliance. That's it. Thank you.
Very well presented, Richard. So we all know that brolucizumab is a wonder drug. The only concern is of IOI. So do you give loading doses, or how do you what is the frequency of doses if you are planning to give in a naive case?
Sir, so what I have tried to do over my practice changed over time. Initially, I would give the second injection at 8 weeks. But now what I do is I call my patients, so neovascular AMD patients, I will call them every month. I do monthly OCTs after the first injection. Then I get to know at what time the patient more or less is having a recurrence. It could be 2 months, 3 months, 4 months. And I will fix that time. So the patient will keep on receiving, at least for the next 2 years, the patient will receive on that fixed dosing. So that is what I do for CNVM to decrease the burden of injections. For DME, again, monthly follow-ups, and DME again is a PRN thing, and patients do not require many injections. So about inflammation, what you were saying, instead of, so what I did was I tried to look in the literature about inflammation, and the maximum data that we have is from the IRIS and the Komodo registry. That is the Hawk and Harrier study protocol data, which has around 18,000 eyes. At their 2 years data conclusion, they came out with the findings that inflammation was seen first more in cases which were switch. And if the patients are treatment naive, they tend to have less inflammation and less severe inflammation. Second is female patients tend to have higher number of chances of inflammation. Male patients tend to have less. Higher age again is a predictive factor. So I would try to strategize how I use this drug. I discuss every time with my patients all the options that they have. With Vabysmo also coming into the picture, they always get an option. But for neovascular AMD, this is my drug of choice.
But we are more bothered about not just IOI, but the occlusive vasculitis, which has been reported.
Right, sir.
And I think once we experience that kind of a complication, we are very hesitant to use it in future. And that is the reason why in, I think, Europe, it is like now withdrawn from the market, sir, at some places, because you need, no, it is not very uncommon, I would say.
Sir, it is, in our population, it is very rare.
It is very rare.
Yeah.
Okay.
IOI is still common.
I have faced it. I was very confident of using this drug, as you said, because of its wow effect, until I experienced this complication. And
Sir,
I was, and we never give the loading dose.
Of course.
And the patient in which I experienced this was a patient who I had given 2 doses. That too, the first dose was given, he responded very well. The second dose was given, after a gap of 3 months, and he did well, and he was doing well for another 6 months.
Right.
And the third one, when I gave him, he developed a complete occlusive vasculitis. And that was the time when I was really, very taken aback that I lost my confidence in this.
This is exactly the same Dr. Deepak is saying, the apprehension about the IO. We faced 2 cases of endophthalmitis. Actually, in fact, one patient responded to systemic steroid, but 2 patients, they actually required vitrectomy, and after over 100 cases, 100 injections. So because of that reason, I gradually I would say that I suddenly stopped that drug using, and now I occasionally use. That is my experience. I don't know why it is different in different parts, but.
Sir, I have just one point to make. Yeah.
So yes, it's a wonder drug. There's no question about the efficacy of Peginax. It works wonderfully. But just one word of advice that I would have is don't use it for off-label, ever. Because what happens is, in case, okay, we are not saying it's 0 incidence of IOI, right, in India, because the VRSI study has published that we have seen inflammation. Yeah. Many a times the patients have recovered very well. But in case you have a bad IOI or an occlusion, if you use it for off-label, you're going to be in a lot of trouble. We are very tempted to use it because we have a whole lot of RVO patients who are not responding to anything. And you know, RVO needs a whole lot of injections also. But if something happens and it is not given, even the company will not be able to help you out.
True. Ma'am, but see, one thing that I would want to say is, as Dr. Padmaja was here in the morning, she said one interesting word, idiosyncratic. We still do not know the reason why this is happening.
Yes, so how do you know we are safe in giving?
Exactly. So, any injection can lead to endophthalmitis. Then you
this
do not give.
This is not endophthalmitis.
I agree with you.
I'm talking only about occlusion, not even vasculitis.
I agree with you. But then the whole point is, instead of not using the drug, shouldn't we try to use it in a manner in which the patient also becomes safe and.
How do we know that, Ruchir? How do we know?
But not using the drug is not the answer here.
No,
this is
so let them get the approval for the ones that they don't have.
Even for approved indications, not using it simply because you have
I'm not talking about approved. DME and AMD, of course.
Yeah, sir. Just one case you had a bad incident. And you stop using the drug altogether. You do not even think of using it. That is
we are using. There's no question. We are still using.
So that's what my
only thing was for off-label.
So off-labal data is also coming for RVOs, and there's a lot of published data for RVOs as well now.
Then it will be safe for us, because patients will be ready to go to the court, and we should not get into trouble. So AMD, PCV, and DME, there's no question.
So I just have
European market also.
Yes, they have.
Then why did
So the reason, like he mentioned, is the incidence is not as much in our population, and it's very low in DME patients. The only where we have seen the reaction is only in patients with AMD. Surprisingly, though DME is supposed to be more pro-inflammatory, milieu. But hardly any reports in our experience. We have used many injections at NN. Yeah. We have not seen any severe conditions, and even in the 2 or 3 patients who are doing well after an inflammation, they were all AMD patients.
Right.
So and we continue to use it. It's part of our armamentarium.
I just want to ask one question to the House. What's your take on using anti-VEGF, and how safe it is to be using in patients with concomitant cardiac problems? Different cardiac problems.
Technically, ma'am, the data that we have, there is no risk per se. I mean,
there's no problem. Right?
There is not. There's no data to say that a patient has increased cardiac or increased neurological even after an episode. But of course, a cardio clearance, we just ask to get a cardio clearance.
Okay, that's all.
Yeah. Sir, as a VR practitioner, we usually prefer aflibercept, brolucizumab or faricimab in high risk, tall PEDs, PCVs and PEDs, FVPEDs having larger linear diameter. I want to say that those cases which are more prone to develop RIP. So, in your practice pattern, how do you feel that RIP incidences are, how vary with aflibercept, brolucizumab and faricimab?
So, I don't think it matters much. What I've seen over the past so many years is that I have had one patient with aflibercept and one patient developed RIP with brolucizumab, and both had a similar sort of picture. Even the first case that I showed was that of a patient who developed a RIP without any anti-VEGF treatment. So when you are supposed to treat the patient with the same drug that is actually causing the disease, we are left with no choice. We still have to treat the patient.
So, do you think we should change over our anti-VEGF choice after developing RIP, or?
I don't think so, because the stronger the anti-VEGF agent, the better it is. Even if it causes a RIP, when you need to treat it again, you require whatever anti-VEGF you are using. So that should not be a reason to shift the anti-VEGF.
Okay, thank you, Dr. Ruchir.
Thank
That
you.
was excellent. Now it's my absolute honor and privilege as well as happiness to introduce our next guest faculty for our conference, Dr. Chaitra Jaydev. She is a senior consultant and previous head of department of the VITREO Retina Services at Narayan Nethralaya, Bangalore. She is currently the treasurer of VITREO Retina Society of India and the secretary of the Karnataka Ophthalmic Society. She has over 180 PubMed index journals and the recipient of the prestigious Colonel Rangachari Award, J.M. Pava Award, amongst many other awards. And most importantly, she is a very good friend of Dr. Satyajit and myself. And she has, on one phone call, she said, no, I have to somehow make it. She was in Mumbai last evening attending the Bombay Ophthalmic Conference. And she got up at 3 a.m. in the morning, changed flights 2 times, and somehow made it for our conference. So we are very, very grateful to you, Dr. Chaitra, for having accepted our invitation. And we consider it a personal favor.
Not at all. Pooja, pleasure to be here and a pleasure to come back to Patna. Ever since I came for the first meeting, I think it was in this hall itself. It's always a pleasure to be back here, and so many friends in the audience and on the stage. So glad to have made it. Yes, some last minute flights getting cancelled and all the detours, but still worth the visit, I think. So I'll be speaking on management of pseudophakic CME. I think the reason why this topic is important is because it's a crossover for cataract surgeons and for retina surgeons. So it becomes important for us to see, do we have anything new in terms of managing these patients better? We've been facing this situation of handling pseudophakic CME for several decades now. So let's see if we have anything new. How big is the problem? Well, the overall incidence in Indian patients with clinical CME is about 2% of uncomplicated surgeries. And you know the number of cataract surgeries that are performed in our country, so that's quite a large number. But if you look at, angiographic CME, it's much, much more. It's close to 20%. Not that all of them require intense treatment or immediate treatment, so some of them just tend to resolve on their own. But these are the big numbers there. And when you look at it in patients with diabetics, with 101 million diabetics in India, the crossover population of diabetics undergoing cataract surgery is quite high. So again, this becomes a very, very important population for us. So literally half the patients with or without pre-existing diabetic retinopathy are going to develop cystoid macular edema, and we need to follow up these patients closely therefore. So this is just as Ruchir mentioned, this IRIS registry is very, very important. I wish we'd had something in our country as well, because we have so much data and we're unable to get it in a formalized way. So there are efforts from VRSB to start a registry for our population as well. So they've looked at 3.1 million cataract surgeries that were done, and CME was diagnosed in just 0.8% of the patients. So this is like the latest data that we have available, and the average onset was at 6 weeks, and males aged less than 65 years from the black race with pre-existing diabetic retinopathy were the highest risk factors, and those with CME were more likely to have poorer visual outcomes compared to those without CME. And it says here that finally at the conclusion of the study that CME after cataract is low, and most of them tend to get more than 20/40 vision. So it is a concern, but not as large as we assume it to be. But this is in a formal setting where the follow-up is close, the investigation is good. Not in our country. Most patients, once they finish their cataract, they don't come back for months together, not even for a glasses correction. And when they come back, it's chronic CME, and no matter what you do, there's no response to treatment. So quickly I will cover the development of CME, classification, risk factors, diagnosis and treatment. Well, we know that inflammation is the major cause here. There's disruption of the blood-retinal barrier, leakage, and then finally accumulation of the fluid here. So this is the vicious cycle that's set up there, and eventually the CME needs some form of management without which the visual acuity does not gain. So now the classification as per the onset is when it occurs within 4 months it's acute, after 4 months it's late, and when there's chronic after 6 months. Now coming to the risk factors, intraoperative complications are important, whether it's trauma to the iris, posterior capsular rupture, intraocular lens dislocation, vitreous loss, and you have all these other complications that can occur which can cause CME. Now it can even occur, like I mentioned, in uncomplicated or uneventful cataract surgery, but it obviously is much more after complications. Now what are the pre-existing ocular conditions? DM, like we spoke about. We also have RVOs, epiretinal membranes, neovascular AMD. RP is one population who's at risk, and preoperative use of PGAs. This is a very important history that we need to ask, because this is something that we tend to miss in our OPD because we are so busy. Always ask for PGA and then never tend to tell you unless it's a history that's sought for. And also untreated elevated IOP can give rise to some incidence of CME. So how do you diagnose? Clinical examination, the foveal reflex is not as sharp, OCT, octa even, and fundus fluorescent angiography. So here you can see how typically the CME is seen in this particular patient. Multicolor imaging, you see how beautifully you can actually see the cyst there. It's quite well demonstrated on multicolor as well. And then of course where there is greater, another new thing that they found is that there is greater global superiotemporal and superiornasal RNFL thickness in comparison to healthy eyes. And also after resolution of the CME, they saw that there was thinning of the RNFL. So maybe peripapillary RNFL measurements may also help in the diagnosis and follow-up of patients with pseudophakic CME. So this is how you can follow up these patients using the RNFL, and this is of course the octa. Other than looking for CME that's resolved and vision not improving, so ischemia is one reason here, especially in diabetics, so octa would help there. Coming to the treatment, topical is simplest. We also have prophylactic and post-operative oral medication, some injections, laser and surgery. So this is a very good table which shows a summary of all the possible treatments that there are for pseudophakic CME, right from the different topicals to the intravitreal injections and the immunomodulators as well. So I'll just go through them quickly. We know the NSAIDs and the interferon. NSAIDs rapidly permeate through the cornea and sclera, and they block the inflammation-mediated breakdown of the BRB and therefore help in resolution of the edema. So you administer it pre-operatively and continued for at least 2 months post-operatively, and it helps in reducing the risk of even post-operative CME if there was no pre-existing macular condition. Now interferon is one other new topical agent that's available, and recent studies have concluded to be a good economical and effective treatment option. And our center has done a study as well from our UVA department. They have looked at predominantly patients who had PCR intraoperatively, and the mean resolution duration was about 5 weeks. So topical interferon can therefore just be an effective medication for resolution. So what we've been using is interferon alpha 2B. It has about 3 million international units. You get it from Intas. You basically reconstitute it by diluting it with 2 ml of distilled water to form a 3 ml eye drop. The cold chain has to be maintained with ice packs during the transport, and the patient should be instructed to store it in the refrigerator door at 4 degrees Celsius and start it about 4 times a day. So we found this to be a good alternative as well, and we have different literature to support the same. So this is the Intalpha that's available. For briefly in between it was not, but I think now it's back, availability is now back. Next is oral carbonic anhydrase inhibitors. Complete resolution was seen in 87% of the patients, and 100% of cases treated with a combination of acetazolamide, NSAIDs and steroids had resolution of the edema. So this was another experimental injection of acetazolamide intravitreal. There's just a publication. I have no personal experience. Here again they saw that in a patient with chronic CME, intravitreal acetazolamide worked. They used a 25 gauge trocar cannula to instill the same. Coming to steroids, I think we're most experienced as far as steroids goes, whether it is DEX or IVTA. or maybe even some tenons a couple of years ago, there is definitely a better compliance, and but with the risk of IOP. Periocular, like I said. Anti-VEGF, well, not as effective for pseudophakic CME, but still for patients with glaucoma, you have no option but to use anti-VEGF, and they respond, but most of them do require a second or a third injection. Laser for some patients, not all really. You can use 577 subthreshold laser, and studies have shown resolution of the edema. Surgery is basically to take care of the complications that have occurred during surgery. And we did a quick study on biomarkers. This is the same patient, both eyes treated with intravitreal anti-VEGF. You can see resolution in one eye and absolutely no resolution in the other eye. So we collected tears of this patient and aqueous and did a couple of studies. We basically wanted to look at the different mediators, which is besides anti-VEGF, or besides VEGF itself. These were the different soluble factors that we looked at in the aqueous humor. This is how we conduct the experiments at our lab. The aspirate is put in a sterile phosphate buffer, and we use it after 2 hours at 4 degrees. And we use cytometric bead array to do these tests, and we detect several study factors. And what we found in this particular study was cytokines such as ICAM, VCAM, and IL-6 and IL-8 were much more increased in the persistent macular edema group, giving us food for thought with respect to resistance to anti-VEGF therapy. And we really need to also focus on non-VEGF mediated pathways, and helps us target more. So we've also made this biomarker kit, which can be done in our OPDs itself. So this is another patient, last 2 slides, who had incomplete resolution after anti-VEGF treatment. And we saw here that the VEGF levels were very low, which is why we went ahead and gave this patient IVTA, and you can see near complete resolution of the edema. So to conclude, pseudophakic CME is more common than previously thought. Advances in imaging actually have helped us pick out lesions which we probably would have missed clinically. History of CME in the first operated eye is the strongest independent risk factor. So this is what we need to be careful about. Counsel patients that in the first eye you had edema, there's a good chance you may develop in the other eye, even if they were operated elsewhere. That becomes very important. And high-risk populations should be screened ahead of the development of vision loss. Don't wait for patient to come back with symptoms. See if you can screen them sooner and treat them. This is one latest study that shares the edema risk in diabetic patients is high, and diabetes itself can worsen the edema if it's uncontrolled. And pre-cataract OCT, we do that for all our patients now, because when the cataract is significant, you cannot pick up pre-existing edema. So this will help you medico-legally. And they say DEX implant intraoperatively gives you the highest benefit of preventing post-operative edema. Okay, this is for the non-retina people in the audience, if there is any. When to refer to a retina specialist. Don't keep waiting with just topicals. If you're not comfortable injecting, please do refer, because we will need to rule out the cause. Maybe even surgical management might be required. Thanks to my team at the lab and the department. Thank you very much.
Wonderful presentation as always, ma'am. Just 2 questions. Like the EVRS study said that you should give NSIDs in non-complicated cataract surgeries for at least 2 months. Do you think should we practice that, or
absolutely.
even in non-complicated cataract surgeries? So NSIDs for 2 months.
Yes. So we also give it pre-op for a few days, like say probably a week before. So and then we continue the patients for at least 2 months. All of them are on NSAIDs, but what we have found in a couple of our ocular surface studies is that NSAIDs can affect the ocular surface on long-term use. So we give it along with a lubricant. So just even a BD dosage with the lubricating drop is beneficial.
So one more thing, ma'am. Do you think that when we are giving topical steroids, prednisolone, so should we start it along with that, or when we are tapering it, or right from the beginning?
No, I think NSAIDs are required. The way they act is a little different, the pathway. So we are now at our center giving it simultaneously.
Simultaneously, okay. Thank you.
Because the steroids are started from day 1, but then we start tapering them off, right?
Yeah.
So the patient actually gets very confused when to start, when not. So since we're doing a BD or a TID, and we've given them a printed thing with the date and dosage, and in fact we even put in the timings of the injections, they are quite comfortable we feel the compliance is better when we start it off.
Now single dose NSAID are available. So what is your
OD
choice?
dosage.
So you give.
We are actually doing a study to see patients with diabetics who are on OD and TID dosing to see whether there's change in the edema. We're still not very sure about the potency of the OD dosing.
So it's better to give the 3 times dose.
Yes,
of.
I think in the risk population, better to go with TID. For those with no risk, absolutely no macular changes preoperatively, OD dosing should work because of the risk of ocular surface abnormalities.
So just as a last take home.
Ma'am, what is your approach in chronic CSR treated patient who develop post-operatively CME, and even with NSAID they keep on troubling with CME?
So like I said, these CSCR patients with a change in the pattern will need to rule out PNV. So rule out a pachyneovasculopathy. It could be coincidental that you're seeing a worsening. It may not be attributable to the cataract itself. So always image them on Octa. Actually, Octa beautifully picks up PNV in these patients. Then you have to treat them with an anti-VEGF. It will address both the pathologies anyway.
You mentioned diabetics. Are diabetics more prone to CME post?
Yeah, absolutely. Very, very high.
And so, in these diabetics, should be pre-operatively 2 weeks before start NSAIDs?
We are starting about a week before now. 1 week before.
And then you see that the incidence is lower for CME?
We have not really followed that up because patients who already have edema are getting injections at the time of surgery. So we can't really tell whether the NSAIDs are working for them or whether it's the injection that's worked. For diabetics who have high blood sugars without any macular edema, we're just doing TID NSAIDs for now. We still don't know how many of them actually develop the macular edema because of a pseudophakic CME or whether it is just diabetic macular edema. That's the only concern for non-controlled diabetics. We can't really tell for sure.
So just to sum up, if a patient comes to you 6 weeks post-op with pseudophakic CME, how do you manage? Do you start topical drops, wait for some time, then give anti-VEGFs? In my personal experience, anti-VEGFs have worked for me. Maybe because of the inflammatory, they had more inflammatory component to them. So how do you start with topicals?
So 6 weeks post-op, it's the first time the patient has ever developed a macular edema. No pre-existing macular edema.
No, there was nothing.
And so my approach would be based on the patient's vision, symptoms, and the degree of edema. So if the patient is mildly edema, just a few cystoid spaces, topicals have worked very well, and diabetic control if the patient is a diabetic. But if there is center involving edema with significant cystoid spaces and subretinal fluid, I would go ahead with an injection. If it's a very mild edema, then anti-VEGFs work well. We've seen even anti-VEGFs doing well. Even NSAIDs have done well. I have a patient with just topical NSAIDs who did fairly well, but the patient was not very symptomatic. So it's also very difficult to convince the patient to take an injection when they're not symptomatic. You just see clinically that the foveal reflex is not looking healthy in image and you see some edema. So if the edema is very severe, Pooja, I would go ahead with a steroid. If I know that I'm going to need more than 2 anti-VEGFs, patient has no risk factors for giving a steroid, I'll go with steroids.
So thank you very much, Dr. Chetra. Now I would like to request our President, Dr. Subhash Prasad, to please facilitate, to please honor the guest faculty. Dr. Ruchir Tiwari.
Can I invite Dr. Arvind Jaiswal sir and Dr. Pranav Ranjan sir also to please come on the dais? Next, Dr. Chatra Jadev, please.
Now I request Dr. Sabitab sir, Dr. Sabitab Kumar sir. Abhishek. I request Abhishek Kedia sir to come on the desk. Now I request Dr. Pratik Nisan to come on desk for moderating next session.
Thank you, and it is an absolute honor and a pleasure to moderate the session on different strokes in surgical retina at the VRSB 2025. I am Dr. Pratik Nishan from the Regional Institute of Ophthalmology. May I now welcome our enlightened council for the session, consisting of Dr. Subhash Prasad sir, Dr. Vidhata Vidhu sir, and Dr. Rajesh Agarwal sir. Okay, please come forward. May I also invite Dr. Shalabh Sinha sir to chair the session, because Dr. Padmaja Kumari ma'am has left for a tour. May I invite Dr. Shivani Sinha ma'am to start with her talk on thinking beyond vitrectomy in fresh RD.
Good morning, everyone. I would be talking on thinking beyond vitrectomy in retinal detachment. So this is a patient who has been on follow-up since 2019 after I had done scleral buckling. This was my second patient of SB who is following with me till now. So this is a case scenario where a 14-year-old male who sustained trauma by ball 5 days back presented with a vision of 618 with a nasal RD. So the first choice in this case would be very obviously a scleral buckle. So we went ahead with the scleral buckling, and this was on post-op day 7, a very flattened out retina in this case. So what is actually the principle of retinal attachment surgery? So basically it consists of 3 principles, that is localization of the break, retinopexy and tamponade. So how does vitrectomy works? It works by removal of the vitreous gel and all the tractional membrane, leading to intraoperative flattening of the detached retina, application of a retinopexy either in the form of laser or a cryo, and then placement of a tamponade either in the form of a gas or oil. So where does scleral buckling fit? Scleral buckling is a state of is an art, and it has got a long history even when vitrectomy was not there. So the most important thing in scleral buckling is a good IO skill. So it demands the surgeon's indirect ophthalmoscopic skill and a very good hand-eye coordination and analytical acumen. Analytical acumen in the sense when we have to place the buckle, we have to estimate up to what width it is going to cover, and in the lateral as well as the anteroposterior aspect. The procedure is specially demanding because we have to wear the IO, and it has a weight, and also we have to keep on bending to put in the sutures and to keep on looking for indentation. So in a vitrectomy, usually the surgeon keeps on sitting, but in buckling procedures we have to sit, we have to stand up, so it demands a lot of physical strenuous capacity also. So how does scleral buckling is fitting with the younger surgeons? So it is like we are veering away from the scleral buckling art. There are various reasons. One of them is because of insufficient training which is being provided elsewhere. And we have a perceived superior outcomes of vitrectomy, which may not be a case, true scenario. And also vitrectomy allows us to keep sitting, and it's a relatively comfortable position for the surgeon. So why to choose a buckle? So this is a snip from a meta-analysis where scleral buckling had a better final visual acuity compared to the PPV. And PPV is associated with a higher risk of cataract formation and iatrogenic breaks. This is obviated by the scleral buckling procedures. And at the end of the day, there is not much of difference between primary and final reattachment rates. So this again is a meta-analysis where superior buckling has been shown to be superior in terms of final visual acuity and occurrence of post-operative cataract in uncomplicated phakic RRDs. So a scleral buckle allows for earlier rehabilitation compared to vitrectomy because we do not need to remove any oil, or we do not wait for the gas to disappear. So and also vitrectomy leads to a faster resolution of fluid leading to metamorphopsia, whereas in scleral buckling, if we go by non-drainage, it leads to spontaneous resolution of SRF leading to a better better quality of visual outcome. So the question arises when to choose a buccal procedure. So young, phakic, high myopes, and in those patients where we have absence of PVD and in which we are suspecting difficult PVD induction and absence of high grade of PVR, and specifically the indentable breaks which are anterior to the equator, and obviously retinal dialysis. These are the subsets where we need to choose scleral buckling. So scleral buckling is relevant even in this era for the management of RRDs, and it is preferred in cases of young patients, von Witteris, atrophic retinal breaks, and subretinal gliosis. So this is a case where again a young male presented with a superior RD with a, as we can see, the break here. So this was a case which Dr. Anjali had earlier shown in her presentation. So we went ahead with the pneumatic retinopexy, and finally we had achieved a good anatomical and functional outcome. So why retinopexy? Why pneumatic retinopexy? So time taken is very less, and it has a very improved integrity of the retinal reattachment. So it has got a long-term visual acuity, superior long-term visual acuity results, and less vertical metamorphopsia, again because we are not going to drain it, so the anatomical results are better. So when to do a pneumatic, when to think about a pneumatic retinopexy? So macular breaks, other posterior retinal breaks which are not amenable to buckles, we tend to prefer pneumatic. And isolated tears, impending macular detachment, these are the cases where we need to think about pneumatic. So when not to do PNR? So like this is a very controversial, and therefore I have written relative contraindications, because the recent publications by Rajiv Muni said they have gone ahead with the inferior breaks also. But inevitably, if there is presence of higher grades of PVR, we need not do pneumatic, and also in cases of severe or uncontrolled glaucoma, and in cases of cloudy media, which is going to hamper our second stage procedures of retinopexy. So important consideration is consideration of one session versus two session. This can be choice of the surgeon also, and specific procedures where we need to do a steamroller procedure, where we need to have a two-session procedure. So the choice of the gas is mainly SF6 because we do not want a very long tamponade in these cases. And also C3F8 takes 3 days for the largest size to happen. But we need a faster expansion, which is provided by SF6. So one of the important things is the steam rolling technique, where we want the fluid to regress through the primary break and not come down and detach the macula. So we need to steam roll the patients. And one very important thing is proper positioning. If we are sure the patient is going to maintain then only we can go ahead with pneumatic retinopexy. If we are not sure that the patient is going to achieve a proper positioning, then we have to defer pneumatic. So the beauty of post-op patients in pneumatic retinopexy is that when they come to us, it just reminds us of the patients who had just had laser retinopexy for a retinal tear. So the take-home message should be a meticulous workup of patient is mandatory to choose the best suited surgical techniques for patients. And the evergreen buckling and pneumatic, they are there to stay, but not without a good thorough peripheral examination with indentation. Thank you.
Thank you, Shivani. I think one more contraindication you can add is a patient who cannot maintain position.
Yes, so that I told.
Yeah, so that wasn't there in the list,
yes,
because
yes,
there are few patients who cannot maintain positioning. And the other thing is that from the time we started doing these minimally invasive vitreous surgery, when the trocar cannula system came, it was basically the companies who pushed us to do more vitrectomies and leave scleral buckling aside. That is why we have more vitrectomies rather than scleral buckles. But all those people who have been trained by seniors who used to do more of scleral buckles and less of vitrectomies, those are the ones who still do scleral buckles. The younger people who are more exposed to vitrectomies rather than scleral buckles would rather do vitrectomy in every case than do a scleral buckle. But everybody, the young people should understand that a scleral buckle is much more safer procedure than a vitrectomy, especially in young patients, as you said. And the clear lens, we have to make sure that the patient maintains his normal crystalline lens for his proper age. 25-30 years mein, if you have to do a lens removal and put a implant, that's not the right thing.
And especially, sir, in more so in very young patients, like 6 to 10 years, children, especially buckle works like a wonder. So buckle is there for these patients.
Another contraindication pneumatic you should have written is the person who wants to travel by air.
Yes.
Regarding buckling, I would say that we have been trained mostly in buckle, because at that time the equipments were and the visualization system was not that good. So more and more patient, even the pseudophakic patient, even having bad vitreous, they used to go first for buckle. उसके बाद बताते थे कि if it doesn't settle, then we'll go for the another one. Abhi, I think that it is definitely, it has advantages in many places, like where you have disturbed vitreous and particularly complicated cataract patient where you tend to miss small holes which are there in the aura. उसके अलावा अभी क्या है कि this is era of glamour and social media actually. तो with vitreous surgery you tend to show surgery इतना बड़ा GRT ये वो 10 minutes, 20 minutes, 30 seconds, 30 ये वो थोड़ा सा वो भी hype है, but no, nothing against anyone, but definitely VR surgery is there to stay in many indications. लेकिन scleral buckle का तो role तो है ही. We still do in our center also still we have good percentage of patient undergoing buckling surgery.
Just to add, there is not the role. It's superior than vitrectomy. That is the
definitely.
We should be able to convey that message. In certain lot of situations, I mean, if we just demarcate the age bracket of 40, so less than 40, and they are way the outcomes, the overall outcome, everything is superior than.
That's the message. Abhishek, I would like to add one thing. It is the mindset, a barrier which we have set that below 40, above 40. In fact, as Shalabh has said that the patients who cannot afford to maintain the posture and all that, in presence of anesthetist, we can take the buccal surgery in even persons who are senior citizens, and they have performed well.
For buccalable position, I maintain that if you are putting gas, the patient post-operatively, very obese patient cannot maintain positioning.
Yeah. They cannot, obese patients.
They cannot maintain positioning.
The trend for all pseudophakic RDs is to go ahead for a vitrectomy. So, in your practice, do you still do buckles for a pseudophakic patient if there's a superior break?
Yes.
So, do you still do buckle, or would you go ahead with vitrectomy
no,
and gas?
I do a lot of segmental buckling. Just put
even
the
in
buccal,
the pseudophakic
yes,
patients. So
just put the buccal where the break is.
Yeah.
The retinal detachment, the whole concept is close the break. The retina will settle if you close the break. So
yeah,
if you are
but the
sure
trend
that
now has changed to in pseudophakic RDs, go ahead with primary vitrectomy with
because
gas or with oil.
People will tell you that post PPV you do not have any
complications.
Not complications. There's no change in the glasses. You should not be worried about the glasses. That's the least thing that you should be worried about. The retina should attach and the patient should get back vision with a lesser complication. Vitrectomy, you can always create retinal breaks, iatrogenic breaks. You may have a superior break and you do a accidentally you make a break in the 6 o'clock. Bina oil ke chalega hi nahi.
Another thing is the cost. Buccal mein, if somebody of that era is there, Naginder must be knowing that. And Sivender, when I joined IGMS, koi equipment nahi tha, nothing was there. But we started retinal surgery started with buckling. केवल 500 रुपया का खर्चा आया, बाकी सबके पास indirect था, cryo था. So that's another thing that it is very much cost effective also.
I just wanted to add that I've been using a lot of 42 bands now. That's working fantastically well, especially young patients. Just place a 42, you get 360 degree. You don't even need to do segmental. So this we have at least 20-30 patients now where we used only 42 band and they're doing very well.
Segmental versus 242 has its own role when we are
not
talking
242.
about 42.
Yeah,
but then we are arguing
it's a broader band than the 240.
2.5
versus a 360 degree peritomy. That is what we are talking about. I mean
360 degree peritomy, but that hardly matters. We're using glue
there's
now.
a lot of OSD and then we have very irregular astigmatism that patients come. I think
why astigmatism?
I mean, we are just not trained that well with the segmental buckling. I would always prefer a segmental buckle over a 360.
No, but this is new. Like off late, we've been using it, and especially for young patients, because they're doing well because you're getting 360 degree support without actually having to indent any one particular, especially post-trauma patients where we tend to miss dialysis and all that. These eyes are doing quite well.
Yeah, the only problem with the encirclage is the incidence of ocular ischemia. Dr. Ingrid Kreisig, I attended a few courses.
240 you are doing encirclage.
Yes,
the 42 in
42 is a broader
and in that there is one thing, madam. What we have to cut at the ends, what distance we have to cut the ends and do the ethibond. So that is very tricky, whether it is covering or not covering, and many times it is too much tightened and
too much because we are giving good support. Buccal height never is too much, but 2.5 it is almost, but more important is the thickness, it's not the breadth. The thickness itself is almost 2 millimeters. So the tunnel required is quite large. That's one technical challenge that we have while operating. Second thing is we have sleeves now even for that. Yes. Everything is with tunnel, no sutures.
Always better to use tunnels rather than sutures because of the suture related complications.
We are using tunnel only, sir. Yeah. 42 also works, sir.
It goes, sir.
So just one point I wanted to make. I mean, I think there is a very significant divide between the older generation and the younger generation between buccal and vitrectomy for retinal detachments. So I was trained at a place where both the things were being done, and while doing training, vitrectomy shifted from band, VR, oil in each case to vitrectomy with gas. So for most of my patients, pseudophakic patients, older patients, I would do vitrectomy and gas, and for me that seems to be the minimally invasive thing and least complication. It is the best for the patient as well, because you don't put any sutures. If you have not made a posterior retinotomy, you can just put C3F8, ask the patient to lie prone, and all the breaks are covered. So I think it's in your hand what you think is best for the patient. Buckling, of course, should not go out of fashion because buckling is a very good procedure, but then vitrectomy should not be like that. It always leads to complications. And
nobody is saying that it always leads to complications. Even with a scleral buccal, you can have complications. You can have a bad bleed that goes to the macula. You have subretinal blood there. So nobody is saying that neither of the two have nil complications. Both of them have their own complications. The only thing that I believe is driving vitrectomy, and Dr. Subhash also agrees, your ability to show it in the conference, your ability to show off that vitrectomy is more superior. But as the meta-analysis also shown by Dr. Shivani, scleral buckle, the visual gain or the the patient gains is better with the scleral buckle.
Both with pneumatic and with buckle, visual gain is better. There is no doubt.
So why not do a scleral buckle?
We are not talking about the visual gain here itself. We are also talking about the functional gain also.
Of course, functional gain only.
Yeah, so the quality,
specifically.
yeah, that is, I think, what she wanted to emphasize, right?
So in the interest of time, we will move on with our program. We now invite Dr. Abhishek Anand, who will be presenting on retrospective outcome of optic disc bit with scleral graft, outcomes of 3-year data. This presentation is being made on behalf of Dr. Manish Karn, who could not be here due to some family commitments.
No, I have not made the presentation. Dr. Manish only had made the presentation. He has provided me only 8 slides, and we'll try to look into those 8 slides. He had some personal family issues. So let's focus on these slides and let's see, because we all know that optic disc pit is a relatively rare condition. The prevalence is around 1 in 11,000, and these are generally young patients. So to convince them at a young age to undergo a surgery is quite challenging. So many of the patients that you will encounter will not be convinced for a surgery at a very young age, and generally this unilateral. So the other eye is relatively normal. So the main challenge is, if you look at the prevailing literature, very few case series are there which have crossed the 10 patients data. Generally it's around 5, 6, 7, 8. So we have around 11 patient data in the last 3 years that we have operated. We try to look for scleral patch graft along with an autologous ILM transplantation for autologous ILM graft on which the autologous scleral patch graft was placed, and try to plug the optic disc bit and look at the outcome of resolution regarding this. So we are focused on role of SPG in optic disc bit maculopathy. There are various surgical modalities which have been advocated, and not a gold standard exists. So it was a retrospective interventional non-randomized study, and these are all patients who had been confirmed diagnosis of optic disc bit maculopathy based on SSOCT, and the main ocular assessment were BCBA, IOP, slit lamp examination, Swept-Torch OCT was performed before and at each visit after the surgery. The pre-op best corrected visual acuity was, in the log mass there is a gain, a significant gain. I think there is some mistake here. But we look at this 11 patients data. We see on the right side, the middle of this, that most common location is the inferotemporal location. If you look at the age part, most are young. Only 2 or 3 patients who are around near the 40 and 50s. So we are able to convince most of the patients to undergo surgery. The pre-op, there was significant reduction in the gain, reduction in the CMT pre and post-op, and almost all our patients had a resolution of this. What is important in our study is that we use the ImageJ software to analyze what was the resolution pattern of the SRF and the IRF compared. So how did we do it? Is that you can use the ImageJ software, which is freely available, and then you can look at you can demarcate an area and look at so we evaluated the area under the curve for resolution of the thickness. So regarding the IRF, we created a center, and on either side of the 1000 microns, we created an area, and then we analyzed the IRF resolution and the SRF resolution separately. What we can see is that the SRF resolution precedes the resolution of the IRF, and also in patients who had very late resolution, the SRF and the IRF resolution also. We need to further extrapolate this data. The earlier or fastest resolution of the subretinal fluid was observed in younger patients, most likely attributable to the healthy RP. or more functional RP, in contrast to older patients or those with RPE dysfunction. So, in cases who are presenting with RP atrophy, which we can know on fundus autofluorescence, you should desist them or tell them beforehand that you will require a very long follow-up, and the resolution pattern can be quite vary. A few cases resolved SRF rapidly within the first few follow-ups, but on an average, the resolution time was around around 6 to 8 months. This study suggests PPB being the nucleus of treatment for optic disc pit maculopathy, along with scale patch grafting, as an effective adjunctive option to seal off and resolve the retained intra and subretinal fluid. Another dimension of the study suggests the fact that the healthy RP is must for active pumping out of fluid, mostly seen in young patients presenting with ODP. Our case series comprising a large cohort of ODP maculopathy. Patients treated with scale patch grafting as an adjunct to PPB represents the largest such study reported from this side. Thank you. So we can discuss more on optic disc pit maculopathy.
So all the patients get a nasal ILM flap?
So what we did was we created nasal to the fovea and ILM flap.
Nasal to the fovea.
Yeah.
Okay.
So it was a fovea sparing ILM peel. So we just transfer the vertical slit of the ILM, and then we try to flip it over the optic disc pit, and then during the placement of the scalp patch, we try to use this bed of ILM to stuff I think I missed one data. Out of the 11 cases, 2 had post-graft dislodgement of the scalp patch.
So wouldn't it be better to put the scleral graft inside the pit and then cover it with the flap?
So the idea of putting the ILM flap was, how did the idea came was like, if you want to ensure watertight something, you generally put a polythene or something like that and then ensure. Okay. So that was the idea, that if you use an ILM graft,
because it is thinner and probably will plug the smaller hole.
But to engage that scleral patch graft in that optic disc pit is quite challenging. That has been my experience. There is chances of dislodgement certainly.
What is the role of, if you can think on that way, that can you put amniotic membrane in place of scleral patch?
So all the things that can be put inside the eye have already been put. So we are not doing anything new. We are just analyzing whether a scleral patch graft. So there is one data from Arvind which has commented upon ODPIT and scleral patch. We also wanted to re-evaluate the same with an ILM bed. That was the whole study. Because
this is one of the modalities. There are so many modalities, and the outcome is not much different in all modalities.
So what we can understand is that if you look at optic disc pit, so if on the bed of the optic disc pit there is a glyotic membrane, and on this glyotic membrane is the vitreous which is attached. So overall pathogenesis is that this vitreous and the abnormal gliosis is transmitting the traction. So I think after doing so many cases that even if you do a good PVD and do a complete PVD, almost on, I think out of 100 cases, I mean, if you say 70, you find 70, I mean, around 70 to 80% of cases dysgliosis. And if you remove that vitreous attachment to that gliosis, it should be more than enough to resolve. So the main is to cut off that transmission of traction.
Yeah. So,
but do you think that the fluid, there are two sources of fluid also? Yeah. So the subarachnoid fluid also.
So that is controversial. But then the latest hypothesis is there is a difference between the CSF pressure and the intraocular pressure. Now, how to hypothecate is that we have found silicon oil migrated to the CSF, right? Yeah. So for that, something must have caused a negative suction for the silicon oil to break from its parent bubble and to go into that. To generate that amount of suction, there has to be a variation of, I think, 14 to 16 mm of Hg. And that difference can only be achieved if there is because the IOP fluctuates that much. So that is how we can explain that how did that silicon oil got dislodged from that its parent molecule, big bubble, and then it dislodged to that CSF.
Did you have any failure of these cases, like the fluid did not resolve despite the surgery?
Yeah, so we had one case which was very interesting case, because so there was a 50-year-old female who was primarily misdiagnosed as a case of glaucoma, one-eyed female, and she was diagnosed as a case of glaucoma who had already underwent a phacotrap, and we didn't want to operate her, but she was so adamant coming to us that we had to operate her. And because she was one-eyed, I didn't want to put a scale patch graft in that patient. So I just did a PVD. That patient didn't resolve. In fact, she worsened. So after 3 months, because we kept watching, but she kept worsening, and after 3 months, we asked her that if you allow us, then we can go for a scleral patch graft. I don't know about the outcome, how it will be. She consented for the surgery, and then she did resolve post-scleral patch graft.
So all your cases basically resolved with the scleral patch graft?
But the resolution period is pretty long, up till 11 months.
Sir, have you tried laser?
No, I have not tried laser.
One of the findings that probably you have published is that with the scleral patch graft, the RNFL thickness decreases over time.
Yeah.
So that is a novel finding that the house should know.
But then because there is when we are measuring the RNFL, there is already presence of fluid. So the reference is a bit biased, because it will reduce, the fluid will reduce, and the RNFL thickness will tend to, because there are some amount of fluid matters which can.
We are not sure whether that is because
we are also trying to analyze that also.
The actuality, or whether that is a segmentation error. Okay. Thank you so much, sir. And now we move on to our third talk by Dr. Bhulesh Raya, advancements in VR surgery.
So, thank you, Pratik. I am going to talk on recent advancement in VR surgery. So first one, like in era of vitrectomy, usually everyone is being trained or is using 25 cutter
Is it a
mostly.
sponsored talk?
Yes, sir. It is a sponsored talk by Alcon. So when we are using 25G or 23G mostly, and what we feel, there are three issues which we can face. One is increased surgical time because of luminal limitations of small gauge vitrectomy systems, or sequential cutting and then aspiration of vitreous. Then second one is fluttering of retina because of retropulsion or pulsatile traction when jerky closure of port opening is there. That causes iatrogenic breaks in bullous detachments we regularly encounter. And one is complex membrane surgeries. As we saw yesterday, Dr. Sangeet Mittal sir saw a very excellent diabetic vitrectomy case in which he used forceps. Few surgeons, including me, prefer to use cutter itself rather than using forceps to reduce traction and reduce iatrogenic breaks and subretinal heme migration. In those cases, a vitrectomy cutter which has a shorter tip to lower edge of port distance works very well. It goes beneath the membrane and cut very nicely. On these three things, Alcon worked very nicely and developed this hypervit cutter. So its tip and port is shorter than our conventional cutters, and it gives the surgeons opportunity to go beneath membrane very near to retina and segment membranes very easily. Regarding vitreous removal, it has dual edge of cutting in the port itself, port shaft. So it gives us 20K cut per minute, and cutting and aspiration has two different pneumatic drive channels. So these are independent. I mean, it is not a sequential cutting then followed by aspiration, but two processes two procedures go on simultaneously. So vitreous removal efficiency has also increased in these ultra width cutters, hyper width cutters. Now one more thing, that retropulsion and pulsatile traction, what we see in our other cutters because of eddies current formation at the tip. This is seen very less as per some studies in hyper width cutter. Just it is my observation. I tried to choose 3 similar cases having 3 to 4 clock hour bullous RDs with multiple HSTs, and first 2 cases were operated by ultra width cutter and last was operated with hyper width. So you can see the fluttering of retina, although there can be some surgeon biasness in this video. We need further more studies and observational studies to establish this fact, but I felt that retina flutter was, so you can see retina flutter is there. And now this is hyper width cutter. Vacuum was 500 in both scenarios, but cut rate was 20K in hyper width and 10K in ultra width case. In all cases, we know this any 2 case cannot be similar, even if configuration is same and scenario is same. But even then, I personally felt that fluttering of retina was less in hyper width vitrectomy. So hyper width excels over all these 3 points: the bevel tip design, continuous port opening, and high cut rate and superior fluidic stability. So after that, yesterday we were discussing, Shivendra Sai sir suggested DDMS in one talk. So few surgeons are reluctant to use DDMS or Finney's loop to induce pinching effect, pinch of ILM. We all most of us prefer to pinch ILM with forceps only and start our ILM peel. Like I use, most of us, including me, prefer not to use PFCL most of the time because of its PFCL related complications. Even in macular hole RD cases, I try to avoid PFCL. In those cases, for getting a pinching effect of ILM, we usually need to indent our forceps up to some extent in retina. That sometimes leads to superficial pinch, or that sometimes leads to deeper pinch, leads to iatrogenic bleeding or iatrogenic breaks also. So this Sarskin forceps developed by Alcon has brought with some rough surface which is laser ablated micro serrations. So it gives a little rough surface at the edge, and apart from this, it has a pinching capability with open forceps also. I mean, it can be used just like DDMS or Hin's loop. We can open forceps and stroke to induce ILM flap. It has been seen to reduce tissue trauma and is to continue with peeling. So apart from these two, now we are moving ahead with ergonomically comfortable visualization systems like Ingenuity, RTO 800. All yesterday, Padmaja ma'am suggested us to go ahead with this deferred life surgery and try with 3D head-up visualization system. So all these are ergonomically very comfortable for surgeon. We don't need to keep stretching our neck for hours and hours. Even in complex cases, there are variable depth perceptions. Apart from this intraoperative OCT, then disposable cryo pen is being tried to avoid intraoperative disturbances due to cylinder. Like most of the time we feel that gas pressure is not coming in cryo probe, and all those sterility issues are there because of there is a limited movability of system of cryo system. So these cryo pens are single use disposable handheld instruments which can be easily transported in OT and can be maintained in a sterile way to finish our cases. Then FDA approved gene therapies are also being tried, and stem cell based therapies are also being tried for AMD and Stargardt disease. Methotrexate has also been used, as yesterday we saw Dr. Vidhata shown in one case where he used methotrexate for PVR prevention in old RDs. Then now this is the port delivery system with ranibizumab is being tried. Although incidence of endophthalmitis and surgical complications are there, so still it is in trial phase and in observation. So this is a never ending journey of science. No book, article, presentation can complete it. Science is going on, and we are just learning and learning and learning. Thank you.
Thank you, Dr. Bhulesh sir, for taking us through all the bouquet of innovations that has recently been introduced, and definitely no book or science can complete the science. That is the truth. One of the points that were discussed yesterday is how you control the turbulence that occurs due to the cutter, whatever machine you have. So do you think the ultraviolet offers a definite advantage, or is it experience or surgeon?
Actually, I have limited experience for commenting over this, but still I just tried to compare with similar parameters, and I could feel there is a little advantage of hyperweight cutter over ultraweight.
Hyperweight over ultraweight and ultraweight over conventional?
Yeah.
Okay.
See, it also depends upon the machine that you are using. So I've been using the mid-lab cutter for many years. In fact, I still use only the mid-lab cutter. At 7,500 to 8,000 cuts, the retina hardly moves with the mid-lab. And that kind of stability I've never seen with Alcon. So I was surprised to see this, even with the ultraweight and the hyperweight, the amount of the retina moving. With 20,000 cuts, the retina is still so mobile. That never happens if you are using a mid-lab 8,000 cuts.
Actually, I think that was because of 500 vacuum, sir.
Yeah, so
just for comparing these two things, I kept that parameter.
Basically, the problem is that the Alcon system requires a higher vacuum to remove the same amount of vitreous than any other machine.
Yeah, that
yes.
That is also
so the turbulence is not only because of the cut rate, but also the higher vacuum that is there. So that is why they talk about the sphere of influence and all those things. Those are the problems with the machine. जिसको एक term दे दिया गया है कि the 25 gauge will have a smaller sphere of influence and things like that, and they are confusing our minds. The moment you shift to another system, you will feel the difference. 8,000 cuts, 250 vacuum, the retina hardly moves with a mid-lab cutter. And so much movement with the 20,000 cuts.
एक चीज़ और बोलना है, वी आर प्राइवेट प्रैक्टिशनर्स. एक टीवी में ऐड आता है, चलता कितना है. तो मेरे क्लिनिक में शुरू में एक्यूरेस आया 2,500 कट, एंड एक जो किट खरीदते थे दैट मतलब 10 केस आराम से चलता था. उसके बाद कॉन्स्टलेशन आया हमारे यहाँ तो 5,000 कट वो भी 7-8 केस चल जाता था। उसके बाद अब लोग फोर्स कर दिया कि 10,000 कट, वो 3-4 केस जाता है, उसके बाद काम तमाम। 27 गेज 1-2 केस फोकट में मिला था शुरू वाला, सारा टेढ़ा हो गया। तो सवाल है कि इट इज ऑल द हाइप, सारा कमाइए और इन लोग को झोंक दीजिए।
It's a very important point that experience tells us is how you tame the lion, and the longer the whip, the easier it is to break. Right. Thank you so much.
At the end, it is all depends on surgeon.
Yes.
Yeah, thank you so much,
Dr. Chaitra, I
Dr.
would like to know from you, how often are you using methotrexate in your vitrectomies for PVR? Yes.
I'm not really used much. I don't have any experience of using methotrexate. It's primarily for prophylaxis, so I don't have much experience. I think Arvind Goop have published about it.
Yeah, so I was also very surprised that Gaurav Shah in the last VRSI conference, he said that they in the US are using methotrexate even in infusion for all their RDs. I mean, is that an overkill?
Yeah, I think so. Because our patients are doing pretty well even without the use of methotrexate. Of course, there will be a one-odd patient with extensive PVR that even methotrexate can't save. So I still don't have any experience with methotrexate.
Sir, I have spoken to Dr. Naresh from Arvind, and he and one of his fellows, they are having pretty good experience. So they have said me that in all cases of PVR, they are using methotrexate and it is giving wonderful results.
No, but what grade of PVR? What is the grade of PVR in which you will always use methotrexate in the infusion, or is it post-operatively? Are they using an infusion also?
No. One of his fellows is using it in infusion, but at Arvind they are using it post-operatively.
Sir, we had a pilot study of 10 cases around. We injected intravitreal methotrexate at the end of surgery, under vial. So it's 0.2 or 0.4 ml we inject at the end of surgery, and we had a very good results in all the PVR CRDs.
Actually, in methotrexate use in PVR RD cases, we need to see outer layer response post-operatively. I feel, and few literatures have shown that immunosuppressive or immunomodulator drug used intraoperatively can lead to apoptosis of outer layer photoreceptors also, which are very precious for those cases. So even if we achieve anatomical settlement of RD and less recurrence of RD due to PVR, we are not going to offer anything visually to patient.
Yeah, so I think somebody in Disha, Boral, Dr. Boral uses triamcinolone. Whenever he does a retinectomy, he uses triamcinolone in the area of the retinectomy, and probably that is safer than using methotrexate.
It is exactly safe. That is what his talk was. That you don't need to worry about anything regarding the concerns that Dr. Voles has raised. That is extremely safe. But the point is that whether in our scenario where we generally don't get that much, our fresh cases comprises only of 15 to 20%, we have a preponderance of advanced PVR changes. So is there a role in this? I think Arvind, they are, what sir was saying was that they have injecting 3 times, one just after conclusion of surgery and after 2 more times. I don't know the time frame in which they were injecting, and it is absolutely safe regarding this, the concerns regarding the photoreceptor layer and the RP. Regarding triamcinolone acetonide, we all know that once the triamcinolone acetonide goes subretinally, it causes RP atrophy, and there is a risk of RP atrophy. So if by mistake it goes submacular, then obviously we all have experienced that sometimes it goes submacular also. It causes RP atrophy. Triamcinolone crystals.
Dr. Boral uses it at the edge of the retinectomy. So once he's done the retinectomy and flattened the retina, before he puts the oil, he puts triamcinolone there.
So how do you maintain the triamcinolone there at the edge?
It sticks. I have also tried it. It sticks.
So you are leaving vitreous there, right?
No, you're not leaving
vitreous there.
That is how you're
sticking the...
No, it sticks to the retina and to the choroid. It sticks.
So the small fold of retina that occurs at the edge of the retinectomy, you try to lock that triamcinolone there. a streak of triamcinolone, a streak of bubbles of exactly. Thank you so much, and we move on to the next talk. We do have a few minutes of time before we break for lunch, and we have Dr. Pooja Sinha presenting on retinal ischemia following anti-VEGF injection. Are we lost in the woods?
Our two national faculty for today, Dr. Rupakanti Biswas and Dr. Vishal are en route from Amritsar. They've just landed, and they'll be on the way to this presentation area. So I'll just sneak in my talk, and then after lunch we can accommodate the talks by them. So I'll be speaking on two cases which I recently encountered, which didn't have a very favorable outcome, and that is the reason why I wanted to discuss them in this podium. So my first case was a 72-year female patient who complained of diminution of vision in the right eye for 1 month. She was a known hypertensive for 10 years, controlled with medications. There was no cardiac history. There was no history of fever. There was no COVID history. She was the wife of a prominent politician, and thus, she had come to me for a expert retinal evaluation and treatment. So the vision in the right eye was very poor, counting finger of 2 meters, and left eye was 6/18. And you can see that the fundus picture showed convoluted retinal vessels and blot hemorrhages in the macular area. So I confidently made the diagnosis of branch retinal vein occlusion. There was on OCT, there was subretinal fluid and convolution of the inner retinal layers. And I told her that we will go ahead with an anti-VEGF eccentrics, which will be given in the right eye. But to my dismay, when she came after 15 days, there was a sudden flurry of cotton wool spots all along the peripapillary area and along the arcades. The blot hemorrhages had increased, and definitely it signaled that the ischemia in this retina had increased much fold. On OCT, the fluid had decreased, but there was a wedge-shaped hyperreflectivity at the level of the inner nuclear layer, as you can appreciate in the OCT picture. So FFA showed hypofluorescent patches in the posterior pole. There was leakage of dye from the capillaries, and there was non-perfusion of the vessel along the inferior arcade, as you can see on the FFA picture. There was mild capillary loss at the level of the deep capillary plexus, but not much of ischemia that I could make out at this point on OCTA. So I got the peripheral blood profile done, which was normal. Carotid Doppler was normal, and the patient was started on systemic steroids after consultation with physician, because I thought maybe there was an inflammatory component to it. However, the vision improved marginally to 6/60. Though the foveal contour was good and it was looking nice on OCT, the patient was not very happy. This was the case too, a 67-year male patient, hypertensive on treatment. There was no history of hyperlipidemia. There was no cardiac history. There was no history of diabetes. Vision in the right eye was counting finger 3 meters, a classical dot and blot blood and thunder appearance with cotton wool spots and hemorrhages. This was the OCT picture, a massive intraretinal fluid cystic spaces and small amount of subretinal fluid. Foveal contour was completely obliterated. But however, after 2 injections of eccentrics, vision only improved to 6/60. The cotton wool spots here had increased as well. And if you see closely, a fibrin ring had formed in the macular area, which was probably the cause why the reason why the vision was not improving. So this was the OCT picture, and you can see this hyperreflective shadows in the deep retinal capillary plexus. And this was the left eye, which was normal. So the most probable diagnosis that came to my mind was a post-anti-VEGF injection related paracentral acute middle maculopathy, PAM, in the setting of coexistent retinal vascular disease. There was a sign of deep retinal ischemia exacerbated by intravitreal anti-VEGF injection, and there was infarct of the inner nuclear layer, and it could be an acute macular neuroretinopathy, or AMN, where we see hyperreflective lesions at the level of the outer nuclear and the outer plexiform layers, along with disruption of the ellipsoid zone. And these were the 2 case reports that I found in American Journal of Ophthalmology, which I have quoted here.
So what could be the possible explanation of PAM post anti-VEGF injections? When I did a review of literature, these were the possible causes. A sudden increase in intraocular pressure affects the blood flow in the pre-capillary arterioles of the deep capillary plexus. There could be a subclinical intraocular inflammation in these patients, which is causing ischemia and then the obvious cotton wool spots which were appearing. And VEGFs, and that VEGFs are vasodilators, so their antagonism might lead to decrease in the caliber of retinal capillaries and resultant ischemia. So thank you so much, and I would be happy for some guidance on my cases. Anyone wanted to add some points?
So
Sir.
Dr. Padmaja ma'am, the first case and the second case, I think they are two slightly different cases. The second case already had cotton wool spots, but the first one didn't. And probably since we don't do a OCTA for before we do and give an anti-VEGF, I think there was already retinal ischemia to begin with, and that got worsened over time. It was not the injection to blame. What is your take on the first and the second case?
I also completely agree, because the amount of ischemia, we are not really quantifying whenever we see these cases. We make a diagnosis and we give injection as a protocol. Yes. But we all know that all the venous occlusions, the visual acuity will not correspond the similar way. So this is cases where actually sometimes ERG also can give, if it is available, sometimes can give some quantification that how much ischemia we are able to make it up. But cotton wool spots itself is an indication of significant ischemia.
So that is what my worry was, that why was the ischemia increasing?
Yeah.
There was ischemia, we understand, but why did it exacerbate?
So the 7-up study, whatever that anti-VEGF and followed by ischemia, it was more in terms of foveal avascular zone disruption and in the macular area. I think you did an FFA also, right?
I did an FFA, yes.
It was not very clear cut where was that, the dropout or anything like that.
There wasn't much
qualitatively we could not find out
dropout
anything.
areas, so that is why.
The FFA actually was just one frame.
Yeah.
We didn't see the full
frame. But
frame.
I went through all the frames.
All the
so
frames.
It was not like this was the FFA.
I'm thinking it is more about underlying disease process rather than anti-VEGF probably injection related.
Yes.
Okay, thank you.
So that brings us to the end of the current.
No, there's one more. I would like to invite Dr. Chaitra to deliver her talk on retinal manifestations in hematological disorders.
Schedule a little bit so we have time for Vishal and Rupak to speak after lunch. So this is my second talk. Just put a picture of the retina. Can I have the slides, please? Yeah, so I put up a picture of the retina to show you that it's the only part of the body where you can visualize the nervous and the vascular tissue in a native state, without any invasive maneuvers, without any blood draw required, without any radiographic imaging. You can just see all the blood vessels so clearly, which is why retinal surgeons are sometimes the first point of contact for more ominous systemic conditions. And we need to be aware of some of these rare conditions as well, because missing them could actually be fatal for some of our patients. So let me just go through quickly. This is a patient that I saw a couple of weeks ago. 80-year-old male came with gradual painless blurring of vision. He's a hypertensive for 10 years. He'd been operated for cataract in both eyes before. Now if you look at the fundus picture, the right eye looks quite normal. In the left eye, you see multiple intraretinal and preretinal hemorrhages along the superior-temporal arcade, with a hemorrhage at the fovea as well. So one would think that probably it's a vein occlusion, but it looked a little unusual to me. I said, let me investigate him for more. And with any vascular occlusion, we do send them for routine blood investigations, a complete blood picture, and all of that. So this was the OCT, right eye normal, left eye you can see the intraretinal and the preretinal hemorrhages, and then you can see the hemorrhage of the fovea as well. So when I sent this patient for investigation, it came out that he had myelodysplastic syndrome. So had we, dwelled upon it and not sent him soon enough, we would have missed a very serious condition. So we need to be aware of retinal manifestations of hematological disorders and how soon to refer them, why we need to refer them, and what do we as retina surgeons need to actively do, because most of these conditions, just treating the underlying pathology will make all these findings in the retina disappear. Now, what are the typical findings that you see in these patients? Retinal neovascularization should not be confused for diabetic, PDR picture, because some of them might have coexisting rod spots. Some of them could be very simple for a low-grade anemia, or it could be as bad as a leukemia. So we need to be again cautious. Retinal hemorrhages may look very innocuous, but they could again have some serious underlying condition. And then we see serious detachments, NSDs, unexplained hard exudates, cortical spots, and disc edema. Disc edema again should not be confused, because you can have leukemic infiltration of the disc. So that's something that again you should, in an atypical picture, think of other underlying pathologies. So beta thalassemia is quite common. It's an autosomal recessive hemoglobinopathy. It causes microcytic hypochromic anemia. And it's basically a quantitative defect of the hemoglobin synthesis. So what you see here is not only a manifestation of the disease itself, but you also could have iron overload in these patients due to multiple blood transfusion that can also cause changes in the eye. So the typical retinal findings that you will see are pseudoxanthoma elasticum or PXE-like and non-PXE-like findings. So in this you see pudy orange, you see angioid streak, you can also see retinal hemorrhages. Other manifestations are RP changes, retinal edema. Sickle cell disease, again we are all quite aware of. It's a group of hemoglobinopathies. It's inherited in an autosomal codominant. And basically it is characterized here again by two components, hemolysis and vaso-occlusive crisis. Again, we should be very aware that we do see certain patients, it's not as rare as we think it is. Not common in Indians, but it should still be there in our thought processes. So according to the Goldberg classification, you can peripheral arterial occlusion, tortuosity. In stage 2 there is hairpin loops. Then you see the CFAN classic neovascularization, BH, and TRDs and rhegmatogenous RDs. So if you see here the typical findings, you see silver wire vessels, and then you see the salmon patch hemorrhage. You can see this black sunburst, which is basically round chorioretinal scars, and then iridescent spots and CFAN neovascularization, and also autoinfarction is seen in these patients, which is quite typical. So this is just a representation of how CFAN neovascularization occurs, and it's most commonly in the superior temporal quadrant. So this is the hemorrhage there that you can see, and the late phase angiography that shows leakage corresponding to the neovascularization. These are some rare conditions such as thrombophilia and hyperviscosity syndrome. Again, we need to be aware of them because they can cause ischemia, and again not to be confused with other vascular conditions. Most common finding here is retinal vein occlusion, and plasma dyscrasias, Waldenstrom macroglobulinemia is rather common. Most common manifestation is venous stasis retinopathy, which can again lead to RVO and then retinal hemorrhages, exudates, and finally also see serous macular detachments. Hyperviscosity, you see this picture with multiple flame-shaped hemorrhages and with multiple myeloma. I have a patient with multiple myeloma who was diagnosed so late. He was again a diabetic patient with pre-existing DME. I kept injecting anti-VEGF, and it was such an atypical macular edema. It just didn't go down, and then I thought, let me get a hemato-oncologist's opinion, and it turned out to be multiple myeloma. He went to Tata Memorial, and he's quite okay now. But vision somehow doesn't come back to normal. So this is some of the findings that you see, CRVOs and venous bleeding. These are some of the conditions that are associated: hyperviscosity, polycythemia, leukemia, severe hyperlipidemia as well. You can see dehydration. Hypercoagulable states, we need to be aware. You can see anticardiolipin antibody syndrome. I'm just going through all the conditions because we tend to forget them, and it doesn't come into our mind when we are handling unusual cases. You can see ophthalmic artery occlusion and infarcts as well. This was one of my patients who had this unexplained peripapillary bleed, sent him for investigation, turned out to be immune-mediated thrombocytopenia. So again, the hematologists are definitely very important in managing these patients. Bleeding disorders, hemorrhages, you see all these findings, and most important is that handling the underlying pathology takes care of all these findings. DIC, we see both thrombotic and hemorrhagic phenomenon, and this needs definitely an immediate referral to hemato-oncologist. Anemia findings we are all aware, leukemia we are aware, but like I said, you see improvement in or resolution once the treatment is given appropriately. So like I mentioned before, optic nerve involvement, especially with relapse, it could be a very common relapse site. So early diagnosis is fundamental with the relative scans. This is again an interesting patient with CRAO, with cilioretinal sparing in a patient with leukemic, he was a leukemic patient, you know, vision was good, but when I saw the retina, it was so scary, immediately sent him and turned out to be leukemia. So venous stasis, this patient again had venous stasis retinopathy, leukemic patient, came 1 month later with CRVO. So he had everything from CRAO, optic nerve, disc swelling, and then subsequently CRVO as well. So how has my management changed is that I tend to address these patients. This is a 56-year-old Indian male, my last case. Followed up for almost 2-3 years. He was on my treatment for NPDR with edema. He came back with worsening of the edema, and you can see those hemorrhages there, very unusual. So I thought I'll send him for a workup. Diabetic status had not worsened too much. Can any of you guess what it could have been? CML? No, it's something that even I had never heard of. It is HIV associated thrombocytopenia. Imagine, I mean, I never had thought something will happen. So first thing came was thrombocytopenia, and when they went on to investigate the thrombocytopenia, it turned out that he is retrovirus positive.
And those dark color hemorrhages, no? That is the clincher.
Key check, yeah. So I mean, it's the first time I saw it. Such bad edema, all of a sudden, sugars are under control. So then treated him, he went on to receive a cocktail of intravitreal bevacizumab, ganciclovir and dexamethasone, and you can see the response. So this was at presentation, and 3 months follow-up visit he came like this, and after treatment with, he was put on heart of course, and ganciclovir intravitreal, he is doing very well. So to conclude, more than 80% of our retinal diseases are due to an underlying systemic pathology. Ocular findings may be the first presentation in identifying a systemic condition, and whenever we see something unusual, please investigate and refer early. We could be saving that person's life. Thank you so much.
Thank you, Dr. Chaitra, for this enlightening talk. And you know, while you were giving the talk, I kept going back to what my father used to tell me, that what you're seeing in the eye is just a part of the disease. It's not the entire disease. And you must always consider the eye just giving you that window to see the entire body. So don't forget the body, just don't treat the eye alone.
Absolutely.
And you know, for those who don't come to conferences or just give their talk and run away, this is so important that every conference, Dad used to always tell me, that even if I learn 2% from every conference and I can go back enriched by that 2%, it helps me to treat my patients better. So I think the importance of conferences is just not to learn something new, but also you get reminded. She, you know, enumerated all the various diseases, and probably we forget.
Yeah.
We forget. We just completely forget about these diseases. So conferences also basically remind you of those things that you learned when you were doing your PG or your post-graduation, and how important it is to learn those things or be reminded of those things. So thank you so much.
Thank you.
Ma'am, just...
What about the? 2% ही दिमाग में जाता है, 98% थोड़ी ना दिमाग में जाता है.
Yeah, Ruchi,
just one point I wanted to know. Why did you inject ganciclovir in the last patient? Intravitreal.
Was advised by the UVA department. They thought that maybe there's an inflammatory component, infective component. I don't know. I was happy just giving bevacizumab, but they were worried that some inflammatory or infective component might worsen. We've never given. There's no literature.
Because HIV associated thrombocytopenia, ganciclovir not.
No clue. This was advised, and they gave DEXA again to reduce the inflammation. Yeah, but
okay.
there was no CMV, there was nothing else, but they did feel that there is some amount of vitritis. Maybe that's the reason why they wanted to give it under the cover.
CMV or something along with it.
Yeah, but there was nothing, none of the findings of CMV were there. But good for me that he's doing well. He's still on my follow-up, and no recurrence of macular edema. That was a crazy, finding. I never expected when he came back with an retrovirus. Unfortunately, his wife is also positive, but at least we got to know soon enough. Yeah, thank you.
Thank you, ma'am.
Thank you so much, ma'am. And it brings us to the close of the session. It is my pleasure to invite Senior Ophthalmologist Dr. Shalabh Sinha, sir, Dr. Soni Sinha, ma'am, and Dr. Shivendra Sahai, sir, our President-elect, to hand over mementos to the speakers and our chairpersons. So, memento to be given to Dr. Subhash Prasad, sir. A memento to be given to our very senior ophthalmologist, Dr. Nagendra Prasad, sir. Kindly come over. Dr. Rajesh Agarwal, our chairperson, or member of the Enlightened Council, I should say. Dr. Bhulesh, sir, our speaker. And Dr. Roshan, sir, who did not receive the memento in the morning. So we handed over right now. Thank you so much, and now we break for lunch.
sir, sir. Yes, ma'am. Dal is good, really good.
बढ़ा लीजिए। कैसा चाहिए आपको?
कुछ चाहिए नहीं, आप हटा दो।
आप इसमें डाल सकते हैं।
अब डाल दीजिए।
I'm Dr. Punab Ranjan, sir. I was in LGPI in 2002. At that time, Dr. Chandrasekhar, Dr. Ravi Thomas, you were there.
I was there.
Yeah. So I had gone there for the photoemulsification training program.
Okay.
That was a 4-week program.
Right.
And after that, the refractive surgery suit also I attended that training schedule. So a lot of good memories about the place, the hospital, about UNI. Dr. Sangwan was there, Dr. Ravi Thomas, you were there, Dr. Chandrasekhar. I think Dr. Chandrasekhar at that time probably was the director. So my training schedule was under him.
बहुत बढ़िया. Now become a little bigger, थोड़ा बढ़ गया है.
ना अच्छा था उस समय even then it was very good.
Why do you get it?
We'll be starting, attention everyone, we'll be starting our post-lunch session in 5 minutes. So requesting everyone to, wind up the lunch. And I would request the moderator and the enlightened counsel for this session to finish their lunch, please, and join us on the podium. Dr. Shalabh. Sorry to rush you through lunch. We just have another 5 minutes, please. We have national faculty who have to take their flights. So please requesting everyone to settle down. The national faculty have their flights. So, and it will be a very enriching experience for us to listen to their talks. Those who are still eating can take their places, sit down, and but please, in 5 minutes we'll be starting.
So we are starting with the post-lunch session. Yes, I would like to now invite the Enlightened Council, Dr. Shiven Sai sir, Dr. Pranavanjan sir, Dr. Satyajit to join when he arrives. Dr. Vivek, please join on the stage. So the first talk of this session, the retinal potpourri, will be delivered by Dr. Padmaja, and Dr. Pooja will introduce Dr. Padmaja once again.
It's an absolute honor and pleasure, along with a lot of happiness, to welcome Dr. Padmaja. She is a very dear friend of mine. We did our fellowship in Shankar Nitale, Chennai way back in 2001, and since then we've been in touch. And she is a very prolific vitreoretinal surgeon. She is the head of teleophthalmology in LV Prasad, Hyderabad, and she is doing a lot of work in medical retina as well as surgical retina. So today she'll be talking to us and taking us through her experience and her journey in teleophthalmology in LV Prasad, Hyderabad, how she has evolved it, and how we can benefit, our patients can benefit from it, both in Patna as well as in the rural outreach. So over to you, Dr. Padmaja, for your presentation.
Thank you, Pooja. In one word, I can say Patna visit, maja aa gaya. Means it's an absolute honor to be here and interact with everyone, both younger and older, every generation. Thank you so much. Yeah. So let us look at teleophthalmology innovations in our network. So when we look at LV Prasad Eye Institute is a 38-year-old organization. We are present in around 275 locations and in 4 Indian states, and also with a presence in Liberia, Africa. So before pandemic, our teleophthalmology was mainly connected from the 275 the primary eye care centers, which are connected to the tertiary center. But after the pandemic, we call it as a LVP Connect, which is a mobile platform and an app platform, where we are able to now connect all levels of care through teleophthalmology. And since June 2020, this model is actually connecting entire pyramid. And in a word, we can say teleophthalmology is like a healing, as per WHO, is healing from a distance. It's a virtual patient care. And when we look at, since June 2020, we have reached around 500,000 teleconsultations, in which the primary is a majority, where the vision technician assisted teleconsultations, and secondary centers are where our doctors are present and we connect to tertiary ophthalmology. And at tertiary, where we are able to do various subspecialty care through standardized guidelines and indications. And also it includes retinopathy of prematurity and diabetic retinopathy and home care, where we can reach disabled and also geriatric patients who cannot come to the hospital. And tele-rehabilitation is again another unique place where we are able to do the teleconsultations. So all this was possible because of the first innovation, that is India, where we are able to have digitization and electronic medical record infrastructure. And way back in 2014, we have invested in electronic medical record, and that paved the way to create teleophthalmology system during the pandemic in the need of emergency. And we all know very well there are smart mobile phones both in rural and urban areas, and we have one of the best probably system where you can even get Mungpalli se leke Banaras sari you can get with a Google Pay. So we have digital payments, we have excellent internet connectivity, which we can be proud of as an Indian. It doesn't exist anywhere in the world. So, and when we look at the workflow in the primary network, what we see is that where we have our vision center and where vision technician will be there, who are actually local trained rural population, who can do 3 R's, that is they can recognize, they can do refraction, and they can refer appropriately. So the patients visit the vision center and their images are captured. Image is essence for teleophthalmology. A good quality image is equal to good virtual patient care. So those images are captured. Through cloud network, the electronic medical record, the images are transmitted to the command center, that is at the tertiary hospital, tertiary center, where the images are reviewed and proper e-prescriptions are delivered to the patient. Similarly, at the tertiary, we have an LVP Connect platform, which is the doctors can access the platform both on mobile as well as in the computer, where all our patient care every week we have a dedicated 2 to 3 hours we dedicate to virtual patient care, where the patients, our follow-up patients who are being operated, probably a partner patient will come to puja, but I will talk to the patient, see what happened to them, and also new patients who want to take second opinions after uploading the reports. So this is the tertiary platform. And it's important whenever we develop a platform, it's important to recognize standardized guidelines in terms of what are the teleophthalmology, what are the conditions that can be done by teleconsultation. So we have defined these things. So that is where it's important that standardized guidelines should be there. What can be done through teleconsultation, what cannot be done. And similarly, as I said, image is essential to promote the quality of teleophthalmology. We introduce a contest every day called Picture of the Day, where the technicians take pictures in the primary eye care center. The doctor who does the command center teleconsultation chooses this picture of the day. And this picture of the day is actually an essence in terms of importance, essence in terms of improving the quality, and this will be posted in the same day in the WhatsApp groups so that it will be a fellow learning experience. And another second innovation is the referral color coding. Through electronic medical record, what we have done is we introduced a simple color coding called red, green and yellow. So red means as soon as the doctor sees the patient and he says that this is an urgent referral, he will code as a red referral, and that will flag simultaneously in the vision technician's tablet, and he can immediately prompt the patient to next level of the care. And we also track these red referrals. Similarly, yellow is a semi-urgent referral which requires the conditions which within 1 to 2 weeks, and green are the conditions which can be managed by teleconsultation alone. So in a nutshell, on a daily basis, we see that 80% of the conditions are actually managed by teleconsultation alone at the vision center. Only around 16% require actually referral to the next level. And this is an example of a prompt red referral, and the case is a very clear-cut example of a congenital glaucoma which was picked up and through prompt referral, and it was referred to tertiary center immediately, and now the child and mother is a example how a prompt red referral could save the eyes. Similarly, this is a picture of red referral where primary eye care teleophthalmology can not only save the eyes but save the life. This is an example of retinoblastoma which was picked up at the primary eye care. Because of the red referral, we could track immediately and efficiently. And this is an example of a green referral. As a retina specialist, for me, so how many anterior segment conditions we can manage with through teleophthalmology. These are dancing larvae. Vision technician was the most confident. He said we have to just remove these larvae and prescribe the antibiotic drops. Whereas a teleophthalmology doctor and me, we were referring to the literature how to manage this condition. So this is the required just removal of meticulously those larvae and then actually prescribe the antibiotic drops. So this is an example. So picture of the day and referral color coding were simple innovative solutions for optimizing the primary eye care in teleophthalmology. And not only teleophthalmology can just produce in terms of giving the expertise, but it also has a significant environmental and economic impact. So recently we have actually proven this through how much by doing teleconsultation it reduces the carbon emissions, and this has been awarded as a BMJ award in terms of sustainability category. So where what we have done is that when we do the teleconsultations, we actually know that how much carbon emission was reduced. In the primary network, at any time the patient was saving at least 80 kilometers of travel by availing teleconsultation at the vision center itself, and that is equivalent to whereas in a tertiary network it was almost 1600 kilometers because of the referral nature. And when we equate to environmental impact, it is equivalent to one adult tree actually as absorbs 21 kg of carbon dioxide, so which is equivalent to planting almost more than 3000 hectares of forest land. So that is the significance of environmental impact of teleophthalmology. And teleophthalmology is not only economic and environmental impact but also social impact. You can reach the people regardless of their equity and gender and also distance. That is the importance. And we could also see in pandemic time the patients were all ravaged with this black fungus, and we could give appropriate advice through teleconsultation between the cross consultation. We could give them appropriate advice about the black fungus, and then reading those MRI records. All those was possible through the teleconsultation platform. And also some attachments also improve the efficiency of teleophthalmology. This is a simple smartphone attachment we call Grabby, which can produce clinical quality pictures. Now this Grabby we have introduced as a part of a routine care of post-transplant follow-ups and also the corneal conditions. So where patients are immediately after the treatment transplant, they will be given this simple device and which they take and then take the pictures and they will be shared through the platform. And teleophthalmology is also essential where the PK training is done through teleophthalmology eco platform. And also this is a Site Connect app which we have introduced along with Infosys, where the patient can actually self evaluate their vision, and also triage algorithm is there so that immediately they can refer to the nearest eye center location. And this is a rural and as well as urban care where we call it as silver site, where we are able to reach the teleophthalmology, where patient optometrist as well as vision technician, they go with the kit and they do all the examinations, and then they connect to the doctor through the video call after uploading the reports in the app. This is ROP where we are doing through RedCam technicians examination, and also Forest Neo where the technician led program and the doctors can see the thing, see the images and give the appropriate advice. This is a smart drop where AI enabled diabetic retinopathy initiative, where we are trying to link physician clinics with central ophthalmology clinic. And tele-rehab, as I said, is again another unique piece where you can help. So what I would like to say in summary, digitization and EMR investment has been very important for effective telemedicine. Targeted referral guidelines are essential for every subspecialty when you do teleconsultation. Picture of the day, referral color coding, these can be very simple, innovative solutions to improve the efficiency. And teleconsultation definitely bridges all the barriers. It saves the time, saves the cost and also environment. And image capturing devices, visual acuity apps, all these when you incorporate, that will provide very efficient teleophthalmology. So the journey continues to deliver people-centered, climate-smart eye care so that all may see with excellence, equity and efficiency. Let's make greener healthcare greener together. Thank you.
Thank you so much, ma'am. I think the teleophthalmology has a bigger role in larger institutes with multiple vision centers. Those with single practices cannot do it. But I think in Bihar also, with Akhand Jyoti coming up, it has also multiple vision centers, and probably their next step would be to introduce teleophthalmology, because as yet they are not having it.
I think it has got a lot of scope in the present scenario. This teleophthalmology along with artificial intelligence, especially if you are talking about ophthalmology, diabetic retinopathy and glaucoma, these are two things which if linked to teleophthalmology and artificial intelligence will do a lot of good. We can reach to the periphery, to the last person of the village, and financially also it is going to be very, very viable. Yes. So most of the cases can be diagnosed based on that. So instead of them traveling 300 kilometers coming to an expert in Patna or Muzaffarpur, they can be treated there itself. And if required, like red coding and all, that is very good, because that becomes crucial so that it can be referred to Dr. Shalabh Sinha or Dr. Shivan there.
Just to add, our manuscript, I used to be in Akhand Jyoti till a while ago, and the manuscript on the hub and spoke model that Akhand Jyoti is following quite similar to LV Prasad. It is already under process, and it might be published very soon. The important thing that the house would be interested in knowing is that AI and teleophthalmology is already integrated into Akhand Jyoti. There are about, say, 30 or odd vision centers which are working with teleophthalmology, and the optometrists who are posted there, they send the anterior segment as well as posterior segment images to the reporting center that is there in Mastichak. So I think Dr. Sumit Ranjit Singh is here.
So as of now at Akhand Jyoti, we have 10 fundus on camera Remedio smart capturing devices. And from last July onwards, we have a data set of around 20,000 patients, which we have captured, and it has been analyzed by the Medios AI software as well.
Yeah.
But so is there anybody who, any doctor is there?
There are doctors who are posted
full-time?
Full-time on an everyday basis.
So all these cameras, everything requires both software maintenance as well as hardware maintenance. So we need to be in continuous talks with the camera and industry. But this is the technology to stay with us. And even individual small practitioners also, if they want to have some home care component or anything. So we all require some tele component always in our sales so that we can maximize our patient care.
Yes, very true. And what you said was so very correct, that we are fortunate that almost everyone has a smartphone. If the parents don't have, their kids have.
Yes.
So it's not as if the poor people are not having smartphones. A simple problem, an app can probably be developed, which can help them take care of their disease and the various complications in a better way.
Yes. Another very important thing that was shown was the fluorescein filter incorporated into the smartphone flash. So that happens to be a blue patch that is developed by my colleague Atul Putlat, and that is that was published in the ICMR journal. So that when integrated into smartphone, it can also act as a tele consultation device that helps you stain the cornea or the ocular surface and then get pictures on epithelial defects. So like ma'am said, it is definitely a thing to do with corneal transplants.
Yes, the Grabby that I remember in the Delhi Onson midterm conference, somebody had come from LV Prasad, I'm forgetting his name.
Vineet.
No.
Praveen otherwise.
Praveen, yes. He had shown the Grabby and how they are using the teleophthalmology.
The advantage with Grabby is not just device, it has a software. So all the images will be stored in your network. So you can actually see track your follow-ups. Okay, first day the ulcer was like this, second day it was like, so you will be able to track the follow-ups.
Thank you so much.
Thank you very much.
So we have two guest faculties with us, Dr. Vishal and Dr. Rupak. Dr. Vishal is from Jaipur, and is a senior vitreoretinal surgeon. Just a sec. So Dr. Vishal is a recipient of FRCS from Glasgow. He is a vitreoretina fellow from Shankar Nethralaya. He is director of Agarwal Hospital in Jaipur. Also, he is the treasurer of Rajasthan Ophthalmological Society and a past chairman scientific committee of ROS, past secretary of Jaipur Ophthalmic Society, and ex-professor of the Department of Ophthalmology at SMS Medical College, Jaipur. He's a senior vitreoretinal surgeon, and he did his post-graduation from RP Center, and as I said, fellowship from AIMS. Also, he is a faculty and university certified dissertation guide for postgraduate students in SMS Medical College for more than a decade. And his main interests are surgical retina, pediatric retina, and macular interface disorders. And he has presented numerous instruction courses, co-authored books, published in index journals, and performed live surgeries in in national and international conferences. And he's also on the editorial board of the Indian Journal of Ophthalmology. Dr. Agarwal is the principal investigator for more than 6 phase 3 FDA approved multicentric trials on AMD, RVO and uveitis. And his recent awards include the Image of the Year finalists at ARCRS Stockholm, American Society of Retina Specialists Honor Award at Seattle, the Reed Buckler Best Video Award of the American Society of Retina Specialists, Image of the Year again of the American Society of Retina Specialists, Best Video Award in the EU Retina, CS Reshmi Best Video Award, Suraj Narayan Gold Medal in Ross, Best Surgical Video in Delhi Retina Meet, and IJO Honor Award for Peer Review, and also he has received the AIOS Ophthalmic Hero of India Award on 3 years, 2017, 20 and 21. So we will see in his videos why he has so many awards. So over to you. There are 2 talks by you, Dr. Vishal. I think you can give them one by one.
इसमें प्रेजेंटर मोड आ रहा है. Thank you, and sorry for the delay, and thank you VRSB, Dr. Pooja madam, and my big brothers in Patna, Satyajit sir, Subhash sir, for having me here. So I'll be taking you across a series of videos showcasing various macular surgeries, and I'll start with atypical macular holes, not the routine ones, those associated a lesser known entity with epiretinal proliferation, also known as degenerative epiretinal membranes, and when it is associated with the ERMs, it is known as LHEP, of course. So just to start, normal epiretinal membranes are very simple, straightforward surgeries, and you don't need to actually stain them. Sometimes, like in this, only the tricot crystals give you a guide how to dissect them in one piece, and even if they don't stain, they stain beautifully with trypan blue, and they might have some appendages which are more adherent than others, but again, it's a straightforward surgery, like you can see. And many of these cases do not have a ILM remnant after the ERM has been removed. I'll be showing you a few cases of degenerative ERMs associated with macular hole. And this is a post-buccal patient, and you can see the macular hole there. And after, almost a minute of staining with both the eyes, there was absolutely no stain. There was absolutely no negative stain also. So these are the cases where you should suspect and go back to the pre-op OCT, and you will see that homogeneous mass which is now being peeled off. Actually, it's a glial tissue, and once you catch hold of it, you slowly move it across the macular hole, and just taking care not to go through the hole because it will enlarge and avulse the hole edges. And these are little difficult cases. It requires a lot of patience. But once you get hold of that, grasp that gummy tissue, you will find it, and you can stretch that dissection and the peeling towards the hole 360 degree around that hole. And then the important point here is, then again you stain with your brilliant blue, there will always be some ILM left, as you can see, and then you can peel that and envelop it over that epiretinal tissue, that degenerative ERM. So that blue stain is of the ILM, and that pale yellow stain is of the degenerative ERM. So it's a scaffold technique in which first you enfold the epiretinal membrane, which is shown as the arrow, is the yellow part, and then the blue part, which is actually the ILM. And almost 20 to 25% patients have this entity, and you can see the OCT again at the foveal edges, that there is that homogeneous tissue, which is very important to recognize, because you have to be prepared. Routine macular surgery is simple staining, good view, you just invert or peel off the ILM and it's over. These cases take time. It will require multiple stainings, maybe longer staining. So again, the same problem, that gelatinous tissue was after many attempts was caught and peeled, and after that again, in every case after BBG staining, you will get that ILM staining again.
and then you peel and invert it over the epiretinal tissue, and that gives you excellent results. But you have to be patient as opposed to the routine macular hole cases. So I'll now shift to the holy grail of macular holes. You know, myopic foveoasciasis, axial length more than 30, 31 mm, where the instruments are short, the eyes are long, the contrast is very poor, and you can see the posterior pole and it has no contrast, it's all yellow, it's all sclera. So the staining is poor, so you have to make the ports around 4.5 to 5 mm. There is posterior pole fluid because a hole associated with such myopic eyes will eventually end up in a RD also. So there are two prongs. First, to reduce the posterior pole fluid and then close the hole also. And a simple routine ILM peeling will not suffice as in normal cases, routine cases. So here we have induced the PVD, made the patient pseudophakic, stained it with BBG for some more time than the usual cases, and we were fortunate enough in this case that we got a good stain here. Now if you get a good stain, which is a norm, is a norm if the axial length is less than 30. So this was around 29 mm. So we got a good stain. Now the point here is that if you are inverting the ILM, the area of the peel should be much wider than your routine ILM peeling. It should actually encroach the edge of the staphyloma in these pathological myopic cases. If you don't do that, and if you just have a small peel area, then of course the hole will close, but it will cause a high incidence of recurrence because the retina is stretched out. You have to make it pliable enough to have long-term type 1 closures, and I'm talking of type 1 closures, not type 2 closures here. But if you extend it beyond the staphyloma, it will cause a it will result in a type 1 closure for a long term with zero incidence of late reopening. The other benefit in this technique is you don't have to make a secondary retinotomy to aspirate the posterior pole fluid. You just aspirate the PFCL. You can see that fluid which has shifted because of the PFCL on the near the arcades, and that fluid will get absorbed even in such myopic eyes next day itself if there is no secondary break. But the problem occurs in axial length more than 30, 31. Here there is zero contrast, and you can see after staining, after putting PFCL, let alone the staining, you cannot even identify the macular hole in such cases because of the poor contrast. So so peeling under PFCL is a bad idea. So you have to peel under a detached retina, which gives you an excellent contrast. Just to highlight that point, this is a ICLRD with a macular hole, and you can see the poor contrast, the posterior staphyloma, the scleral show, and after doing all the routine maneuvers here, after the staining, we started the peeling under detached retina. And the first grasp is a little difficult, but once you get that fold, you just continue continue the peeling all around the hole, make multiple flaps, don't let go of those small flaps, and then when all those flaps are in position at the edge of the hole, then you inject a small amount of PFCL just to reposition those flaps into the hole. You don't even need to stuff them, and you don't need to trim those flaps because under the PFCL they'll be scrawled on themselves, they'll be wet, and you don't need to trim them. So I've injected the PFCL after creating the flaps are in position, you just have to aspirate the PFCL under air and put a gas tamponade, and the job is done. And these are all the follow-ups of the cases I've shown you. These have been now more than 6 years we have been doing this technique, and there is no late reopening of these, and with a type 1 closure. So, myopic foveoasciasis with a macular hole is a complex surgery. Combined procedures like PVD induction, multiple stainings, longer duration of staining, and making posterior ports are key to success. But trying all these things and just labeling it as a failed surgery is always early and a hurried decision, because these are failed macular hole surgeries where you might be doing a massage or you might be doing a amniotic membrane graft. But and of course, just to showcase the amniotic membrane graft, this is the optic disc pit which has been lasered before, but there is recurrent fluid, and this is a optic disc pit along with the macular hole. So after PVD induction, we tried that we will do the ILM flap for the macular hole, and we'll do the human amniotic membrane for the optic disc pit, and it worked beautifully actually. So it's a very easy surgery. The amniotic membrane, as opposed to retinal auto-transplant or a free flap, is very easy to maneuver inside the vitreous cavity. You don't even need a bimanual maneuver. You can just use your light pipe and the cutter or the forceps to maneuver it in the pit. So here is a flap over the macular hole, and here is the amniotic membrane over the pit. And we had excellent results, as you can see in the post-op pictures, and you can see that amniotic membrane over the disc. Just a few more videos. So this was a failed macular hole surgery, and you can see this is the primary surgery. It was a normal 400 micron hole, and we inverted the flaps, and everything was okay. We trimmed the flaps. Even under FAX, you can see the flaps over the hole, but we had a failure. And this was 7 days post-op. You can see the bubble has almost gone, and there were flat edges. But if you see carefully on the nasal side, there is a scroll of ILM still left, because the ILM was not aspirated. It was dislodged during FAX. And if you see the imaging on Clarus, and this is infrared image, and you can see again on the nasal edge, and a slight frill of the ILM is still left over there. So you don't need to try all the acrobatics like amniotic membrane graft or autologous retinal transplant in these cases. You just have to identify those flaps again by restaining and just reposition them, and the job is done. As you see, after staining, that same scroll, the same picture is now visible intraoperatively. That flap actually got dislodged in the primary surgery in the nasal area, inferior nasal area. It was restained. Now this time we repositioned it under PFCL, and this surgery did not require any other maneuvers. So this was the final picture intraoperatively, and it closed after 7 days. So if you compare human amniotic membrane or retinal autografts or any other technique, I think now we are a part of the ILM flap study group, which has this year released the largest series of failed macular holes with flaps with the AMG study of 962 eyes. At the verdict is the best results anatomically and functionally are from flaps only. The last video is, of course, submacular hemorrhage, and here I'll just tell you a small jugaad which we have made in our OT. So these require subretinal injections of TPA. So we just took a venomal syringe, cut that seal over it, and the VFC cutter which is available in the OT of all VR surgeons, we cut the tube and just attach it to the 1 ml syringe and stain the TPA with a small drop of fluorescein dye. So while injecting it subretinally, you can see the dye flow in the subretinal space, and that makes it very precise. You just observe the second case of submacular hemorrhage. I am injecting, and that the greenish hue, when it reaches the normal retina, I stop. So it is very precise because we can see where the dye is going. So that is something which we did new last year. And these are the post-op and the pre-op and the post-op pictures of the submacular hemorrhage after 7 days. I will not go into the macular fold. Thank you so much.
Thank you, Vishal, for all those wonderful videos, and the use of the fluorescein dye was pretty interesting. Does fluorescein have any effect on the retinal pigment epithelium? Any toxic effect? So, would you like to, quantify the percentage of fluorescein, or just you are saying one drop?
You have that fluorescein strips in your OPD. We just ETO them, okay? And while we just put a drop of saline BSS over that, and that is the amount which is required to stain it adequately. So you don't need to dip the ampule fluorescein. That strip of fluorescein is enough to stain. We just need a greenish hue. We don't want it dark green.
Right.
No, after the
post-op.
hemorrhage has post-op. After 6 months, when it has resolved.
Yes, the heme itself.
These all cases, I'm not talking of microperimetry in subfoveal scar patients. They were all parafoveal, and I had shown you the OCT also. There's almost normal foveal contour.
How do you distinguish the
I
toxicity from
accept that
heme
there
from
is always
toxicity
a
of
bias,
fluorescein?
but there are so many studies of fluorescein subretinal previously also, and there is no toxicity reported.
But I'm asking about per se case of
they were
heat
less than
toxicity
normal,
versus fluorescent
but of
toxicity.
course if there is a scar, we cannot, ascertain whether it is because of the scar or because of the fluorescent toxicity.
Very nice cases, Dr. Vishal.
And macular hole.
Yeah.
We do that temporal flap, we can cover the macular hole, and the nasal flap we can put on optic display.
Yeah, we can do that also. It was just to show, that AMG also works equally well, and it is an option in field cases, and it is very easy to do it. It is very cheap and available in the market, and everybody should try it for field cases, as opposed to more, aggressive steps like, cutting a retinal tissue and sticking it over it.
No, AMG, this was a wet AMG or a dried one?
That was a dried one.
Dried one?
Yeah, life.
Okay.
Just one little different question. What is your take on traumatic macular holes with ERM? Especially, I had one case where there's a choroidal rupture just at the edge of the macular hole. So, if there's an ERM along with that, then how do you raise a flap?
Any ERM, whether it is traumatic or atraumatic, first you stain with the trypan blue, and then you identify the ILM. But if it is bisecting the foveal center, then it's a little difficult because that might be incorporated in the scar tissue. So you cannot just pull it because you might enlarge the hole. Then you have to be, a little careful, trim it and keep it over the hole, and not just pull it over it.
If it is at the margin of the, the choroidal rupture is at the margin of the hole, then we need to be a little careful about the surgical closure, because there will be an addition between that closure area. Yeah. So in that situation, you have to manually dissect of that area will be a good idea, or you can just balloon it in that particular area, if not the other area, and balloon it and pass the fluid through that, so that you make sure that the retina is mobile in that area so that it can go away.
It's just like macular folds, you have to balloon it and
correct.
Traumatic macular hole with subretinal scarring. Regarding the ballooning, I tried it, but the fluid doesn't dissect through that scarring. It is not. So the issue is
but that must be a long-standing trauma. If you do it, within 1 or 2 months of the choroidal rupture.
CR rupture passing. So we are talking about that case scenario, and it doesn't dissect. What is the issue is that you have one retina which is able to migrate and one part of the retina which is not going to migrate. So their chances of failure is really high in this case, right? So manually, how do you dissect?
It is difficult in that area, but again I'm telling you, in that situation we need to be very careful. But if it is not at the margin, the choroidal rupture is little away, then probably you can get away with that.
Then that becomes a routine macular hole surgery.
No, I have done few cases of traumatic macular holes with choroidal rupture, and it hasn't failed. Of course, you're not going to get the same results as a normal macular hole. The choroidal rupture, since it is already going through the fovea, obviously the patient's vision will be poor, but he will have more of the parafoveal vision fixation that he will recover.
Eccentric fixation.
Yes. So thank you, Dr. Vishal, and your second talk we'll take up a little later. So the next talk is by Dr. Rupakanti Biswas. Again, he's a senior vitreoretinal surgeon in Kolkata. He was with Shankar Netralaya, Chennai, and then he was a consultant at Shankar Netralaya in Kolkata also. And now he is a partner.
Shall I? I'll just introduce myself. I'm Rupak. I'm a blessed junior of all the seniors like Pranab sir, Sahai sir, Jagopal sir, Arvind sir, and proud friend of Salav, Pooja, Satyajit, all of them. So let us start with this, direct with this. Now, it was an excellent presentation by Vishal, where he has shown off multiple areas of to deal with different situations. Now, I will play in a little different way. So whenever you have a staphyloma, so you can deal either, if you have a more of a bend, then you can tell them, you can tell yourself that ठीक है रेटिना टेढ़ा है तो मैं उससे भी टेढ़ा हूँ, मैं उसको सीधा कर सकता हूँ, ठीक है? So let me talk with this. So macular buckle is a concept where you get into it, where there is a mismatch between the retinal circumference and the scleral circumference. So you need to match these two whenever it comes. Yes, Vishal's technique and in his hand this is very good, but yes, this can be an additive factor which can give you a lot of. I'll give you an example of, this is a case of 54-year-old gentleman who has unilateral myopia presented with counting finger vision in one eye, and he had, this is the presentation at presentation, and this is how his presentation. This is right eye is having myopic macular traction with impending hole and a staphyloma. The left eye is absolutely fine. So what we decided is to go ahead with a triple procedure of this session of having doing a vitrectomy with ILM peeling along with macular buckle and the cataract surgery altogether, so that the patient gets the maximum visual benefit in one surgery. So this is the macular buckle made by FCI. I will talk about that, which is not freely available right now. So this is the temporal part, this is through the supratemporal area. So you just, with this buckle, there is a 240 band usually comes, but that is really tough to handle. So I have converted that with the 240 band with this, and then I have passed the 240 band. And then from the supratemporal region, I just placed the buckle under the macular area and kept it there. So now at this point of time, you just keep it. You don't finalize the buckle at that point of area. Now, after finishing cataract, then you do a routine vitrectomy and ILM peeling, which is much more easier job for any vitreoretinal surgeon and as a routine procedure. So, but again, you need to keep it in mind that this is a myopic eye. So again, so there are few procedure for the myopic eye we need to keep. We need to have a longer size of the instrument, and we have to have a very good staining. Otherwise, with the contrast, it is difficult to remove that ILM. That is also one of the important. So I did it under air, and then as a routine ILM peeling, a little larger size of ILM peeling I did it for these kind of cases. You can make out that there is significant amount of that peripapillary atrophy. Yes, after this normally, usually we don't close this 25 gauge, but here I wanted a properly sealed eye, because whenever you are trying to push that buckle and then tightening it off, there is always chance of choroidal detachment if there is a hypotony. Yes, I'm just trying to push the buckle under the macular area. Now, what happened, this is called folded into this, so that's why it was not going there. So I just wanted to show this part of the video also, because that was not that every time it will go very smoothly. So I have again just unfolded the buckle and then again, replaced it slowly, and you can now make out very easily that the macular area is getting lifted gradually once you pull the 240 band from the nasal side. And once you keep on pulling 240 band from the other side, then you finalize the buckle and place it, suture it, by both the sides of that lateral rectus muscle. And this is the end of the surgery. And 2 months later, this is usually the visual outcome, and the patient is extremely happy, and I'm also more than happy than the patient. So this is another patient who has similar kind of manifestation. She was also an unilateral high myope, and this was the preoperative presentation, but her cataract was not significant, so, and there was not much, so we decided only to go ahead for the macular buckle. And the similar way also we have, this is the most important here is that this FCI buckle is little, larger and bulkier. So you need to place it supratemporal area where you get the maximum amount, or from the infratemporal area as well, you can put it from there. And this is just for the trocar cannula for the chandelier light. And this time I have planned for, for a scleral tunnel as well, so that, the direction of the pull should be in a stabilized way. So we have, again, this is the left eye, and from the supratemporal area, I have just placed it and passed through the scleral tunnels as well, and then slowly, whenever you pull it, this automatically when you try to pull it from the nasal side, this buckle will automatically go inside. So you just need to titrate at that point of time where exactly you are going to place it. So once it is placed, you are satisfied enough, you can just, yes, yeah, you can see that there is you can see the progression of the, yes, the macular area, the foveal area was lifted. Yes, then you can just, fix it up. And rest of the thing is like the same what I have shown you earlier. And this was the postoperative area. We have a significant amount of the more buccal effect, but I try to put it a little more over a period of time. It tends to go a little because the sclera is much thinner. So they again, with the normalization effect, the sclera goes to little go away. So the effect will go down. And these are the two cases I just wanted to share with you. So when you have a significant amount of the posterior staphyloma, this is another way out of handling this situation. Thank you.
It is really a marvelous presentation, Dr. Rupak. What I could get that this is the 360 240 band, and this sort of this macular part is there. So. And rightly you have shown the thing through video indirect. So, do you think that after some time it will come or give away or something like
No,
that?
sir.
Because this part is unsupported, and there must be some elastic component of that flap-like thing.
No, what happens?
Can it go back again like this?
No, because the 240 band is through this.
Yeah.
So 240 band, see, it is like if you compare the globe is like this. So from one side, this buckle is going there in the macular area, and 240 band has gone through the buckle. So 240 band is actually holding it, and that I have
But the larger part,
I have sutured with the nasal by the side of the medial rectus muscle. So now if you cut the cross section, so the buckle is like this, and this 240 band is from other side to this. So two ends are holding it at this end. So it is usually it does not slip.
No, I am talking about this jhanda type effect, because
So
can it come back again?
The push is also a fixed, no, sir? Because yes, over a period of time, it has been reported that the effect has gone down a little bit up, but that's why I have tried to put it a little more so that it remains there.
Really, very.
Yeah. So that's why I tried to put a little more of the indentation so that the effect does not go there. And even these kind of high myopes, the scleral thinning is always there. And it has been reported that there is a continuous progression of the posterior staphyloma. So even with that also, the effect should not go there. So the effect should be little on the higher side.
Very good.
I agree with you. Maybe probably this was all of us in the learning phase. So probably yes, I will. These are the gray zone of, again, you can try to it without that also. But again, once you are, you know that you have pushed the staphyloma area as well. So you know that yes, I am going to give the best result out of that.
How long is the follow-up period of your case?
This is, both of them are, the second one is around 5 months, the first one is 7 months.
So you cannot comment on the atrophy part, right?
Long term, you don't know. But again, the atrophy which has been reported is not significant enough for all of them. But yes, there are infection and related, the usual buccal related complications has been reported for that.
So what is the posterior most extent of the buccal? Like
Sorry?
how far posterior most extent of the buccal tip?
It's just on the macula. Whenever the macula is elevated, you can stop there. You don't need to go beyond that. Then again, the chance of impingement on the optic nerve is there.
And then how do you titrate the height of the buccal? Like what the second patient you showed.
So this is an imaginary. How do you see in that? Because you are seeing directly on the visualization. So 3D effect is already there. It is not that you are just seeing with the even you can see with the indirect ophthalmoscope, but here the chandelier light pipe is there. So with the biome, you are directly visualizing when you are titrating it.
I have done few cases of macrobuckling with this T, morning diamond T implant. So I found that there was a restriction of movement, especially on when you are trying the lateral rectus abduction here. So did you find that in your case? And also one case had, after a few days, the patient's conjunctival meltdown was there. So did you, I mean, seriously, because that T, the last part of the T, I mean on the anterior side.
You have used this FCI one?
Yeah, FCI one.
Yeah. So now what I have noticed is that once you have fixed it to the temporal side, both the sides, this part is fixed. So the nasal part is not yet fixed. So once the nasal part you are finalizing it, then you suture it on the nasal part. So that is little on the higher side, and once you try to suture, there is always a possibility of little loosening. So make it little on the higher side so that it automatically comes to a normal stage.
Did you find any restriction of movement of the eye? Because one of my patients started complaining diplopia after that.
The first patient, no. The second patient initially was there, but which over a period of time has gone now. That is the usual complications of buckle what we used to have. No, it is not going to the vortex band up to that area. Which one? You are 240 band, or you are talking about the?
240 when we are tightening and just suturing it below medial rectus. At that time, I can imagine it is going just a little bit posterior to equator also.
Yeah, so that's why if you have this scleral tunnel, then probably we will be able to restrict. So if you think if the scleral tunnel is there, so it is going like this, and then through the scleral tunnel it is coming out. So probably you will be able to less chance of impinging the optic, even the vortex band. Yes.
So we have another talk by Dr. Rupak, and that is why change.
No, I have one more.
Yes.
This is
lipemia. Yes, lipemia retinalis.
Yeah. So this is something interesting kind of patient which has come across to our OPD. So a patient who has 34-year-old gentleman who has came to our OPD, and any of the PGs are here. Any of the senior resident of PG are here. Anybody? Okay, then I'll target Vishal. Okay, Vishal, what do you expect this patient's vision when they come to the retinal OPD? Six, 360, counting finger kind of vision. Because what do we expect? That the most of the blood circulation is completely stopped, so kind of thing, isn't it? This patient has come with bilateral 6-6 and 6 visions. So the patient has come as a routine checkup, and patient was completely asymptomatic, and the AT, anti-segment, everything was fine, except that, clinical, the finding. So whenever then we did this thing. If you see very carefully here, I will, show you this part. So if you notice here, these are the area is actually the end-on cut section of those retinal blood vessels. And normally these blood vessels may not have that kind of whitish or oval shaped area. So these are actually a lipid-laden whole blood. So that's why you have some amount of the posterior back scattering as well for this. So here also you can see those black scattering. So in fact, this patient, when we did, this is the lipemia retinalis, that the patient is absolutely asymptomatic with a serum triglyceride level of 2250 milligram per DL. So, and the patient was having already a risk of cardiac and other manifestations. So immediately the patient was sent for a cardiologist opinion, and 3 months later the patient has come back. Vision is 6-6 and with the normalization of the vessels. So the blood circulation is still maintained unless until it goes into the vascular occlusion stage or the stroke stage. Before that, it can present with a normal phenomenon. This is the other, differential diagnosis, all those things. But one of the differential diagnosis where, hyperviscosity syndrome like leukemia or, Waldenström macroglobulinemia, they can also present like similar, but then they will not have this much of amount of the, that lipid-laden, that creamy kind of picture. I would like to acknowledge Krishnendu's contribution because he has seen the patient first and then he has shared with all of us. Thank you all. This one? Yeah, so lipemia is a rare manifestation, but mostly when the triglyceride level goes more than 1000 or 1500, then only it can present, depending upon the patient. And most of the cases, this is incidental, unless until the patient present with vascular occlusion at that stage. Clinical significance, otherwise also there is an acute elevation of the triglyceride level. Probably they have some kind of a metabolic disorder, usually get detected, and to be treated by, then rest of the part is the cardiologist's purview, so we'll not, yeah. So I think we'll stop it here. We'll go for the, I'll present the last one also as well. Baby smoker.
One thing is very important, the creamy appearance of the vessels.
Yes.
It is not faded appearance like in RVOs or like that. You will have a creamy type of appearance, and rightly I said the vision will be unaffected. Then you have to doubt that such kind of things, lipid profile and all these things are needed to be done.
Yeah, sometimes it may be confused with the severe hypertensive retinopathy, which may have like copper kind of reflex, but again, it is equally distributed in all the areas are equally, so that will give you a kind of clinical impression for that. Sorry for bothering you for the consecutive talks because everything was due because we are delayed. So why anything change in life is the constant, why change is because the change is the constant thing in life, which is a common dictum. But change करने के लिए change करना है is not a mandatory thing. Whenever you change, go for the betterment. That's what is always look for. Otherwise, change का कोई मतलब नहीं बनता है. So this is just a disclaimer for as because I'll be sharing this real world scenario, so which may not mimic always the exactly what we are following in the posology of those clinical dictum. So in near about 1.5 to 3% of the patient who is having AMD, and near about 28% of the patient who is having AMD, DME patient. So they are being treated for for the decades with the anti-VEGF treatment. Now, if you look into again go back and look into them, so over a period of time, if we see that first year treatment, even in our clinical practice also, the second year, those patients are, you get a little add-on patient, but there are few patients which either they get stabilized or they don't follow up with you. So what happens over a period of time, because these are lifelong cases, so they have to have a lifelong follow-up or a stabilization of the disease. So that's what, these are the two cases where the patient gets fed up of treatment, then they completely goes away. But what we have seen in these kind of cases, dropping out over a period of, even for those cases where we have real world experience, this Western data has shown that first 1 year, then 3 year, then 5 year, there is a gradual dropout of those patients. So why these things is occurring? Because you have disease which is being supplemented but not being taken care of the basic pathology, so that's why it was keep on coming, and then every time you give injection. So the patient has a feeling that I have to live with this injection for the rest of my life. And I think all of us is faced like these kind of questions. So if we start thinking that yes, what are the basic pathology, and start thinking of those repair of the basic pathology or something which can cover up the basic pathology from the multi-sprung effect, that's what we are looking for. That's why in the newer generation we already started getting off depot injection, or there are injection which is to be sutured in this thing and can be topped up with that. So these are all the pipeline into this. But even before that also, if we get a drug which can have the multi-sprung effect, probably they will have a little more edge over the only VEGF target. So this is the only, as of now, have the biphagic effect of faricimab, have the biphagic effect, which Ang2 inhibition effect, as well as the VEGF-A. And the VEGF-A, as you all know, that VEGF-A is the mainstay for those pathological changes occurring beyond this. and Ang2 is actually inhibition of Ang2 causing the repair of those blood vessels, which is the changes which is occurring because of the promoting the Ang1 stability, vascular stability. So I will give you a short clinical scenario, which this is we have done a study here in our in Netalam along with other branches. And we have initial 24 patients, but believe me, this is the data which I am sharing with you before the patient support program. So that point of time, we used to have this PRN treatment as well. And almost initially baseline from the visual acuity changes, if you see initially 0.66 to over 6 months, with more than 6 months follow-up, this has improved to 6.2. So there is a significant improvement of the visual acuity. And the most important here, what I am trying to show you here, is this part of it. So if you see, this is the visual acuity and the central subfoveal thickness. This is the gradual decrease is there. But SRF out of 22 eyes, out of 24 eyes, 22 has SRF. And after 6 months, there is 2. That is accepted with all anti-VEGF. But what is more important is that intraretinal fluid and the PED, these are the 2 important parameters which is difficult to handle by only anti-VEGF. By these 2 also has significantly come down. It is from 16 to 2 eyes, this is 11 to 6 eyes. So this is where exactly we have the age of it. And we didn't have any reported IOI for these cases. This is just a West Ham data comparative of how the IOI data is that. Just 1 or 2 clinical example. This is this is case 1 who had a multiple previous injection, and then this is a baseline visual acuity, and over a period of time after first injection improved, second injection also improved. The similar way we have a multiple cases where you have a significant improvement and which is being maintained over a period of 6 months. So that is most important, and I think this is the way to change and looking into the change whether we can change it for the betterment. Thank you.
So thank you, Dr. Rupak, and next I would invite Dr. Vishal, and he would also be talking about the real-world experience using Vabysmo in Indian patients with neovascular AMD and diabetic macular edema.
So I'll be, sharing my real-world experience on faricimab since its inception, launch in India last year, and these are my disclosures. And I'll not go into the detail, as Dr. Rupak has already covered the unmet need of sustained and effective treatments in both NAMD and DME, and the financial constraints, especially in our country, where the insurance sector percolation is very poor. And apart from that, even if you remove the economics, the money out of the equation, we all know that a significant proportion of our patients of DME and NMD are non-responders from the word go also, and that prompts us to think that apart from VEGF, there is an inflammatory component which is common to these diseases and which has been proved subsequently. So, sorry. So this is the pharmacology again. There is no point in discussing it in detail, but Ang1 and Tie2 pathway is the pathway which Ang2 promotes vascular instability, and it hits at the Ang1 and Tie2 pathway in a pathological switch conditions like DME and NAMD. And this was the first bispecific antibody which was launched in January 2024 and is available with the brand name of Vabysmo in India. And it inhibits both Ang2 and VEGF-A, promoting vascular stability in addition to inhibiting leakage and neovascularization. बंद हो रहा है. चलेगा फिर बंद हो जाएगा. Sorry for the technical glitch. And now the Salvin trial data has also been released, and it shows that the drug shows robust and rapid improvement in visual acuity, leading to complete closure and activation of polypoid lesions in almost 86% of all the cases, and the safety profile was robust. So coming to the main focus of the presentation is RWE, that is real world evidence, and why is it important to us? Because in in our clinics, in your and mine OPD, when we see patients of NAMD, we do not treat on the basis of clinical trial inclusion criteria. We do not see the lesion size in every case. We do not see the age. We do not see the size of the scar tissue. We treat because the vision has gone down recently and the patient complains of a recent vision loss, or we have edema, whether it's subfoveal, juxtafoveal, or parafoveal. As opposed to the RCT data, which is collected in a dedicated research setting, there are certain set of inclusion criteria which are actually impractical to follow in your clinics, in your OPDs. So we are catering to a very heterogeneous population, and we cannot inject every 2 months or 1 month, unlike the trial recommended says for 2 years, because the economics simply does not allow us to do. So that's why RWE is very important for us. So I'll be sharing few interesting cases, most of them PCV. So we have a experience of now more than 400 injections of Vabysmo since January last year, and most of these cases which I'm going to show is with bleeds and with a lot of PEDs and a lot of scarring. So this is a 75-year-old gentleman, one-eyed, with a central subfoveal fibrosis, and you can see the bleed on the left side of the fundus photograph, and the OCT, the serial OCT is on the right side, and this is the timeline of the injections being given in March 2024, April 2024, and the last follow-up was in October 2024, and these are all with loading doses of 3 Vabysmo as opposed to the 4 recommendation in the trial, Tinea and Lucerne. And the last OCT is 20 weeks post the 3rd injection. So the patient has not required a 4th injection till now. Of course, the visual acuity has modestly improved because of the scar tissue. But as you can see in the fundus photograph, there is no bleed, there is no fluid, and the patient is treatment free for the past 6 weeks now, 6 months now. This is an aggressive RAP lesion. You can see the fibrosis, you can see the bleed, one-eyed patient, and she came in January when the drug was launched. Again, you can see the timeline of the OCT on the right side of the slide, and 3 injections were given, and the last OCT on the right side is of June this year, and the patient required 3 injections. The vision has improved from 660 to 612. She is maintaining that vision. She has a normal and a dry macula. In June 2025, of course, when she came last month, you can see a slight frill of fluids in the subfoveal space. So she had a recurrence after almost 6 months, and then we injected the 4th injection after 6 months. So she had a disease-free interval of more than 6 months, and you can see the macula, the bleed has gone. Of course, there is a little amount of fibrosis here. The third slide is for delegates here who are new to this drug and who are planning to inject it in the near future. So this drug, as opposed to brolucizumab or aflibercept, does not have a fast action. It will act slowly. So this was a patient again in February last year, one of the few first patients, and the patient was actually on Paginex and had recurrence every 2 months. So we gave her the option of Vabysmo, and after 10 days she came back, and actually she was in a panic mode because she said that, doctor, you used to give me a Paginex injection and it I had an immediate improvement within a week, and you have given a much more expensive injection and it's not responding. So what is happening? And at that time also we were a little perplexed, but when we talked to colleagues and searched the literature, it showed that it has a slow acting effect. It will act. Most of the people, it will, most of the patients, it will show effect after 3 weeks. The last OCT on the right side is after 3 weeks, and it responded. The patient is happy, is on Q16 weekly as opposed to Q8 on brolucizumab, and the vision is maintaining at 612 parts. So it responds, although a little slowly. So you have to explain to patients whom you are switching from aflibercept or Paginex to faricimab. Again, not all patients respond very slowly. So this is a patient of subretinal heme, PD, intraretinal fluid, and this is a 3-week photo. We called the patient on follow-up, and you can see on the fundus photograph, the heme has gone, the edema is resolving in the resolving stage, but you can see the effect, the robust effect in these patients. But majority of the patients, they will respond, although a little slowly. 75-year-old gentleman, you can see the PD height, the intraretinal fluid, the subretinal fluid, multiple anti-VEGF injections. A switch patient here presented with 660 vision, 3 loading doses were given. The last follow-up was, just last month, and you can see there is the PD height has gone significantly down. The fovea looks dry. There is no fluid after 3 injections. The patient has not required a 4th injection till now. Again, a PCV patient, you can see the bleed, the PD height, and the fluid. And again, a switch patient, 3 injections were given. And now you see the serial OCTs. In October 2024, after 3 injections, the PD has almost flattened. Came this year in March with the recurrence after 3 injections with almost 6 months of treatment-free period. And there was a recurrence at 20 weeks, of course, and then we gave the 4th injection. But the patient was disease-free for 6 months after 3 injections. And you can see the serial fundus photographs on the right side, and there is no edema, there is no fluid, and that huge PD has almost flattened. Again, you can see the exudation, the polypoid lesions clearly in this, and the tall peak PEDs in this, a classical PCV patient. And after 3 injections, the patient has improved to 612, the heme has gone. And if you see the last OCT, and if you see the first OCT, you cannot say that this is the same patient because it's almost a normal anatomy here. Again, a very interesting PCV patient. This is a vitrectomized eye. 2 years before, I had injected a subretinal TPA and a massive submacular hemorrhage with the same patient in the right eye. Again, there was a recurrence after 2 years. You can see the PED, the typical subretinal heme, and we gave half dose of Vabysmo, and two injections we gave. And this patient came 2 months back this year, and you can see the serial OCTs. You can see the flattening of the PEDs. The PEDs are almost gone. The heme had gone even after 2 injections. The vision is 6/9. The patient has not required a 3rd injection in this patient, in this eye. See again, extreme PCV cases, lot of heme, lot of PEDs. Peak the height of the PEDs you can see. And this was a particularly resistant case, and we gave 4 loading doses, after which now you see the last OCT and compare it with the September 2024 OCT, it has almost gone. Of course, there is a subretinal hyperreflective material, shows some scarring, but the vision is maintaining at 618 parts, and it is May 2025 now, the last follow-up. The patient has not returned. We continue to follow up with these patients, has no recurrence, has not required a 5th injection, and on the fundus photograph, it is evident that there is no heme, and the PD has gone without a rip. Lot of exudation. Again, a very severe case of PCV. You can see the yellowish exudation, the polypoid lesions. You don't require ICG in these cases. This is a spotter for PCV. And you see the heme has gone, the exudation has reduced, and the vision is now 624 after 3 loading doses. The last follow-up was in March 25, again with subretinal hyperreflective material, but with no fluid, and has not required a 4th injection. This is the last case I'm going to show. Again, a PCV patient. Particularly, I'm focusing on PCV because all other drugs will do well with routine CNVMs. PCV in your practice, in my practice, is exponentially increasing, and these are particular resistant cases, and they will bleed massively if not treated in time. This was a treatment naive patient. You can see the PD, the exudation, and the heme. And the last OCT and the last fundus photograph, you can see the exudation has almost gone. It is dry. The PD has miraculously disappeared, again without a rip, because of course hypothetically it is a slow acting drug, so the chances of rip are less. And the vision is 6/9 and has not required a 4th injection even after 20 weeks of the last injection. I'll skip this last slide and focus on the data. So these are all, the master charts of our experience, and the important thing is the patients who had all the loading doses and have follow-up of more than, Q16 dosing period. So most of these, more than 60% of the patients are into the subgroup of Q16 weekly dosing, and more than 80% are into the Q12 weekly dosing in my experience. So we have now published the largest cohort from the Indian population, focusing on all 3 diseases, that is DME, NAMD, and RVO as an off-label indication. And the results, actually resonate with all the trial data, and it is well tolerated, and there was no systemic adverse effects. A few cases of mild AC reaction, but no intraocular inflammation, significant intraocular inflammation. And of course, the Q16 weekly dosing was maintained in more than 60% of the patients. So to summarize, there is a greater numerical gain even after the first dose of this drug, although it slowly acts, but after 1 month, that's 4 weeks after the first injection, there is definitely an effect. And majority of all anatomical parameters, that is intraretinal fluid, subretinal fluid, hard exudates, PED height, subretinal bleed, especially in cases of PCV, improve drastically. The safety profile is robust. Of course, the data which I showed you is still modest. We have a limited experience, and most of these data are, still evolving, because most of these patients are in their loading dose phase. Some have completed the loading dose, but do not have adequate follow-up. So maybe, late next year or in middle of the next year, we'll have ample data. And as the company promises, if all these patients, more than 50% of these patients are requiring Q16 dosing, and if my patients of DME and NAMD require 3 or 4 pricks a year, then I think this drug will be a game changer in the future. Thank you so much.
Very nice presentation, Dr. Vishal. I have one question which commonly comes to my mind, that if I remember the trial's name correct, Lucerne and Cantanea trial, yeah. And at that time, the VRSB did not arrive in our country. They said that it is non-inferior to aflibercept, meaning thereby the 2 monthly dose they suggested. Now, after some time, the Pagenex came. They claimed the Hawk and Harriet study. They told that no, we can give 3-month protection, roughly. So that because of this sterile vitritis, people stopped using it. Now we have this drug. Eylea 8 milligram has not come. That also claimed 16-week effect. Now, they say fairly long duration you have given, and you have given number of 400, that's a decent number. So your experience will also count, and it's rightly you have shown that 4-month, 6-month gap is there, and they have remained stable. So what is your suggestion that what we can take from you, that what should be the gap? Is it 3 monthly or 4 monthly? Or 2 monthly as per Lucerne Cantanea trial, whatever.
So I think we should forget about the trials and focus on what our experience shows regarding the efficacy and regarding the safety profile. So if you ask me, all these cases will respond to brolucizumab also, with aflibercept also. But the point here we are looking at is the sustainability. So in my experience, more than 50% of Pagenex patients and aflibercept reach 2 monthly, and some of these reach 3 monthly. But the maximum proportion reaching Q16 is with faricimab. So if a PCV patient comes with so much of bleeding, so much of PEDs, then my first line therapy will be faricimab. Otherwise, of course, in our country, it all depends on the economics also. It's an expensive drug. So most of our patients will be opting for off-label bevacizumab or maybe biosimilars. But if the patient is affording or he is covered under health insurance, I think this is the drug to go for in these severe cases.
I've been practicing retina for 11 years. Have used ranibizumab throughout. I have never encountered any inflammation or any side effects which I would not expect in any of the patients so far. We had brolucizumab some time ago. We all used it. I've also used it, but I faced intraocular inflammation in three patients, which in a duration of 6 months to a year's time. So I definitely stopped using it because I had never had it in ranibizumab. With Vabysmo, have you ever encountered any intraocular inflammation, any vasculitis, or any side effect which you wouldn't have expected to
routine
have?
Side effects, normal AC cells and flare in some patients. but you should know it's the nature of the drug which you can have an intraocular inflammation in any salt, whether it is aflibercept, brolucizumab.
Okay.
Even brolucizumab, I think it is overhyped. If you give the loading doses 6 weekly apart, then the incidence is very low.
Okay.
So I think it is the nature of the drug. You will, at some point of time in your practice, will encounter, unfortunately, these cases, and you have to deal with them. But with this limited data for this drug, no significant side effects till now in my practice.
For ranibizumab or even for aflibercept
I have
also,
had inflammations in ranibizumab, aflibercept, brolucizumab. Every drug I have used, Avastin.
Okay.
Ranging from AC cells to intraocular inflammation to endophthalmitis. And I think anybody with a 20-year practice cannot deny that they had this experience. So no drug is completely or 100% safe. But the percentage should be acceptable in clinical practice.
So it is equivalent to aflibercept or ranibizumab?
Yes, yes.
With
Till
Vabysmo.
now. Yes.
Thank you, sir. Thank you for the very nice presentation. Now I'd request Prati. Okay. May I request Subhash sir to please come and facilitate the presenters. Dr. Rupak sir, please. Dr. Vishal sir, please. Now may I request Dr. Nishant please to take over the dais for the next session. Dr. Divya, please.
Not to forget Dr. Divya Pandey as well. We are all getting a little drowsy after lunch, and we thought, how can we wake you up? So now we are coming to the very exciting Jugalbandi, the ophthalmic Jugalbandi that is to take place here at the VRSB 2025. It is the clash of the titans, and we have our first presentation on how to put it back, and of course it pertains to the lens. So Dr. Santosh will be speaking on iris claw IOL, Dr. Prashant on scleral fixated IOL, and as the jury member we have Dr. Shalabh Sinha sir. If he is here, I'd like to invite him. Dr. Santosh, to take your podium. Dr. Prashant sir, please take the podium on the opposite side. We will have 1 minute for rebuttal, each presenter to the next after the presentation, and a final comment from the expert.
Very good afternoon, all the dignitaries on and off the dais. And thank you, VRSB team, for giving me this opportunity to present my case here. So, my PowerPoint presentation is on iris fixated IOL here. So, first I'll start with the video like how easy it is to put iris fixated posterior iris fixated IOL. So in the same sitting, like we can just take the IOL out, and as you can see, the maneuvering is so simple that through the same tunnel, through the same side ports, we can go for putting this iris fixated IOL. So this one is the second case. So this is just to show that particularly in the large volume centers, when you are doing a lot of cataract surgery, if any such kind of complication happens, then you can just convert it to iris claw. So as you can see here, the management of aphakia is the best way is to deal with IOLs, and among the IOLs, iris fixated IOLs, SE IOL and SF IOL. So I will be talking about iris fixated IOL, and definitely retropupillary IOLs are becoming the the preferred options, because of it. It is away from the endothelium, and anatomically in a better position. So here you can see iris fixated IOL. It is away from cornea, in a more physiological position, less endothelial damage. PI is not always required, and this is like this was in contrast to anterior chamber, which was just the opposite case. And iris claw, as you can see here, it is a rigid single piece IOL PMMA material, and haptics have fine features to capture by way of enclavation. So indications for iris claw IOL is iatrogenic aphakia, complicated cataract surgery with inadequate capsular or zonular support, ocular trauma, any ectopia lentis. So the prerequisite is obviously the sufficient iris tissue, and ideally a normal size and shaped IOL pupil. And the mid dilated pupil is always the most preferred one. If it is more dilated, then it is tough to get the iris, that chunk of iris tissue. And if it is like very small, then it will be very blind procedure to see and tuck the haptic. So why iris claw IOL over other IOLs? So obviously it has short learning curve, and the same SICS tunnel can be used for IOL insertion. Additionally, just a forceps is required. Can be done in primary seating, and with lesser complications, or at least as good as the others like SFIL, and more economical of course, and it is done in high volume center with outreach, and it takes very less time. So the contraindications for iris claw IOL is aniridia, ischemic vascular occlusion with rubiosis iridis, and uveitis. So post-operative outcomes, as we have taken their studies. So all of these studies are like showing this disenclavation rate, pupil ovalization in a very acceptable range, and the endothelial cell loss is also not much. These studies are suggesting the same thing. So the conclusion is short learning curve, less surgical time, lesser rate of complications, economical, can be done in primary settings. Thank you very much.
Yeah, thank you sir. And थोड़ा सा अजीब हो गया ना, IOL का हम लोग क्लासिकली वो शेप जानते हैं कि वो उल्टा एस कॉन्फ़िगरेशन में लगता है, एंड यहाँ हम देख रहे हैं कि दो केकड़ा जैसा क्लॉ रहता है, इसमें वैसा वाला IOL लगाते हैं. सो व्हाट इज योर टेक सर?
Iris claw is easier to put, and it's cheaper, but I need to present my topic, and I just want to.
Yeah, but the point is like you do need an iris claw lens, right?
I think
but
let him finish his.
SFIL is sufficient.
Yeah.
Let him finish his.
Yeah. आप आओ बताओ. Can you give something more in favor of SFIL?
SFIL, yeah.
Please take the opposite podium, sir.
A very good afternoon to all of you. I am Dr. Prashant. In this ophthalmic jugalbandi session of how to put it back, I'll be talking about scleral fixated IOL, the anchor in phakia. Now, whenever the capsular bag fails us, we need a reliable solution that doesn't. At present, we have three secondary IOL options available. The first is AC IOL, which is quick to put but has a risk of corneal decompensation and uveitis. The second is iris claw IOL, which is easier to put but has a risk of pupillary distortion, uveitis and endothelial damage. And the third is scleral fixated IOL, which is technically more demanding and anatomically it is more safer. Now, SFIL today is like ordering a coffee, like we have got options. The first is Yamane, in which there is no sutures, just tuck and toast the haptic. The second is glued IOL, where we'll flap it, tuck it and glue it. And the third is CMT Flex, which is built to bend but never breaks. Now, there is a comparison between the scleral fixated IOL and then iris claw IOL. SFIL is put into the posterior chamber. It has high endothelial safety. It has a moderate surgical complexity. The long-term stability is excellent, and the visual outcome is stable and centered. Whereas an iris claw IOL is put anterior to posterior to the iris. The endothelial safety is low, especially in the case of anteriorly inflated IOL. The surgical complexity is low, and the long-term stability is variable, as there is a risk of disinflammation. The visual outcome, it has chances of pupillary distortion. Now, this is the post-operative complication rates between SFIL and iris claw IOL. As we can see, the complication rate is nearly more than double. The chances of CME, endothelial cell loss, dislocation and pupillary distortion is almost more than double. Now, this is a picture of a glued SFIL, and this is a picture of a CMT Flex IOL. Now, this is a short surgical video, like here after explanting out the IOL. We are planning for the Yamane technique. Now, after marking the 0 and 180 degree position, a 2.5 millimeter marking is made on the either side of the limbus. Now, the IOL is put on the top of the iris. Now, a 26 gauge needle is taken. It is tunneled 2 millimeter into the sclera and then is pushed back into the vitreous cavity. Now, the haptic is held with a micro gasper and a couple of pushes are made into the needle. Now, the needle is gradually pulled back. Similar procedure is done on the opposite side. Here also the needle is pushed back into the vitreous cavity, and the optic is held to move the needle is held to move the optic away. Now, this is also put into the needle, this haptic. Now, the needle is gradually withdrawn and the haptic is held with a forceps. The end are melted to create a bulb. Now, this is pushed back into the tunnel, and this is secured easily. Now, the take-home message is that SFIL offers the most anatomical and physiological solution for a phakia with poor capsular support. Compared to iris claw IOL, it ensures better visual outcome, reduced endothelial loss, and fewer long-term complication. Glued IOL and Yamane techniques are expanded options for the complex eyes, and SFIL it can be summarized as stable vision and reliable fixation. Thank you.
So, as you can see here, it takes more time and definitely it has a long learning curve. And if the chances of disinclination is there, so definitely the chances of tilt is more probably in SFIL, because if it is like not 180 degrees symmetrically, the haptic is not exteriorized properly, or if it is like a little bit of the error, and it will be on the tilting side. So
yeah. That is the point that we were discussing last. You do need that iris claw lens, whereas this is just a routine lens that you can use in any cataract surgery or anything. It might already be in the eye in which you have to fix it to the sclera. So is it not a technique that everybody should know?
Yeah, definitely the technique is to know, and nowadays even we are doing more of SFIL by XNIT technique. So we can go for XNIT for SFIL, but iris claw is for like high volume center, and if like in the same sitting, in the primary sitting, if you want to do, or for all the general ophthalmologist, I think it is a much safer technique with short learning curve.
Yeah, I agree. The surgical time is less, but yeah, the long-term outcomes are definitely better with a scleral fixated IOL.
So you do need that incision actually. If you have
Yeah.
that incision open, you can go on and do an iris claw straight away.
Yeah.
Since I don't have any experience at all on the iris claw, I've been so fearful of using anything that is sitting on the iris or sitting behind the iris that I've never adopted this technique, and I do more of scleral fixation, but I don't somehow, I've tried the Yamane, it hasn't worked in my hands. So the classical glued IOL without the glue, that is what I do. And I find that the length of the haptic that is inside the scleral tunnel actually makes it more stable. When you do the Yamane technique and you make a bulb and you push the rest of the IOL inside, the incidence of tilting and it shaking is probably more than the technique where the haptic is firmly inside the tunnel of the sclera.
Yeah, we recently published about 15
the newer IOL that he was talking about, the CMT Flex,
yeah.
I think that is probably something that is going to change how we do scleral fixation. Probably not many of us are doing it because probably it's not available as freely as the 3-piece intraocular lens. But I think that CMT Flex is going to be the better lens and will provide better stability, and even in the long term will probably stay in the proper anatomical position because of those flanges that come out of the eye. You know, only a bit of it is in the sclera.
So it is quite a relatively straightforward technique also, and quite logical to have flanges coming out and then stabilizing from the outside. We recently published on 15 different techniques of scleral fixated IOL, and it is really very difficult to ascertain which is superior over what.
Yeah, I saw one patient who got iris claw implanted 8-9 years back, and because of iris atrophy, the haptic got detached and the IOL got decentered. So I feel in iris claw, 8-10 years after the IOL insertion, because of the atrophy of the iris, there is risk of decentration of the lens, whereas it is less in chances of SFIL.
Yes, also doing a surgery secondarily when you have a retinal attachment or so in the eyes which were not properly vitrectomized in the first go, removing that iris fixated IOL, I believe, is as compared to an SFIL also very difficult.
Removing a iris fixated IOL is very simple. You just go along with a Sinskey hook, just de-enclave it. It's a 10-second job.
Okay. And sir, what about the pull on the iris while we are removing it sometimes?
So I've been doing both, and even the CMT Flex. Every set of secondary IOL has its own share of complications, even iris fixated. But we have been doing in Marfan syndrome, pediatric cases, doing a PPL and putting a iris fixated lens. It works very well, very well. If the anterior segment is compromised, I'll go for a Yamane or a SFI. But if the anterior segment is good, there is no significant risk of glaucoma, iris chafing, uveitis, iris fixated. I'll not say laser. You can do n amount of surgery in the periphery with the iris fixated. It dilates beautifully.
So we just avoid dilating for 1 month, just for the precaution, and after that we have done RD surgery under this iris fixated IOL also. It dilates very well.
Yeah, I think to make Salaf's job much easier, all the technique are excellent if you master that technique.
Yes.
So okay, believe me, you can try n number of procedures and stick to one, master on that, stick to that.
And the last thing to add is a small tip. You all are retinal surgeons, and you must be having that endo laser in your OT. So we have published technique of making a flange with the endo laser in the continuous mode. It becomes very adequate width flange, which will not go into the sclera or dislodge the IOL. One way is that. The second way is a very cheap way. You can just heat a 24 gauge needle and you can just touch the tip of the haptic and it becomes a beautiful flange.
Thank you so much, sir. Very nice and crisp presentations by both of you. So we'll go forward to the second battle that we have today. It is between Dr. Abhishek Kedia, sir, and Dr. Vidhata Vidhu. Dr. Abhishek sir will be speaking on scleral buckle and Dr. Vidhata on pneumatic retinopexy. So the judge for this session we have is Kumar Vivek, sir.
Good afternoon, everyone. I am a big fan of buckle, and I believe in certainty, not hope. This is a story of a patient, pseudophakic patient, and there was a lattice with hole superiorly, so I thought it's a good case for pneumatic. I did pneumatic, the superior retina settled, and but the SRF moved inferiorly, and वो वहाँ पे डिफ़ॉल्टर किराएदार की तरह बैठ गया. मैं हर हफ्ते पेशेंट को बुला के देखता रहा, कुछ नहीं हुआ, तो फाइनली मुझे बकल करना पड़ा. और यू कैन सी द पेशेंट हैज़ रीगेन्ड 6/9 विजन विथ गुड retina settlement. So scleral buckling is a reliable warhorse. It is proven for all type of retinal detachments. It works for inferior breaks, lattices, PVR. There is no need of gas, no yoga postures, just buckle and relax. Pneumatic retinopexy. It can only be used for simple and superior breaks. My friend will sell. Dr. Muni does it for GRT, inferior breaks, but all of us are not Dr. Muni. So strict head positioning is required. Risk of recurrence is there. अगर पेशेंट ने गलती से छींक भी दिया या खांस भी दिया तो हमें एक एक्सक्यूज मिल जाता है कि हाँ हमारा न्यूमेटिक शायद उसके छींकने से फेल हो गया. The primary success rate is much higher. It can be done for any quadrant breaks. The patient compliance is very much needed in pneumatic retinopexy. The post-op positioning is strictly required in cases of pneumatic. Who is really doing the surgery? In a scleral buckle, it's the surgeon who is the undisputed master. They control everything. It's the symphony of skill, not a prayer. In pneumatic, it's a chaotic team effort. The surgeon, the patient doing various yoga poses like this. Playing dice में even और ऊपर से जो हवाई जहाज जाता है उसकी हवा से भी शायद अगर कुछ हो गया तो चलो pneumatic settle नहीं होगा. Is the buckle dead? Traditionally, single operation anatomic success rate has been used as a measure of surgical success. A recent Cochrane review concluded that pneumatic retinopexy had a lower retachment rate and a higher recurrence rate, but lower burden of postoperative complications compared to scleral buckle. A recent data from insurance of patients in USA showed that 30% cases of managed by primary pneumatic retinopexy compared to 20% cases managed by buccal or vitrectomy required a reoperation within 90 days of the primary repair. Is there a refractive shift after scleral buckling? Yes, there is. But a mild shift is a small price to pay for a reattached retina, like Dr. Salab said in the morning, and it's nothing a new pair of specs cannot fix. Would you rather have a perfectly corrected eye with a detached retina or a slightly myopic eye with a stable reattached vision? The choice is clear. Why do we still buckle in 2025? It handles all the complex cases. It's no fancy gas is needed. It's the surgical skill. Once buccal, it tends to stay buccal, and patient can live life without gravity checks. There are no controversies. This is your moment to defend gas or admit buccal deserves more love. Thank you.
Can I request Dr. Vidhata to please come on this side of the dais, put your points, and then we'll have rebuttal questions from both of you.
So, just because your one case has failed, that doesn't mean pneumatic is bad. Just now, Rupak sir has said, if you master a technique, then that technique is good in your hands. So, let's move to the pneumatic retinopexy. So, the different retinal detachment treatment procedures we all know, PPV, buccal, and pneumatic retinopexy. PPV 94 success rate, 74% success rate, wow. Scleral buccal 80 to 90%, and PNR, oh my God, such a bad procedure. Now, let's see, where is the debate? You said it works for all quadrants. So, any surgery, हर चीज़ के लिए नहीं बनी है. जो सर्जरी जिस चीज़ के लिए बनी है, उसमें करो ना, उसमें सक्सेस रेट देखो. ऐसा थोड़े नीचे ब्रेक है, उसमें न्यूमेटिक करने जाएंगे, फिर तो शीर्षासन देना पड़ेगा उसको. ठीक है। सो PNR बना है ये 4 इंडिकेशन के लिए, एक क्वाड्रेंट में ब्रेक है, एक 1 clock hour के अंदर है, उसमें PNR करो, देन सी द सक्सेस रेट एंड कंपेयर। सो इफ यू हैव अ केस fake kick, clear lens, fresh RD, 2 to 3 DOB and all the brakes are in 1 quadrant, तो इसमें क्या करना है? सिंपल है, इट्स ऑल सिंपल, यू हैव द आंसर। रहीमन देखें बड़े इनको लगू न दीजिए डारी, जहाँ काम आवे सुई काहे कड़े तरवारी। दैट मीन्स जो काम सुई से हो सकता है उसके लिए इतना बड़ा क्यों सर्जरी करना? 4 घंटे 2 घंटे लेंस खींच रहे हो, मसल खींच रहे हो, सब खींच रहे हो, 50 चीज़। हाँ, सो डिबेट ये नहीं है कि बक्कल करना है कि न्यूमैटिक। जहाँ पे बक्कल होगा वहाँ तो होगा ही बक्कल, जहाँ पे न्यूमैटिक हो सकता है वहाँ पे आप न्यूमैटिक करेंगे या बक्कल करेंगे। ये बक्कल का केस है, सिंपल, नीचे ब्रेक है, टेम्पोरल ब्रेक है, लॉन्ग मायोपिक आरडी है। आई डिड बक्कल, पेशेंट डिड वेल, 27 एक्सियल लेंथ, विजन इम्प्रूव टू 624। अदर केस इंफीरियर ब्रेक, बक्कल किया, अच्छा हो गया। सो बक्कल का सर्जिकल स्टेप्स, ओ माई गॉड, 360 डिग्री पेरिटोमी, मसल हुकिंग, ब्रेक लोकलाइजेशन, कमर दर्द, पेशेंट भी रो रहा है, अटेंडेंट असिस्टेंट भी रो रहा है, डॉक्टर तो रोता ही रहता है, 2 घंटा लगता है आराम से। उसके बाद क्लोजर करो, पोस्ट ऑफ पेन है, सर 2 घंटा आप क्या किए पता नहीं। PNR सिंपल, डू AC पैरासेंटेसिस, इंजेक्ट गैस, पोजीशन POD 1 or 2, जस्ट लेजर इट ऑफ, दैट्स इट। लेस पेन, फास्ट रिकवरी, अर्ली रिकवरी। So ये सब, these are the some of my experience. Superior temporal brake, just a gas injection, retina is flat on POD 1, or laser after few days, 1 month POD, retina is completely flat. Second case, another superior brake, PNR done, retina is nice flat. Third case, superior brake, fresh RD, just a gas bubble injection with C3 EPET 0.3 cc, retina is flat. Another case with superior brake, retina is flat with just a gas injection, no buckle, nothing, phakic patient, gas injection, that's it, surgery done in 5 and 10 minutes, done and dusted. So even the study is like you quoted Dr. Muni, he is favoring both the buckle and the buckle and pneumatic retinopexy, because both have, the success rate has increased with time because of the procedure he has suggested, like stream rolling technique and all. The concept of integrity has also taken and changed the paradigm shift, like the visual outcome we achieve with a non-drainage buckle and the pneumatic retinopexy is almost comparable. Retinal displacement definitely lays with these procedure, and this was a comparative study published in IGO who compared the cost of the buckle and the pneumatic retinopexy. What they have found as it is a faster, more economical, less tissue manipulative than a scalar buckling with equivalent efficacy and safety profile. So to summarize, buckle is a quick, easy to perform, easy to learn, cost saving and time saving. So, and it is definitely a good outcome. Thank you.
सब मिठाई दिखाओगे, कुछ नमक भी दिखाओगे, सब सक्सेसफुल केसेस दिखाओगे, कुछ फेलियर भी दिखाओगे।
बक्कल सारा सक्सेसफुल होता है क्या?
अरे
बड़ा इंटरेस्टिंग डिबेट रहा, इन द सेंस कि एक आंख में रेटिनल डिटैचमेंट हो गया तो उसको क्या करते हैं ना, टायर से बांध देते हैं। मतलब ऐसा कौन सा क्राइम कर दिया कि उसको एकदम रिस्ट्रेन कर देना है, उसका हथकड़ी लगा देना है, एक इंजेक्शन लगाने में क्या जाता है।
But again, the question is resurgery rates as compared to buccal and pneumatic retinopexy. I think that is the biggest question that we have at hand. Resurgery rates, the rate of second break formation.
That's right. That's what happened in my patient problem.
But if you see the success rate of resurgery, that comes to 90% with PNR.
Second time buccal, फिर again.
Yeah, you can.
इसी पे कहानी में समझ
Another thing is in eyes that we do inject gas. Whenever it detaches for the second time, the PVR formation generally is very fast.
That's very right. एक पेशेंट था आयुष्मान का, उसको मैंने ऑप्शन दिया कि न्यूमैटिक कराओगे या बक्कल कराओगे, उसको पैसे नहीं देने थे। मैंने बोला न्यूमैटिक का सक्सेस रेट है 80 to 90%, बक्कल का सक्सेस रेट है 90 to 95%। उसने बोला बक्कल कराएंगे।
नहीं सर, बट अगेन स्पेक्ट्रम ऐसा भी होता है, पेशेंट को बोलो 1 घंटा
आप नहीं बताएगी कितना दर्द होगा, मसल खींचेंगे
नहीं। सर वैसे न्यूमोरेटिनोपेक्सी का पैकेज नहीं होता आयुष्मान में, रिइंबर्समेंट आपको बकल के लिए ही लेना पड़ेगा। तो आप लिखोगे बकल और करोगे न्यूमो, ऐसा भी नहीं होना चाहिए, अनएथिकल हो जाएगा सर। थैंक यू सो मच प्रेजेंटर्स।
Comment from Vivek sir, please.
एक्चुअली इट वॉज अ वेरी नाइस डिबेट सुन के मुझे ऐसा लगा ना कि मुझे अपनी विट्रेक्टमी की मशीन बेच देनी चाहिए, या तो बकल से हो जाएगा या न्यूमेटिक से हो जाएगा। Very nice debate, but I think rightly said that for the indications for which pneumatic is better, and buckling, of course, now we think in those RDs which are not amenable for treatment by pneumatic, and buckling for fresh RD, superior brake, in nowadays it won't be the primary procedure of my choice. More comment from sir.
ठीक है, स्टेज पे तो आग लग ही गया है, अब जब आग लग भी गया है उसमें थोड़ा सा घी डाल भी देता हूँ। तो ऐसा है कि विधाता के पास 20 का वीआर सर्जरी का लिस्ट रहता है, तो उसके लिए बकल करना पॉसिबल ही नहीं है, वो न्यूमेटिक रेटिनोपैक्सी करेगा। और अभिषेक के लिए उतना ज़्यादा नहीं रहता है, तो अभिषेक आराम से वो बकल करके पेशेंट को सेटल करता है, बट हीज सेटिस्फैक्शन रेट, पेशेंट सेटिस्फैक्शन रेट इज़ हायर। तो इसका जब फेलियर होगा वो सारे तुम्हारे पास आएगा।
Thank you, sir. Very interesting debate. We are moving forward with the Jugalbandi, and we are coming to the third paper, which is about little troubles. We invite Dr. Ratnesh sir for anti-VEGF plus prompt laser for ROP, Dr. Shivani ma'am for anti-VEGF plus deferred laser in ROP. The expert judge will be Dr. Shishir sir.
Yeah. Good afternoon, everyone. So, yes. So my topic is role of prompt laser after anti-VEGF in ROP. So basically we all know that ROP is a vasopressive disorder affecting retina of prematurely born infants, and it has emerged as a leading cause of childhood blindness all over the world. But ROP related blindness are completely preventable if babies are screened properly and treated on time. So in treatable ROP, laser is gold standard treatment because it ablates peripheral avascular retina and reduces the production of VEGF molecule, and hence the regression of ROP is permanent. But it can cause definitely some loss of peripheral visual field and can induce myopia also. In last 10-15 years, role of anti-VEGF has emerged significantly in treatment of especially posterior ROP, because it works by neutralizing VEGF molecule and causes rapid regression of neovascularization, and it provides a safe window period for normal vascularization of retina. It also has some systemic potential effects, and it can result in late recurrence of ROP. So once the injection is given, what to do next? So we have two options. We can go for prompt laser or we can go for deferred laser. In prompt laser, we do laser after anti-VEGF injection usually within a week, while in deferred laser, after giving the injection, baby is closely monitored, and laser is performed only if there is a progression of ROP despite injection or if there is late recurrence. So what are the benefits of prompt laser after injection? So it consolidates the treatment. Anti-VEGF will neutralize the VEGF already present in the vitreous, while laser will reduce further VEGF secretion by ablating the peripheral retina. So the risk of late recurrence will be reduced. Prompt laser also exposes the child to the less trauma. How? Because the number of follow-up will be less in prompt laser, and we know that every time we examine the baby, we give a painful experience to the child. Also, since we are doing the laser in a smaller baby, so we need to exert less physical force for the eye manipulation to access the peripheral part of retina, and hence it causes less trauma to the child. Also the cost factor. Though the initial cost of the treatment will be high because of the combined nature of treatment, but if you consider the overall number of follow-ups, the overall cost of the treatment comes down. And what are the demerits of deferred laser after anti-VEGF? So obviously it increases the duration of monitoring. So patient will have to come for more number of visits. That will increase the trauma exposure to the child. It will increase the cost of the treatment. it will be more disturbing to the family that every time they are coming and we say that still, I mean, the development is not complete, you have to come after some time, and obviously it indirectly affects the compliance factor also. Also, if there is late recurrence, we need to do laser in a bigger baby. So what happens if baby is like 5-6 months old, we have to do laser under general anesthesia. So we are exposing the child to the risk of anesthesia related complication. Also, if we are doing under topical anesthesia like 3-4 months old child, so it's physically exhaustive for the doctor. So like every day I go to gym after finishing my work. So if I'm doing 4-5 months old child under topical anesthesia, whole of the stretching is done in the hospital itself. So there is no more stretching required in gym. It's not benefit, I'm saying that, so it's basically exhaustive for me if I do laser in such bigger babies. Also, since baby is also exerting more force, so sometimes baby will develop corneal edema and the PRP can be inadequate. So in such cases, you have to call the patient for another follow-up, another session of laser will be required. And during the monitoring, if the child is lost to the follow-up, then it gives you extra headache of medico-legal risk. So to conclude, both prompt and deferred laser will have its pros and cons, and there is no hard and fast rule which approach to select. The final decision should be made based on various factors like distance from which family will be commuting, the socio-economic status of the family, compliance factor, and also the postnatal age of the baby. And what we preferably do can be termed as, this I will tell once the discussion is over from Dr. Shivani.
So the points by Dr. Ratnesh sirs they are all well taken. So I'll just start my presentation. So when we are considering patients with intravitreal anti-VEGF in a patient of ROP, so these are basically aggressive ROP patients. So they already have a lower gestational age, they have a lower PMA, they have a lower birth weight, they have the current weight is also on the lower side, and they have associated lot of comorbidities. So basically the babies are unstable. So why not give them a chance to grow healthy? We have already given them a chance to save the site by injecting anti-VEGF promptly, then why not give them weeks to have more health? So why should we prefer deferred laser? So intravitreal injection have already resulted in prompt resolution of the plus disease. So why not, so they have already reduced the need for ablation of the peripheral avascular retina. So when there is a need for lesser ablation, it has already decreased the treatment time with less stress for the neonate, and also in the longer follow-up, it is going to induce less of myopia. And babies are still, they are regaining their weight and stabilizing the systemic parameters. So what are we afraid of when we are doing a prompt laser? So basically we are afraid of the recurrence and the reactivation, which do occur in these patients. And we are also fearful of the patient running away. They are not, we are always fearful that if we inject and the patient is not going to come back. So these are two major problems where we tend to go for prompt laser. But believe me, they are going to come back. Like 99% of the patients do come back. So for 1%, we cannot change our practice pattern. So the period of recurrence is well known. It is 10-week period in bevacizumab, and in ranibizumab it is as early as 6 weeks. So we should wait definitely, because there would be a smaller area of the peripheral avascular retina to be ablated, which is going to result in a lower number of laser spots, which will in turn need a lesser duration of laser with more functional peripheral retina with induction of less of myopia. So this is from a paper which came out from the Anil Gangve sir. And we can see if we had just gone with prompt laser, we would have lasered a much more bigger area when compared to the deferred laser which was done at 6 weeks in both the eyes. So this was the paper which has compared prompt laser and deferred laser at 6 weeks. And they have said, come out like they required lesser number of laser spots, and they had lesser of myopic refractive error in the group 2, which is the deferred laser. So we do go ahead with laser, but in a healthy, smiling baby which is more cooperative and needs lesser of ablation in these patients. Thank you. Yes, sir. Sir, but they also, they don't tend to decompensate also. Like the smaller the baby, the more chances of decompensation is there. Like they go into apnea much more commonly than the heavier babies. So when we are doing a laser in a 33 or 34 weeker child with a weight of 1500 grams or 1600 grams compared to a baby with 3000 and 3500, basically 3000, 3500 is much more safer than the lighter child.
So basically what I said, that what we do, I'll be telling at the end. So we have to look for the merit of both the techniques. So what I do, I will term it as deferred prompt laser. So since we are giving ranibizumab mostly, so all these baby will be having recurrence at 4 to 6 weeks. If we give Avastin, the recurrence is usually at 3 months or later. So in those baby, if there is a recurrence, it will be difficult to do laser, and then most of the time GA is required. So since we are using ranibizumab, baby is anyway going to get recurrence after 4 to 6 weeks. So what we do, we give injection for the posterior ROP. We wait for 4 to 5 weeks and we do it and finish it off. We don't wait for the exact recurrence to happen.
So basically it's not till reactivation and reoccurrence.
Exactly.
It's 6 to 8 weeks we laser it off.
Yeah.
So basically Ratnesh sir agrees ki deferred laser ही होना चाहिए.
I was not ready to take this topic because I'm not doing the prompt laser. By
Exactly.
compulsion I have to take this topic.
So I did not agree to take prompt laser because sir was on the other side.
So it's not exact. If you define deferred, it's like at reactivation. So I'm not waiting till reactivation. So it's still prompt only.
So pre-reactivation deferred prompt laser.
Exactly.
New term coined for VRSB 2025. Very interesting. Pupil खुलेगा नहीं तो laser
सिंपल
करना
है.
ही
प्राइवेट
पड़ेगा,
प्रैक्टिस
बहुत
में डेफर नहीं किया जा सकता है.
Sorry?
प्राइवेट प्रैक्टिस में डेफर नहीं किया जा सकता है.
Exactly.
हो गया खत्म. ये डेफर कर सकती है 2 महीने बाद. मेरे पास टाइम नहीं है. आओ तीसरा महीने पे आओ.
Shishir sir.
It was a wonderful debate. As Dr. Ratnesh said, that gold standard and definitive treatment for ROP is still PRP. So that is why the logic that laser eventually will have to be done is there. So deferred or prompt, but PRP will be required. But definitely with more and more experience we are gaining with how anti-VEGF is helping delay the neovascularization process, which would require laser or might not require laser, that this also holds promise, and maybe with more experience we'll get to know better. And as you mentioned that patients being offered deferred laser being lost to follow-up, I'll say anecdotes cannot make guidelines. We'll have to make our guidelines based upon what the science is saying, and maybe with more experience with the role of ranibizumab, bevacizumab in these patients, we'll come to a conclusion sometime that when is the ideal time for the laser to be done. A wonderful debate, I'll say.
The opinion must go out from the house that this is a gray area, and so the medical legal cases that arise out of this will have to be dealt on individual merit and not something that says
No,
that
I don't
ये
think
guideline नहीं
I don't
follow
think
हुआ
it
चाहिए.
remains a gray area as of now. Everybody is practicing what needs to be practiced. So MLC remains an important aspect of ROP, be it in treatment or be it in screening, and it is going to remain. So I don't think anything like much of gray area is there till now.
One more point with deferred laser is like sometimes you have given injection, ROP has regressed. It's not reactivating, but vascularization is also not complete.
progressed.
So till what time you have to screen those babies? So I mean it will keep going on. So at one point you have to take a decision to do laser. So I mean that also you have to consider.
He is very correct. You know, the persistent avascular retina that remains and doesn't get vascularized, you have to laser at some point of time or the other. And very correctly, those who are doing laser in heavier babies or lighter babies, they know how it is difficult, how difficult it is to do it in a heavier baby. So I would agree with Ratnesh. Those, but like everybody is not doing ROP, na? Everybody is not doing ROP. When you're doing ROP, you know how easy or difficult it is to do it in a heavier child or a child who's healthier. the child who is smaller in weight and who's not moving around so much, because all of us don't have the backup of an anesthetist or a neonatologist. So we have to work alone most of the time when we do injections or do lasers. So from a practice point of view, I think easier to do it in a as soon as possible.
One more practical point I would like to add, like what happens, suppose if a bigger baby is getting AROP, posterior ROP, and in that baby if we are giving injection, suppose after 1 month, I mean you feel like baby is going to be more healthier and stronger. So in those baby we can do peripheral laser at that time only, and maybe we can leave posterior avascular retina, and suppose if there is recurrence and still some area is not vascularized, those area will be easier to do laser at later age also compared to the peripheral area of laser.
Yes sir, sure sir.
Okay, so the next battle that we have is of macular surgery, different strokes. We have it between Dr. Bholesh and Dr. Shalabh Sinha sir. Kindly take on the dais. The jury member is going to be Dr. Abhishek Anand sir. So we'll start with Dr. Bholesh's presentation.
So, so debate can't be taken up between teacher and student. Shalabh sir, Shalabh sir.
सलाह सर आ ही नहीं रहे हैं, पहले ही हार मार ली क्या? सर, सर आइए सर.
So just I wanted to tell, debate can't be taken up between teacher and student.
सर बोल रहा है कि आपका उम्र बहुत हो गया है.
तो वही तो.
So
पहले ही बुढ़वा बना दिया.
No sir, whatever Shalabh sir says, that is that will be take home message for us, and that will be learning for me also. But since it is scientific session, I am bound to defend conventional ILM peeling in cases of macular hole less than 400 micron. I mean small to medium size macular holes. So it is easy to perform. Even in first year of fellowship, we get chance to touch ILM in small and medium size macular hole only. First we take a feel of ILM peeling. Our consultant used to pinch and give us to complete peel. So it is easier to perform. There is reduced chances of secondary ERM since we are removing ILM all around macular hole till arcade to arcade. And studies have shown there is a better and early ellipsoid zone and external limiting membrane recovery. And they have shown higher macular sensitivity on microperimetry. On the other side, temporal flap is little bit challenging, only little bit challenging, and studies have shown there is a delayed recovery of, or sometimes there is a non-recovery of ellipsoid zone and external limiting membrane also, and there are flap associated complications are also there. Like here you can see flap is, there is flap closure, but hole is not closed. There is a closure of flap is in position, but hole is still not closed. So what we'll do now, here we can see there is a flap contracture. Still there is some ILM is there on nasal side, and there will be some cells which has a proliferative potential in between two ILM sandwich on nasal part of macula, and after time there can be macular drag, foveal drag, because of that flap contracture. And now you can see there is a development of epiretinal proliferation, epiretinal membrane on the nasal side of temporal ILM flap, and there is always a risk of flap loss. So if we lose flap, then we how it is handled, back to conventional ILM peeling.
So let me talk in favor of the temporal only flap. उसका ठीक से PVD इंडक्शन नहीं हुआ और ERM हो गया, तो उसको कह रहा है कि ILM ठीक से निकाले नहीं.
ऐसा नहीं है सर.
तो we are talking about idiopathic macular holes, not the other ones. So conventional ILM peeling done in a tertiary eye care center failed. Another conventional ILM peeling done in a very, very reputed tertiary eye center failed. And she's a doctor. I won't tell you which one. And my own case, small macular hole, I thought conventional karenge, chalo theek ho jayega. Ye to aur badh gaya. So we know about the temporal ILM flap from the study that was published about 10 years now. And we are all doing this temporal only ILM peeling, and it's not technically challenging at all. Just like you do your conventional ILM peeling, you just have to peel only a flap, and not the entire retina, the entire ILM over or all around the macular hole, and it works. So so here we are, a conventional ILM peeling done, and you can see that there's a plug of glial tissue there, and that never happens with a temporal ILM flap. So you can see very good closure, and you're talking about the ellipsoid zone. I think you can see all the zones here. Another inverted ILM flap, another one which is a large temporal ILM flap, and even bigger macular holes. Full thickness macular hole, 1,300 microns. What will you do in them? You have to do a temporal flap, and you can see very well the flap has closed the macular hole. People are using AMT plugs. I don't know how they use the plugs. That doesn't work at all. And if you stuff too much of the ILM inside the hole, you get something like this. So I would always go in favor of inverted ILM flap. There is something known as a dissociated nerve fiber layer, and I happen to just by chance get to see this on the OCT. Now if you see this is a macular hole with a dissociated nerve fiber layer all around the macular hole, and this gives you suboptimal results. So you see these depressions all around the macular hole. ऐसा लगता है जैसे कि पूरा रेटिना ही ऐसे गिर गया है. And when you compare that with the temporal only flap, you are seeing that the dissociated nerve fiber layer is less. So the visual gain, not only in terms of visual acuity, but the quality of vision that the patient gets is always better with the temporal only flap, because otherwise ये retina पूरा गिर जाता है. You can see पूरा retina loose होके गिर जाता है, because the molar cells basically which support the retina, you are tearing off these molar cells. So why get a distorted retina like this when you can have a very good closure as well as less amount of dissociated nerve fiber layer with a temporal only flap. So you can see, compare this with what you have now. Pura ka pura, all around the macular hole, you have a retina that has gone down. And in failure, you said about failure. Agar fail ho jata hai, in the temporal flap, you still have either you, as Dr. Vishal also showed in one of his cases, flap sirf evert ho gaya tha, you have to just put it back in its place. But अगर conventional आपका ILM peeling चला गया, तो आपके पास option क्या है? आपको फिर free ILM चाहिए या retinal graft चाहिए? Thank you.
Regarding dissociation of fibers, sir, if we target to peel temporal ILM and just flap it over macular hole, then we need to, sometime, not always, we need to target a semi-circular peeling. So we need to pinch multiple times. And when we are having a free mindset that whatever we grab we can peel and complete conventional, then there will be less pinching efforts. So that sometime I feel that causes less trauma to nerve fiber layers.
But I have shown you these OCT pictures
Yes, sir.
very clearly
Actually, that is
the conventional, because आपने वो पूरा circular area का molar cells का support हटा दिया है, तो वो पूरा retina ऐसे गिर जाता है, and you have those dissociated nerve fiber layer defects.
So I think the debate was whether conventional ILM flap can achieve closure versus a temporal ILM flap. I think both of them can achieve similar amount of closure for less than 400 micron. Second is whether you see ILM as a redundant tissue or whether you see it as a functional tissue, and you have to see it as a functional tissue. That is my personal view. It is not something to be thrown out. It has some function. It is an extension of the foot plate of the Muller cells. And Muller cells, we know, are the backbone of the retinal functionality. So eventually, some amount of functionality is lost once we destroy the foot plates, because the foot plates of the Muller cells get avulsed while you're doing the compression. Third is regarding the success rate. I think both of them would be similar, conventional as well as temporal. But for the larger holes, obviously your flap technique will have a more higher success rate. But for less than 400 micron, both will have equal success rate.
No, but I showed you, my own
me
case.
Complete. Let the jury complete.
Yes.
but what we are talking about is a failure, then you will have more options to achieve a secondary closure than a person who has done a conventional closure.
Yes, sir.
That is what I
Yes.
think.
I agree.
And what people do nowadays is that they do arcade to arcade type of peeling. So that destroys more of the retina rather than just doing the 2 disc diameter or 1.5 to 2 disc diameter around the macular hole. हाँ ठीक मेरा ही टॉक है इसके बाद.
We'll end this session now. Bholesh, you have to moderate.
मॉडरेटर भी है, स्पीकर भी है, और सही फर्स्ट प्रेजेंटर है.
प्राइज है.
I request Dr. Pooja Sinha ma'am.
कौन जीता कौन हारा? May I call Dr. Shiven Sahay sir to please come and give the mementos, and Dr. Deepak, could you please come up? हाँ, अब थोड़ा आराम करने दीजिए. Dr. Santosh, please come and collect your memento. Dr. Prashant. Prashant कहाँ गए? Prashant has left. Dr. Pratik. नहीं, जूरी को कुछ नहीं मिलेगा. जूरी को तो कॉन्टेस्टेंट्स को ब्राइब करना चाहिए था. कॉन्टेस्टेंट लोग ब्राइब ही नहीं किया. Dr. Divya and Dr. Vivek. Dr. Vivek. Huh?
Bholesh sir, Dr. Abhishek Anand sir, please kindly join. हम भी हैं.
So last scientific session. So I request Abhishek Anand sir, Dr. Vidhata Vidhu, Dr. Vidhata Vidu, please come.
So, फिर तुमको उससे मिलने का मौका मिल जाएगा, हैं? दौड़ के अभी एयरपोर्ट पहुंच जाते तुम तो। मतलब कोई मौका छोड़ना नहीं चाहता।
So, Salab sir is our first speaker of this session, who is going to talk on when to consider ATT in posterior uveitis.
5 minutes. 5 minutes. So I am showing you just 3 patients I have in whom I considered ATT, and unlike the institutions where you have to rely on the physicians and the internists and the pulmonologists to start the ATT, I myself started the ATT. So this was a young lady who had been wandering around with posterior uveitis. You can see the choroiditis patches, chorioretinitis patches involving more of the left eye, and then it started involving the right eye. She had already very less vision in the left eye, but now when this same thing happened in the right eye, she was more worried and she came to me. And I just thought that since she had been on oral steroids for almost about 3 months and she was showing no sign of any response, so to my mind it looked like TB related posterior uveitis, and I gave the AKT for 6 months, AKT 4 for 2 months, followed by AKT 2 for the next 4 months, and this time I didn't have a wide angle, but now I did. So this is the wide angle showing the huge number of scars there, but in the right eye she had 618 vision. Because she came very late to me, the left eye, the vision was optimal. It was only counting fingers. So this gave me a little bit more confidence. Another young male came to me with this type of chorioretinitis. Again, he had come from another city and had been treated with oral steroids for about a month and a half. So again, ATT was started for him, and you can see how well the lesions have regressed, and the ATT actually worked in this patient also. Another young lady with this unilateral, the last one also was unilateral, this again was unilateral, multifocal patchy choroiditis, and again she also was started on AKT, and this is the kind of response that she had post the treatment. So I wanted to bring these 3 cases just to emphasize that many a times our patients will come late who've been treated by some other eye surgeon somewhere else, and when you look at the lesions, it should give you an indication or a clue that maybe this patient has AKT, and all these 3 patients, the Monto's was positive, but the chest X-ray by the radiologist was not positive for TB, and the quantiferon gold TB test also was positive in all 3 patients. So, but what they say is that you can't rely on Monto's, you can't rely on quantiferon gold TB test. So maybe a clinical diagnosis needs to be made for such patients. Thank you. Vishal, 5 minutes. ठीक है?
Very interesting cases, sir. We do get a lot of such multifocal choroiditis and serpiginoid choroiditis patients in our OPDs, and it is often a dilemma whether we have to start the ATT first and steroid later, and sometimes we have the steroid already started and then we think कि अरे steroid पहले से चल रहा है. Monto test भी बड़ा controversial हो जाता है उसमें because it is basically an immune reaction. तो आप जब steroid चला रहे हो, that immune reaction might already be suppressed. तो कुछ भी हो सकता है ऐसे केस में. I believe the COTS calculator is a very good guideline, and IGRA is one of the fields that is there in the COTS calculator. It supports the diagnosis of ocular tuberculosis. It might not coexist with pulmonary tuberculosis, as sir rightly pointed out. So pulmonologist के पीछे depend नहीं करना है कि they will start the ATT. it is our protocol in our institution we write to rule out systemic tuberculosis and to start ATT for ocular tuberculosis. ये चीज़ लिख के अपन भेजते हैं जिसमें भी tubercular etiology अपने को लगता है.
So what I do in my patients is that I start the AKT and I send them to a physician who knows why I have started the AKT, that it's a clinical diagnosis, not something that is supported by any particular test, and he just has to see the patient as a whole and rule out any other foci of tuberculosis that the patient may have, and not just in the lungs. You know, TB can be there anywhere. If the patient is a female patient, then she can have TB in the pelvis also, and that is something that he needs to rule out because he's a physician who has a gynec wife, so I send to that particular place so that both of them can see and rule out any other foci of infection. That is very important to do. I mean, you can't just start AKT and chhod diya patient ko.
So can you summarize your treatment algorithm for suspected cases of ocular tuberculosis? I mean, posterior uveitis.
Yeah, so what as I said, you know, I start the AKT. AKT4 has to be started.
Start when the patient is the first time has presented to you. You will start AKT.
Yes, because all these 3 patients already had been treated with oral steroids.
No. What is your treatment protocol? The patient has first presented to you. How will you go about? That is what.
No. These are all 3 were not treatment naive cases. If the patient had just posterior uveitis, you would start. Generally, you would start on oral steroids only, thinking that it will go away. But you know, if you have attended any of the lectures by Professor Amod Gupta and Vishali, invariably they have proved by various tests and analysis that most of these cases are having some underlying tuberculosis, or the tuberculosis is the reason for this type of
tuberculosis. But they proved a lot based on PCR, and
yes,
in the end they concluded that the few clinical signs are the most paramount importance, and then if the patient is not responding, you should start on ocular.
Yes.
I am an ATT. You are following the same.
That is what I follow.
One thing more which I want to say, ocular tuberculosis is mostly immunological. You are not going to get an acid-fast bacilli or chest X-ray. So it is extrapulmonary most of the time. So rightly, it can be urogenital, there can be bone TB, there can be Cox abdomen. So many things are there. And to our handicap, we don't have, Pountus test, yes, you can get it done. Then TB gold, yes, you can get it done. And in chest X-ray, you don't have any finding. And when you send the patient to physician, they say कि ना हमको ज़रूरत नहीं, लगता नहीं है TB है. अब एक बार कान में घुस गया उसको कि TB नहीं है, physician बोल दिया है, तो बहुत मुश्किल हो जाता है. तो we have 2 things which कभी-कभी patient बोलता है लैब में कराने गए, बोला 2 बार दोनों जांच क्यों TB का लिख दिया. तो I suggest कि at least you advise Mountus test as well as TB gold. If there is strong Mountus positive, suppose 30 mm, and same time TB gold is positive, then and you are seeing the clinical finding that there is the tuberculoma and serpiginous like ye, then you can start by on your own. The one thing more which I have experienced, that up to what duration we have to continue, whether it is 6 months, it would be 6-month course, 9-month course, or 2-year course. So this is something which we have to understand. I have seen that 6 month 2 plus 4, it is not going to work. 9 month it is also not going to work. In some cases I have seen, I have asked this to my teachers also, they told that you have to continue just like the bone TB, you have to go for the 2-year regimen. So if you want to get a permanent cure, so this duration factor is also very important.
So that duration,
extrapulmonary tuberculosis.
There are 2 things, as you said, the duration of the AKT should be ideally 1 year. Up to, because of the newer guidelines, it has to be for 2 years, because multi-resistant जो tuberculosis आ रहा है, उसकी वजह से it has to be for 2 years. The duration, I leave it to the physician to decide how long the AKT is there, but I make sure that the patient takes it for 6 months at least. But the flip side is, Dr. Amitabh from Kolkata was sharing that in AKT, if you start AKT,
paucity of time, we can
yes,
continue the discussion.
Yes. No.
On the T and in the.
What he said was that few ophthalmologists have been sued for starting AKT. So you have to be very careful.
So, Volesh, we expect you to complete it in 5 minutes.
Okay.
That is a performance pressure.
So this was a case of a 60-year-old lady who came to me with diminution of vision in right eye. She had a history of complicated cataract surgery 2 months back and managed with scleral fixation of IOL elsewhere. On examination, we could see there was extrusion of nasal haptic, and perhaps reason was exteriorization of haptic nearly 2.5 to 3 millimeter from limbus, and there was a vitreous hemorrhage underlying, and USG showed attached retina. So I went ahead with surgery. The same IOL was exteriorized at 1.5 mm from limbus, and I did not use cautery in this. So surgery was uneventful. POD second, POD 1 it was normal. On POD third, patient came with pain. Actually, I did not take photograph of POD third. It was a congested, and there was a starting of roof melt of tunnel, Gabber's tunnel. You can see here, after examination, I started steroid and gave Ajoran in this patient. I investigated with UVA workup and found RA factor was positive. I kept on prednisolone 50 milligram once daily and azathioprine 50 milligram thrice, and it was like that on day 10. Then I decided to patch with Tenon conjunctiva complex on day 14. I took graft from superior area. I sutured it because I did not want any kind of further complication in this patient, since already she was operated 3 times elsewhere and I had operated once. The same, I was operated 4 times in 2 months. On day 15 it was like that, and day 26 it was looking very normal. So scleral melt can be seen in cases of autoimmune diseases, and any surgical procedure can be trigger factor in these cases. Early investigation and management can save such eyes, and non-infective scleral melt can be diagnosed early and should be treated with systemic steroid and immunomodulation. Thank you.
Great management, Dr. Volesh. In the end, a very good and satisfying outcome. Vishal sir, what is your take on this case?
Excellently managed case, but if that was the case, the melt would have been from the primary surgery also, and that was also attempted scleral fixated IOL, right? Which was done elsewhere, not in your hospital. and the eye was quiet. It was showing signs of melt after your procedure.
Yes, sir. On first time when I explored and I went just like a normal case in this, just I interiorize haptic and re-exteriorize again from 1.5 millimeter without using cautery, because I expected that previous surgeon must have used cautery there. So again, to avoid further melting, I did not use cautery over there.
No, but it could have mean that the repeated tunnel and insertion of the haptic could have deroofed the that tunnel.
Sir,
and
cautery could have played any role.
But that was used by the previous surgeon also.
How does he do?
I didn't use cautery.
He did not use cautery.
Yeah. I anticipated that previous surgeon must have used cautery, so I should not use in on that area again, because I had past experience of scleral melt in 195-year-old patient 1 year back. So
and how much was the pain in this patient?
Excuse me,
it was just showing congestion, or the patient was complaining
patient
of a lot of
was
pain?
in pain. Actually, patient had sign of scleritis also.
You did the B scan?
Yeah, I did the B scan in this patient, but we could not find subcutaneous fluid. Yeah, pain was there. That is why patient came on 3rd day post-operatively. Usually I call patient after 1 week of POD1.
Any ASOCT to?
No, sir.
Okay. Yes, surgically induced scleral necrosis.
But 3 days is little shorter time. But that may be the previous one has already been triggered the surgery. So how was the gap between the previous and this surgery?
Around 2.5 months, 2.5 months.
That may be one of the reasons. But 3 days is usually unusual for SINS to develop. It takes near about 2 weeks.
But overall, a very well managed and meticulous management of the case.
What about the role of an infection being there? You are saying we are talking about the scleral necrosis, immune mediated.
Infection. He started azathioprine and this. So if there is a pre-existing bacterial infection, we are talking about. Right?
Yes, I mean
or mycobacterial.
There was already
so
the haptic was outside, na?
Both of these will be accentuated if you are doing an immunosuppression. Do you think I'm thinking in that line?
No. He started the prednisolone and the azathioprine after this episode of pain and scleral melt.
Yes, sir, exactly.
So I'm talking about, is it possible that there was subclinical infection there because the haptic was already outside the eye, and that is what caused the scleral melt?
That could be. And for just taking care of that, I had also started systemic antibiotics also.
Thank you.
Patient.
We can
because
continue the discussion.
1 year back, I had a scleral melt in same scenario.
Yeah. Thank you. We can continue the discussion below the podium. Dr. Sabita, over to you.
Thank you, sir. I will talk about something personalizing anti-VEGF therapy with ranibizumab. I am Dr. Sabitav. We already know what is VEGF. VEGF is a subfamily of growth factors which are signaling protein involved in forming and maintaining the circulatory system. VEGF is critical for vasculogenesis and angiogenesis. So, excess of VEGF will cause disease. So, when it comes to anti-VEGF therapy, in 2004 we had pegatinib, and in 2006 we have ranibizumab. In 2011, it came aflibercept. In 2019, brolucizumab was introduced, and now the VRSB have come. So, if we see the current anti-VEGF drugs, so bevacizumab is a humanized monoclonal antibody. Target is VEGF-A, and its clinical dose is 1.25 milligram per 0.05 ml, and it is for cancer patient only in 2004, and it is off-label use, and its intravitreal activity is 4 weeks. Ranibizumab is again 48 to 50 kilodalton. VEGF-A target dose is 0.5 milligram per 0.05 ml. Intravitreal anti-VEGF activity is 4 weeks. And approved indication is wet AMD, macular edema following RVO, DME, RV, and ROP in 2019. It is approved in Europe only. So now the ranibizumab has 0.3 milligram per 0.05 ml for DME and DR. So next, if we see ranibizumab is the only approved anti-VEGF drug for myopic CNVM, Now, aflibercept is a molecular fusion protein. Again, target is VEGF-A, VEGF-B, and placental growth factor 1 and 2. Again, clinical dose is 2 milligram per 0.05 ml. And again, indication is wet AMD, macular edema following RVO, DME, DR, and ROP. Available in India, brolucizumab is again target is VEGF-A. Clinical dose is 6 milligram per 0.05 ml, and approved indication is wet AMD and DME. Faricimab is anti-VEGF, anti-ANG2 receptors, humanized biospecific monoclonal antibody, 6 milligram per 0.05 ml, and it is approved indication is wet AMD, DME, macular edema following RVO. So when we see the ranibizumab development, it is a human VEGF injected in mice. Mouse developed VEGF antibody, and Fab portion of antibody is selected, and selected portion is humanized, and in variable region also manipulation done 140 times, increase in affinity. So mechanism of action of ranibizumab is VEGF binding to VEGF receptors on endothelial cell, and then the activation of vascular endothelial growth factor 1 receptors 1 and 2, endothelial cell activation and increase in vascular permeability and induction of angiogenesis. Ranibizumab binds to active form of VEGF and hence prevents binding of VEGF with its receptors, and hence prevents the endothelial cell proliferation, new vessel blood formation, and leakage. So after the Anchor, PIRE, and Excite Harbor trial, ranibizumab trial was done and it is used in wet AMD. When it's come to myopia CNVM, after the clinical trial of Marina, it is safely used in myopia CNVM. Ranibizumab trial in DME and DR, we have RIDE and RISE trial. And ranibizumab trial in RVO, we have data from CRUISE, Copernicus, and Galileo trials. So more specific, I'll talk about RISE and trial and DME and DR. Both studies, it was seen that both 0.3 and 0.5 milligram per 0.05 ml dose in DME patients were effective. And at both the patients with BCVA improved till 24 months, and they sustained through 36 months with the use of ranibizumab. So this is the graph showing RISE and RIDE trials in which both the 0.3 milligram and both the 0.5 milligram of ranibizumab was used, and it showed good outcome till 24 months, and it sustained the development improvement till 36 months. So ranibizumab 0.3 milligram and 0.5 milligram both effective in improving and maintaining BCVA and central foveal thickness over 36 months. I have recently used in 3-4 patients, and 0.3 milligram is equally effective as 0.5 milligram ranibizumab. So RISE and RIDE trial conclude that statistically and clinically meaningful improvement in DME and DR patients after treatment with ranibizumab 0.3 and 0.5 milligram monthly, and the visual acuity and central foveal thickness improvement were observed as early as 3 months after the start of therapy. 3 patients have injected ranitidine with 0.3 milligram, and still I am following up the patient. Most probably in the next conference I will present the output. I am seeing the significant improvement after 0.3 milligram also, and the clinical output and the edema resolution is equivalent to 0.5 milligram. So both studies proved ranibizumab 0.3 and 0.5 are effective in DR and DME. So efficacy and long-term safety established with ranibizumab compared to other treatment option. Ranibizumab covers the retinal disease involving neovascularization, and ranibizumab is the only approved drug in myopic CNVM. So my request to seniors in Vishal sir and Rupak sir and Abhishek sir, please comment on the use of 0.3 milligram ranibizumab in recent. I've injected in 3-4 patients. I'm still waiting. I've seen 2 patients responded clinically very good.
I have not used personally 0.3 as of now, but again, Vishal, do you have any experience of 0.3? Did you use?
Yes, I'm from the Reliance.
Yes.
Yes, I've been injecting it for the past 2 months now.
Yeah.
But I cannot comment. The data is not that large that I can compare it with 0.5 mg. But it's working on the first floor.
I've injected in 3 patients. So 1 patient has drastically improved with 1 dose, and maybe the cost is also less. So for patients also we
500 or 600 rupees cheaper than the 0.5.
And we can for patients also it's quite benefit.
Compared both 0.3 and 0.5.
Yes.
And with equal effect. So then why was the 0.5 used so much initially, and now the 0.3 has come back. I think one of the reasons where we can use 0.3 is in patients who are having cardiovascular or cerebrovascular risk factors. In those patients, the dose can be reduced, and that is where it comes in to be very useful. Yes,
probably the another factor we need to look into it, whether the tachyphylaxis is less with 0.3 or not.
Okay,
so over a period of time. So that may be one of the reasons we should look for that rather than the efficacy. Efficacy has already been proved. So if you have a same efficacy with less tachyphylaxis, then we can take up this drug as well.
Yes. Thank you.
Yes. Thank you, sir.
So our next speaker is Dr. Manish Mahavir, who is going to talk on craft of pneumatic retinopexy. Over to sir.
Very good afternoon, respected seniors and my dear colleagues. Myself, Dr. Manish Mahavir from Mahavir Institute, Darbhanga, and the topic of my presentation is the craft of pneumatic retinopexy. Pneumatic retinopexy is a less invasive procedure for rheumatogenic secondary attachment repair compared to pars plana vitrectomy or buccal. It involves intravitreal pure expansile gas injection combined with laser or cryopexy, followed by appropriate positioning of the patient. Case selection is very critical for the success of this procedure. There should be a single break in the superior 4 to 8 clock hour, or if there are multiple breaks, they should be located within 1 clock hour. There are higher chances of success in phakic patients compared to pseudophakic or aphakic patients. There should not be significant vitreous traction on the break. Ocular media should be clear enough to identify the break, and patient should be able and willing to maintain appropriate position. Sometimes several family members start visiting the patient and then they are unable to maintain the position, leading to failure of this procedure. It can also be performed if there is retachment following buccal or vitrectomy. Pneumatic retinopexy should be avoided if there are breaks in the inferior retina, PVR grade C or D, or if the media is hazy and breaks are not seen clearly, if the patient is unable to maintain posture or suffering from advanced glaucoma, and in cases of giant retinal tear, if the retina is folded over, and if the patient needs to fly before resolution of the gas. So as we have seen in the first picture, we can discuss these. That in the first picture there are multiple breaks but lying within 1 clock hour, so retinopexy can be successful in this case. In the second picture there is a single break at 12 o'clock, pneumatic is good in this case. In the third picture there are multiple breaks, one in the detached retina and also in the attached retina. Here it is risky for pneumatic because displacement of fluid might lead to opening of the break in the attached retina. Similar, there is high risk in the fourth picture also because there is displacement of fluid when we do pneumatic retinopexy, and it may open the breaks in the attached retina. In the fifth case, we can see that there is a large break extending beyond 4 clock hours. In this case, if we want to give position to the patient, it will be awkward. Patient will not be able to maintain the position and it will likely lead to failure. And in the 6th and 7th pictures, we can see that there are multiple breaks which are extending for a long clock, very wide, and which is definitely not possible to support them with a single large bubble. Pneumatic retinopexy requires great effort on the part of both surgeon and the patient along with his family for a successful outcome. In the post-operative period, there should be detailed systemic and ocular workup. Slit lamp examination should be performed to look for open posterior capsule, and dilated fundus examination with scleral depression should be performed to locate all the breaks, and a fundus drawing should be made. Patient and his family needs to understand the critical importance of correct positioning so that gas bubble may tamponade the break for a successful outcome. Patient should be counseled regarding possible risks and need for surgery in cases of failure of the procedure. They should avoid air travel or going to high altitude till the gas is resolved. Breaks in the attached retina as well as in the other eye should be lasered, and cryo may be done if the patient who are less cooperative or if there is small pupil or capsular phimosis. Here in the surgical technique, the aim is to inject as much gas as possible with minimal fish eggs. After topical anesthesia, eye is cleaned with 5% betadine. Paracentesis is performed using a plunger-less syringe or an MVR entry in the anterior chamber. Aim is to express out about 0.3 ml of aqueous. Intravitreal injection should be given away from large breaks or choroidals at 4 mm, 3.5 mm or 3 mm depending on the patient is phakic, pseudophakic or aphakic. And to avoid fish eggs, it is important to make the area of injection the most superior part. Use 2 ml syringe with 30 gauge needle, go halfway, inject a little and withdraw till you are barely in, and then inject smoothly into the bubble formed. Aim is to inject 0.3 cc more than the AC tap. While withdrawing, hold the plunger down and cover the needle track with cotton bud to avoid any gas reflux. SF6 is preferred as it expands quickly within 36 hours and gets resolved in 12 days. C3F8 expands twice as much, but it takes more than a month, and fish egg leads to inadequate tamponade and risk of bubble going subretinal space through the break. In the post-operative period, patient is discharged on topical antibiotics and steroid drops after checking central retinal artery perfusion. Steam rolling is a technique in which patient is asked to keep face down for 4 to 6 hours, then raise their head 30 degrees or 1/3 every hour. It helps in quicker attachment of the retina by expressing subretinal fluid through the break. We ask the patient to take a picture of his head in the appropriate position for reference at home. or make an arrow on his head pointing towards the brick so that it can be kept pointed towards the ceiling. Patient has to maintain his head posture for 10 days for 23 hours out of 24 hours. Patient is asked to follow up the next day to check if the fluid is reducing. If the retina attached at the break, we have to perform a laser around the break until aura by moving the bubble away. If the retina doesn't attach in 3 days, patient should be taken up for PPV. Here is an animation demonstrating the steam rolling technique. 0.6 cc pure SF6 is injected using a 2 or 3 ml syringe through the pars plana at the most superior part. Patient is asked to keep his face down for 6 hours. Gas bubble starts to expand and patient is asked to tilt his head towards the break 1/3 every hour. It helps in expressing the subretinal fluid out of the break and quicker attachment of retina to RPE. When the expanded gas bubble moves to final position, it covers the break completely. It prevents the fluid from going into subretinal space and residual subretinal fluid is removed by the RPE pump. Once the retina is attached, laser is performed around the break and until aura, the gas resolves in subsequent days. So all of us want cheap and best, so why should anything be different when it comes to treating retinal detachment? Pneumatic retinopexy is cheaper and quicker to perform compared to PPV, and hence it saves time of operation theatre. It is less invasive and preserves human natural vitreous and lens. Studies have shown that retinal displacement, outer retinal abnormalities, and anisoconia is less compared to PPV, which translates to better quality of vision. PVR and redetachment rates are comparable to PPV. Even if pneumatic fails, PPV may be easier to perform, so we don't lose much. Studies have reported 80 to 90% chances of attachment following pneumatic retinopexy in appropriately selected cases. Attachment rate is almost 12% less compared to PPV, so the number needed to treat is 8, which means that we have to operate 8 patients to save 1 patient from an additional procedure. So as vice people have said, perfection is a journey. You can start with simple cases like superior RD with a single break and go on to attach GRTs with pneumatic retinopexy. Thank you for patient listening.
So very
Dr.
nicely.
Manish, so from the morning we have been discussing pneumatic retinopexy, and so there are 2 points I wanted to know from. One is the point where you indicated that how to prevent fish egg formations.
Yes.
And second is that you have said that if in case you feel that the pneumatic retinopexy is failing, so you operate it after 72 hours. But there have been a lot of advocacy that if you feel that this break can be well covered by pneumatic retinopexy, to some surgeons have been advocating of a re-injection of the SF6. So can you point out, and one is the technique, can you re-emphasize the technique in which you prevent the fish egg formation?
So fish egg happens once, there are 2-3 factors. One is that if the eye is already very pressurized, for example, we have not done adequate paracentesis, and if you try to inject more and more gas in an already pressurized eye, then fish egg is more likely.
So we need to do a paracentesis before injecting.
Before injecting,
Okay,
and we need to retap because pressure becomes high if you try to inject more gas. So we have to retap after the procedure. So sometimes people prefer to do MVR entry so that they do not have to go in the hard eye with needle again and again. So they do an MVR entry and just press the lip of the MVR to express out more fluid as and when required. And see, when we put a gas, it tends to come up. So if you try to inject in an inferior part, definitely there will be fish egg. So we have to make the area of injection the most superior part. Even if we want to inject inferiorly, we have to hyperextend the head so that the inferior part becomes the most superior part. And once we inject a little bit so that bubble is formed, then we withdraw a little and inject into that bubble.
So I have tried it few times, but it is easier said than done.
Yes, sir, that's true.
To make first a small bubble and then go back into the bubble to re-inject. So it's not that easy that I have failed it in my hands. So
it will be easier if you make it the most superior part. It will definitely, we don't have to worry about fish egg if you make it superior part, and the eye has to be very hypotonous. If the eye is hypotonous, there will be very less chance of fish egg.
Okay.
We have to, what I have tried, if you do paracentesis, then there is very less chance, less fluid comes out. So it's not adequate. If you do MVR entry, that is much better to, it helps to prevent the fish egg in a better way.
Wonderful.
And second, re-injection, if you think that a break is not adequately covered, I think re-injection should be done on the second day itself. We should not wait for third day to re-inject.
But the patient is just lying down, right?
No, patient has to keep his head down. And once because superior,
while we are injecting the gas, patient
at that time, in the injection OT, he is lying down.
So do you suggest that the patient should recline and then we should inject the gas, or we continue to?
No, we inject during injection. It's not much a big issue. You can do re-injection also because at that time IOP is already normalized. So you can repeat the paracentesis
so
and
Dr.
do
Shishir, can
just
you,
exactly
in the
follow
meantime,
the
can
same
you come on the podium? So Dr. Shishir is with the last last presenter, and who better to end this session? And,
I'm here again.
And all is well that ends well. That is the name. And
So
he is our final one.
Today I'm here again with the last talk of the day. The Mohammad Siraj bana diya gaya hai. Rose 11 number batting. Anyway, so due to paucity of time, I earlier had planned 3 cases, but I'll restrict it to 1 case. I'll be.
This is you.
Yeah. So basically, yesterday I had shown 2 simple medical retina cases. Today, I'll be dealing with. I'll be dealing with primary vitrectomy for rhegmatogenous retinal detachment. The 2 other cases were ERM and macular hole, but a lot of ERM and macular hole has already been discussed today. So the purpose of this case is to show the importance of complete vitrectomy in rhegmatogenous retinal detachment. PVD is most of the times present in RRD cases, but some cases a thin sheet of cortical vitreous can still be attached at the retina, and meticulous removal of this thin sheet of cortical vitreous is very crucial for success of the primary vitrectomy for RRD cases. If we happen to lose the meaty vitreous to induce PVD, or sometimes it's not there and there's just cortical vitreous, then ways other than just using the cutter to induce PVD from the disc has to be used. As in this case, we see that the backflush cannula is being used to gently relieve and make a space for the PVD induction. The intraocular forceps is also being used for atraumatic induction of PVD and removal of this cortical vitreous, because complete removal of vitreous is the primary target in vitrectomy for RD. If this flimsy layer of vitreous remains after surgery, then there are high risk of re-RD under tamponade, and which will be difficult to tackle in the second surgery. So patiently, we have to peel off all the vitreous membranes and induce PVD if it has not initially been done with the help of cutter at the beginning of surgery. So we have to be patient, complete this PVD process. PFCL we often use as the third hand to stabilize posterior pole, and patiently continue with the induction of PVD. The cutter is eventually used when once a sufficient plane has been created with the help of backflush cannula and forceps, and once we see that the vitreous has significantly been PVD has been induced to the periphery, then we can start cutting, and then the rest of the case is quite straightforward. So sound दे सकते हैं इसमें?
You want to use the pointer?
नहीं, ठीक है, रहने दो.
We see two.
रहने दो
Sound.
So the purpose was to demonstrate that main target in RD surgery is complete PVD. The other steps of attaching the retina with fluid air exchange, lasering the brakes, and further tamponade are quite straightforward once the initial part has been done. So I'll just show 2 representational cases of one this RRD with CD, where the surgery has been done for successfully attaching the retina. And I would also like to mention that for such cases where there is pre-existing CD along with RD, I would not want patients to delay the surgery, but if there is time in between the surgery and we have seen the patient, I would like to start the patient on systemic steroid, preferably even an IV steroid, because that helps in settling the CD to some extent so that we can have ease in inserting the trocars. The surgery also becomes easier. Another case of, this is a combined rhegmatogenous tractional detachment in the case of VRBO with secondary macular hole and post-op well-attached retina and closed opposed macular hole we can see. I think there are 2 more cases, but due to paucity of time, I think we'll stop at this. The 2 other cases were ERM and macular hole, which we have already discussed a lot. Thank you so much. Thank you, everyone.
Thank you for the compliment from Dr. Vishal sir for presenting, I mean, completing it well below the time, right?
Vishal sir ka bahut pressure tha.
So now I request Dr. Subhas Prasad sir and Dr. Nagendra Prasad sir to felicitate our speaker. Dr. Mahavir.
We'll just do a 2-minute
Manish
validatory
Mahavir.
function. तुम भी help करो. We'd like to do a 2-minute validatory function. I'd like to request our President to please take the center chair. I'd like to request our Vice President, Dr. Shivendra Sahai, sir. I'd like to request our immediate past President, Dr. Nagendra Prasad, Secretary, Dr. Pooja Sinha, and Treasurer, Dr. Deepak Agarwal, please. We'd like the delegates to please take Shishir, 2 minute बैठ जाना. Vivek, 2 minute बैठ जाओ. Rajesh, 2 मिनट बैठ जाओ. ठीक है, खा लो. अभिषेक, 2 मिनट आगे बैठो तो 2 मिनट वैलिडेटरी फंक्शन. शिवानी, 2 मिनट वैलिडेटरी फंक्शन करना. So we are at the end of this wonderful 6th annual conference, and I would like to take this opportunity to request our President, Dr. Subhash Prasad, sir, to please thank all those who were involved.
It has been really a wonderful 3 days for VRSB. I think that first time in the history of VRSB we have conducted our meetings for 3 days, 2.5 days to be more precise, and all 3 days had been very much, you can say very much successful and well attended, with lots of scientific contents, interactions, discussions, and the highlight of the conference was just the first day interaction with the doyen of ophthalmology of Indian ophthalmology, Dr. T.P. Das and Dr. Rajvardhan Azad sir, with जरा हटके वाला टॉपिक पे collaboration and other things. And the next day we had a very good deferred live surgery. First time we have experienced this in any conference in Bihar. We have been conducting live surgery, but the deferred live surgery, that too in VITREO RETINA. The VITREO RETINA Society of Bihar is really very much proud to be having the first deferred live surgery from 4 centers actually, and it went so very well that it was never looking like that it was not a live surgery, with lot of good interactions and well attended too. And again, the scientific content of yesterday was very much very much for the use of everyone, not only for the vitreoretinal surgeon but for the general ophthalmologist also. It was well spoken by all the speakers. Everyone contributed as per the requirement, and everyone were very much precise to the time. Almost everyone actually they finished on time actually. सब कुछ timely हुआ, सब कुछ ये हुआ, and there was lot of discussion. And in the evening we had our inauguration program. That too we had a lot of things to learn from our teachers like Professor Rajvardhan Azad, inspiring speech as always. Then T.P. Das, Dr. Binde sir, all of them, they actually gave us tips how to not only just to do the clinical practice but how to pass on these things to patients. तो कल का inauguration भी जो मिस किए उनके लिए भी मिस करने वाली बात थी. ये just एक फॉर्मल एक दिया बत्ती वाली बात नहीं थी. कल उन लोगों ने भी बहुत अच्छा बताया कि कैसे कैसे क्या हुआ. तो जब भी डॉक्टर राजवर्धन आज़ाद सर होते हैं डाइस पे तो कुछ ना कुछ हम लोगों को सीखने का मिलता है. और मुझे तो लगता है कि कोई भी ऐसा कॉन्फ्रेंस नहीं है जिसमें कि बार बार वो पंप करते हैं, बार बार एनर्जी डालते हैं, बार बार कुछ हम लोग इतना मोटिवेट करते हैं कि लगता है नहीं सही में हम लोग को हो जाना है मोटिवेट. और उसी का अंजाम है कि जितने सारे यंग ऑप्थेल्मोलॉजिस्ट अभी जो विट्रो रेटिनल स्पेशलिस्ट हैं बिहार के, सब लोग हैं सो इतना कोहेसिव होके इतना बढ़िया से सब लोग एक साथ मिल के एकदम एज यूनिट एज फैमिली मेम्बर सब लोग एकत्र हुए. और इस बार का थोड़ा डिफरेंट ये था कि टोटली साइंटिफिक था, कहीं घूमने फिरने वाला नहीं था जैसे कि पिछले बार होता था. तो उस मामले में भी एक यूनिक कॉन्फ्रेंस था जिसमें कि केवल साइंटिफिक बातें ही हुई और हम लोग 3 दिन तक इसी में चिपके हुए रहे और लास्ट तक भी बैठे हुए. अभी भी ग्लूड, अभी भी इतनी बड़ी अटेंडेंस है तो हमको लगता है हैट्स ऑफ टू ऑल ऑफ यू एंड आई एम रियली सो प्राउड टू बी प्रेसिडेंट ऑफ दिस VRSB. और ये जो बाहर के जो स्पीकर्स आए, जो भी लोग आए, जैसे डॉक्टर तारा प्रसाद दास, इतना बिजी रहने वाले, वो आए 3 दिन दिए और ही वॉज सो मच इम्प्रेस्ड। ये अलग बात है कि थोड़ी भीड़ कम, उन लोगों को इतना बिहार दूसरे जगह जाते हैं भीड़ बहुत ज़्यादा मिलती है, हम लोग में भीड़ कम है, लेकिन इतना जो जितने लोग हैं उसमें हम समझते हैं कि 75% जो विट्रोरेटिनल कोर विट्रोरेटिनल पर्सन हैं वो तो आए ही आए, बाकी जनरल ऑप्थेल्मोलॉजिस्ट भी आए, जो नहीं आए वो उनका लॉस है, जो यहाँ रहते हुए भी नहीं आए उनके लिए तो हमको लगता है कि वी कैन फील सॉरी अबाउट दैट कि भाई यहाँ रहते हुए जब आपके शहर में हो रहा है, साल में एक बार हो रहा है, और सर ने इतना मेहनत करके इतना बड़ा विजन लेके डॉक्टर आज़ाद ने एक सोसाइटी क्रिएट किया है, और ये इंडिया का पहला स्टेट सोसाइटी जो कि रजिस्टर्ड है, और इसके लिए भी प्राउड फील करना चाहिए। तो इसको कैसे हम लोग आगे ले जाएं उसके बारे में सोचना चाहिए, पर्सनल गेन के लिए लोगों को नहीं सोचना चाहिए। और सर बार बार बोलते हैं कि कोलैबोरेट कोलैबोरेट कोलैबोरेट, ताकि हम लोग और कुछ आगे कर सकें, हम लोग नाम आगे हम लोग जा सके दूसरे तरह से साइंटिफिक एक्टिविटीज़ के रूप में। ऐसे तो प्रेजेंटेशन सब लोग करते हैं, सब लोग अच्छा काम कर ही रहे हैं, लेकिन बाहर नहीं जा रहा है, रिफ्लेक्ट होना चाहिए। तो सर का बार बार मैसेज रहता है ही करें। और चूंकि ये पटना में हो रहा था, लास्ट 3 ईयर्स डॉक्टर आज़ाद हम लोग के साथ नहीं रहे, तो हम लोग वो पार्ट को मिस कर रहे थे। इस बार वो रहे, हमेशा रहे, ये बहुत बड़ी बात रही है। 3 दिन रहे, परसों कल आज, तो ये बहुत बड़ी बात है कि वो रहे हम लोग के साथ, हम लोग को इतना एकदम इन्फ्यूज किए सारा अपना विजन एनर्जी सारा कुछ, तो वो बहुत बड़ी बात है। और खास करके बाहर वाले लोग आज डॉक्टर पद्मजा जो कि वो भी 3 दिन एक तरह से कल सुबह से बैठी रही, इतने लोग आए जो कि इतना डिफ़िकल्ट सिचुएशंस में रेन होते हुए दूसरे जगह अटेंड करते हुए आए, तो सबको मैं तो बहुत धन्यवाद देना चाहता हूँ। और मैं तो यही कहूँगा कि मुझे बहुत प्राउड फील हो रहा है कि प्रेसिडेंट होके कि इतना छोटा सोसाइटी लेकिन इतनी कोहेसिव सोसाइटी है और इतना कंट्रीब्यूटरी सोसाइटी है, तो थैंक यू वेरी मच फॉर मेकिंग मी सो हैप्पी। ठीक है, और मुझे लगता है कि एज एग्जीक्यूटिव मेंबर जो लोग हैं, सब लोगों की जिम्मेवारी बनती है कि भाई सब लोग मिलजुल के थोड़ा सा इसको आगे बढ़ाएं। हम तो खैर देखते हैं कि कुछ लोग हैं जो कि वैसा कंट्रीब्यूट नहीं कर रहे हैं, लेकिन जो नहीं कंट्रीब्यूट किए उनको भी बहुत बहुत धन्यवाद, जो कंट्रीब्यूट किए उनको बहुत धन्यवाद। जो हम लोग जैसे एक दूसरे को हेल्प कर सकते हैं करें, थोड़ा सा हम लोग को हर चीज़ से ऊपर उठ के करना चाहिए। और हमको तो लगता है कि अब बहुत हो गया, हम लोग को थोड़ा सा रियली में कुछ स्टडीज़ में कोलैबोरेट करना चाहिए। डॉक्टर सोनी भी बार बार बोल रही है कि हम लोग आप मटेरियल दीजिए, हम लोग लिख के भेजेंगे। तो हमको लगता है कि अभिषेक जी जो सर बार बार आपको टारगेट करते हैं, अगला साल उनको बोलने का मौका नहीं देना हम लोग को।
In this 2.5 day conference, we have achieved a great milestone. First day, the talk of Dr. T.P. Das so far and Dr. Azad sir in how to collaborate the different center for the study, and they are talking very much in the favor of us, and we must do as per the guidelines laid down. And we have to formulate the guidelines, and we have to do it accordingly, because Dr. Azad sir हमेशा इन्फ्यूज करते हैं एनर्जी। डॉक्टर सुभाष ने बोला कि हम लोग को काफ़ी इंस्पायर करते हैं कि we must do some study, and not very big things, small छोटा चीज़ पे भी हम लोग we can collect the data like diabetic retinopathy status क्या है बिहार का, वो भी नहीं पता है हम लोगों को। तो उस सब चीज़ों के लिए तो ये तो पहला दिन बहुत अच्छा रहा। I am amazed by the excellent talk by all the vitreoretinal people of the Bihar, and the speakers from outside. They are already speaking, but our people have spoke very well in all the presentations. All the presentation were very good, excellent, at par level of the hats off to, and many congrats to all the speakers from the Bihar Vitreoretinal Society of Bihar, and all these. I think this society is in a great hand of Dr. Subhas and Dr. Pooja, and above all, and backbone of this society, Dr. Satyajit. And it is always a pleasure to take services from him, and it is not possible to do any conference without Satyajit in the Bihar. And so he will remain with us with all the time. And our Vice President is Sivendra is my junior to all, and he is in very think सोचता रहता है कि क्या करना है नहीं करना है, and he spoke little but he spoke very effectively. ट्रेजरर को भी धन्यवाद, बहुत पैसा जमा कर लिए हम लोग, बहुत हो सकता है कि काफ़ी अगला साल कॉन्फ्रेंस के लिए काफ़ी पैसा जमा हो जाएगा। सो तहे दिल से सभी का धन्यवाद, सभी स्पॉन्सर का धन्यवाद और सभी एग्जीक्यूटिव का धन्यवाद। एंड बस यही बोलना है, बोल दिए, अब क्या जाए बाकी सबका। और जो ऑडियो विजुअल है फ्लॉलेसली चला, इनका भी बोल देना है काम।
मैं भूल गया सही में, मैं अपने टीम को धन्यवाद देने के लिए, क्योंकि ये इतना कोहेसिवनेस आने का कारण है कि सब लोग जो मिल के किए, तो इसमें क्रेडिट सबको जाता है। तो स्पेशली जो सेक्रेटरी पूजा सिन्हा जो कि एकदम लगी रही हमेशा, एंड द सेक्रेटरी के पीछे द पर्सन बिहाइंड CLC, वो थैंक यू सो मच, क्योंकि हमेशा जो भी हम लोग को CSC हाँ उनको फेलिसिटेट भी करना है अभी। और डॉक्टर शिवेंद्र सहाय हमारे जो इनकमिंग प्रेसिडेंट है, वाइस प्रेसिडेंट, और दीपक अग्रवाल, तो जब भी ही इज़ वेरी मेटिकुलस पर्सन। एक तो ये बोलेंगे कि एक एक पैसा का हिसाब और कैसे करना है सर, काहे इतना रजिस्ट्रेशन कम कर रहे हैं हम लोग, कैसे पैसा आएगा, इतना कंसर्न है कि पैसा। लेकिन एक चीज़ तो हम सब लोगों को बताना चाहते हैं, जो लोग शायद अंदर की बात नहीं जान रहे हैं, कि हम लोग तो एग्जीक्यूटिव तो जान ही रहेगी कैसे हम लोग इस बार पैसा कलेक्ट किए हैं। सो मतलब कि एक्चुअली दे आर पार्ट ऑफ आवर टीम। उन लोग हम लोग हैं, वो लोग प्रोडक्ट नहीं बनाएंगे तो हम लोग यूज कैसे करेंगे। तो हम लोग तो उस पर भी उन पर डिपेंडेंट है, वो लोग भी हम लोग के ऊपर डिपेंडेंट। तो ये कि सिम्बियोटिक रिलेशनशिप होना चाहिए, जो कि हुआ। तो ये दोज पीपल हैव एक्चुअली कम फॉरवर्ड, हम लोग को सपोर्ट किए। कुछ लोग हैं तो उनको भी थैंक यू बोलना चाहते हैं, भाई आप लोग सपोर्ट किए तो हम लोग थोड़ा आगे बढ़ रहे हैं। तो हम लोग का भी जो कंट्रीब्यूशन जो रहेगा आपके प्रति रहेगा। स्पीकर्स की जहाँ तक बात रही, एक ऐसा ही कॉन्फ्रेंस VRSB का हुआ जिसमें जो भी बोल रहा था, लग रहा है इस सब्जेक्ट का नॉलेज इसको बहुत अच्छा है। माने कि इतना ये दूसरे मीटिंग्स में होता है, कोई पढ़ लिया कहीं से आके बोल दिया, यहाँ पे जो एकदम इन डेप्थ जिसको नॉलेज है वही पढ़ रहा था, ये कर रहा था। ये बहुत ही हाई स्टैंडर्ड, बहुत
साइंटिफिक कॉन्टेक्ट का सब कोई तारीफ कर रहा है,
बहुत ही हाई स्टैंडर्ड वाला।
मैं रिक्वेस्ट डॉक्टर शिवेंद्र सहाय सर, आवर वाइस प्रेसिडेंट, प्लीज।
First of all, I like to congratulate the VRSB for holding such a marvelous scientific feast for 2.5 days, and there is hard work behind this by Dr. Subhash Prasad, Secretary Dr. Pooja, Treasurer Deepak Karwal, and ये जरूर पास्ट है, लेकिन हम लोग के लिए अभी भी प्रेजेंट के समान ही काम करते रहे। एंड लास्ट बट नॉट द लीस्ट और CLC सत्यजीत सिन्हा, इनके बगैर तो कुछ हो ही नहीं सकता है। रहे हैं हम लोग, आगे भी दूसरा कोई सेक्रेटरी बने, लेकिन इनको हम लोग पकड़ के ही रखेंगे, छोड़ने वाले नहीं हैं। एंड आई वुड लाइक टू थैंक टू ऑल आवर द ट्रेड पार्टनर्स, एंड वी ऑल वर्क लाइक अ टीम, एंड there was a dedicated diligence, and that has brought this result. It is because of the cohesive effort. And one thing which rightly Dr. Nagendra sir has told, that we even don't know that what is the percentage of diabetic patients in Bihar population, and what is the percentage of patients of diabetic retinopathy among the diabetics of Bihar. So at least we can do something, and we can make a executive body type of inner core group, and we can at least we can sort out कि आज अगर हमारे यहाँ 100 पेशेंट आए हैं या 100 पेशेंट का कलेक्शन जब हुआ, तो एक रजिस्टर में ये तो लिखा ही जा सकता है कि उसमें कितने डायबिटिक थे, और फिर वो डायबिटिक पेशेंट्स में कितने डायबिटिक रेटिनोपैथी थे। तो इतना हो सकता है आपके पास 100 पेशेंट आए, उसमें से 10-15 आपको डायबिटिक पेशेंट निकल गया। अब उसमें आप जो इंडायरेक्ट कर रहे हैं 90D कर रहे हैं, तो यू कैन नो कि उसमें से कितने डायबिटिक रेटिनोपैथी। ठीक है, बहुत लोग कोऑपरेट करेगा OCT के लिए, पैसा देगा, एंजियोग्राफी कराएगा, लेकिन बहुत इतना तो क्लिनिकली आप कर सकते हैं। यू मे नॉट क्लासीफाई, बट यू कैन एटलीस्ट वर्क आउट कि दैट द पेशेंट इज हैविंग डायबिटिक रेटिनोपैथी। और we look forward for the Nepal conference, and I think it will be a greater success. And once again, thanks to all the office bearers, our President Sahab, immediate past President, and Secretary, Treasurer, and the CLC, and all the executive members and the general members of the VRSB. Thank you very much.
May I request our secretary, Dr. Pooja Sinha, to please say a word.
एक कहावत है टुगेदर वी कैन, और मुझे लगता है कि जहाँ तक मेरा सवाल है, ये मैं बहुत फील करती हूँ कि हमारा सचमुच सोसाइटी बहुत कोहेसिव है, बहुत लाइक माइंडेड है, सबकी रिस्पेक्ट करते हैं हम लोग, और मैं चाहती हूँ कि हमेशा रहे, जो हमारे जूनियर्स हैं वो भी ये लेगेसी आगे कैरी फॉरवर्ड करें. हमारे प्रेसिडेंट डॉक्टर सुभाष प्रसाद, ही इज़ ऑलवेज इनकरेजिंग, ऑलवेज offering his opinion, his support whenever we need. हमारे पास्ट प्रेसिडेंट डॉक्टर नागेंद्र प्रसाद, उनको एक पर्सनल सेटबैक था फैमिली में, मगर हर तीनों दिन वो हमारे साथ थे. वी आर वेरी ग्रेटफुल फॉर दैट. डॉक्टर शिवेंद्र सहाय, हमारे वाइस प्रेसिडेंट, मुझे बोले थे कि सैटरडे को मैं रहूँगा, संडे को मैं नहीं रह पाऊँगा, मुझे जाना है एडमिशन के लिए बेटे के लिए. बट ही वॉज विद अस टुडे. ही सेड नहीं, मैं कैसे नहीं आता. और डॉक्टर दीपक, ही इज़ ऑलवेज सो सपोर्टिव. हर बार कोई भी डेटा चाहिए, कोई भी फिगर चाहिए, उनके पास पूरा हमेशा पोथी रहता है, एकदम तुरंत भेजते हैं रजिस्टर्ड डेलीगेट्स कितने हुए, कितना कौन फंड दिया. सो आई एम लाइक वेरी ग्रेटफुल एंड वेरी थैंकफुल कि इस तरह का टीम है. और लास्ट बट नॉट लीस्ट, मैं कल बोलना ही भूल गई, मेरे हस्बैंड डॉक्टर सत्यजीत, ही इज़ द रीज़न वाई आई स्टैंड हियर टुडे. मतलब इतना ज़्यादा मेहनत किए हैं इस कॉन्फ्रेंस के लिए, और हमेशा करते हैं. बस मुझे बोलते हैं कि तुम अब बस साइंटिफिक प्रोग्राम बना दो, बाकी मैं सब देख लूँगा. तो इसीलिए मतलब कैसे कैसे कॉन्फ्रेंस हो जाता है. आई एम रियली अमेज्ड. ये साइंटिफिक प्रोग्राम और मधुबनी का जो सोवेनियर सब था, आई टुक इट अंडर माई कंट्रोल. बाकी सारा चीज़ सत्यजीत देखे हैं. अरशद, हमारे हॉस्पिटल स्टाफ, मतलब ही इज़ सो ऑलवेज सो हम्बल, ऑलवेज सो हार्ड वर्किंग, एकदम दिन रात मेहनत करते हैं. और बाकी एग्जीक्यूटिव्स, मतलब एक एग्जीक्यूटिव ने इस बार एकदम दिल से कॉन्फ्रेंस में को आगे बढ़ाया है. हर एक एग्जीक्यूटिव ने मेडिकल फार्मा कंपनीज को फ़ोन किया है, कोई भी हो. मतलब आई फेल्ट दिस टाइम फ्रॉम माई हार्ट दैट एवरीवन हैज़ वर्कड हार्ड फॉर दिस कॉन्फ्रेंस. सो आई एम रियली वेरी ग्रेटफुल. और हमारे जो फार्मा कंपनीज हैं, कुंदन जी यहाँ खड़े हैं. कुंदन जी हैज़ बीन ऑलवेज सपोर्टिव. जब बेयर में थे तब भी मैक्सिमम फंड हमारी कॉन्फ्रेंस को दिए थे, और अब रॉश में भी मैं सबसे मैक्सिमम फंड कुंदन जी अरेंज किए हैं. तो आई एम वेरी ग्रेटफुल. मौर्या का स्टाफ, मल्टीमीडिया, सब लोग ने एकदम बहुत अच्छा, इट वाज अ वेरी गुड सक्सेस. हमारे गेस्ट फैकल्टी जो आए, डॉक्टर संगीत मित्तल, ही ऑपरेटेड फ्रॉम जलंधर, रिकॉर्डेड, सेंट द वीडियो. आप देख ही रहे हैं, 3 नेशनल फैकल्टी तो सुबह आए और देर दोपहर में चले गए. तो it is a very quality conference that we had with very meaningful scientific deliberations. Hardcore retina जो attend किए, I think they are blessed. जो नहीं attend किए, it's their bad luck, as our president sir said. And we should all work towards a more cohesive and a friendly society where the society is above all.
May I request our treasurer, Dr. Deepak Agarwal.
Everyone has said so many things, so I would just say that this conference was a very big success, because some of the delegates actually, they personally told me that they enjoyed every bit of it, and for that I am very thankful to our president Subhash, who has been, meticulously he has been behind us, and he has been monitoring each and every aspect of the conference. Again, I would like to thank Naginder sir, Shivendra sir, our vice president, and Pooja ma'am has taken actually lot of efforts in small things which we think is not important, like in choosing the delegate, in customizing the bags, in choosing the food menu. So the food which we had for all the 3 days were actually excellent. The menu was very good, and everyone appreciated the food which we had. And the scientific sessions which were carved out was also very exhaustive, and it was, it was up to a national level conference. So with that, I would like also to thank our Dr. Satyajit sir. Like, he's the energy and he's the propelling fuel, I can say, for all of us throughout these years, and we will want him, and we wish that he would always be there with anyone who is going to be the office bearer. And I would like to thank all the delegates, my friends, my colleagues here. Without you all, it would not have been a success. So thank you so much. The audio-visual team led by Hariji, they were very, cooperative in getting the deferred life surgery done. And actually, they were very kind enough to come to my center, which was not actually planned before. And at the last moment, they did come, and they recorded the video. And as you can see, there were no glitches in the audio-visual section, and it was a very seamless conference without any hassle from the beginning to the end. So a big congratulations to everyone for that. Thank you so much. Thank you.
As is customary, I would request
before they
somebody from the delegate also has to praise.
अभी
तो office bearers अपना तारीफ कर लिए. Delegate को भी तारीफ.
एक second. Before they express their view, I will just ask Dr. Satyajit to come over here. We just want to give a token of respect, not the but respect to you. ठीक है, ऑडियो विजुअल तो सही में बहुत कमाल कर रहा है, बहुत जरा सा भी कहीं.
I think it was a superb conference, and let's leave it at that. Thank you. और किसी को बोलना है तो बोल लो भाई. I think I do not need to elaborate. इससे ज़्यादा elaborate करने का ज़रूरत नहीं.
उसके बाद हम लोग घर में बोल.